Good morning. Welcome to HeartFusion Day 3. It is our pleasure to see people this morning, and as usual in the morning session, we understand that's usually it's for early riser, for hard-working people. Yesterday, we had a very productive day going over heart failure, arrhythmias, and device therapy, and we ended the day with a very interesting session about data collection and how to generate data with the help of AI, in addition to AI application with cardiology. I encourage everybody throughout the day to reach out to your colleagues within KFUPM who really have very great ideas to integrate lots of innovation within biotechnology and AI to cardiology and multiple specialty. I'm going to introduce Dr. Juri Al-Mubarak. She's a first-year internal medicine who really doing an amazing job as a master of our ceremony to break the first session.
Thank you, Dr. Faisal. Good morning, everyone. We're going to first start with the first session of the day. Today we have 3 sessions, all interesting topics. The first session is about the coronary artery disease. It'll be moderated by Dr. Khalid Al-Fredi. Dr. Khalid is the CEO of King Fahd Military Medical Complex. He is also the director of the King Fahd Military Medical Complex Cardiac Center and a consultant interventional cardiologist. Please come to the stage, Dr. Khalid. Joining him are our panelists, Dr. Abdullah Shahri, the chairman of the Department of Cardiology in Al-Habib Medical Group. He is also an interventional cardiologist. Unfortunately, Dr. Fawaz Limplari will not be able to join us, so replacing him will be Dr. Falih Al-Diabi. Also, Dr. Ali Abu Saud, who is an interventional cardiologist and adult congenital heart disease specialist at Imam Abdul Rahman University. And Dr. Emmanuel Ako, a cardiology consultant at Johns Hopkins Aramco Healthcare.
Assalamu alaikum. Sabah al-khair jami'an. Good morning, everyone. First, I would like to thank KFUPM and JHAH for making this HeartFusion live for 2025. Before I start our session, if I might say, maybe the most important session in this whole conference, it's about coronary artery disease. As we know that worldwide mortality is due to cardiovascular disease, around 20 million deaths in 2022, according to WHO, is from cardiovascular disease, which account for 1/3 of overall mortality around the world. And 85% of the cardiovascular mortality is due to coronary artery disease. So today we have great speaker and great panelists. So we're going to discuss about coronary artery disease. Without further, we're going to start with our talk. Our first speaker is Dr. Hani Abdel Hadi. He's the chairman of the Cardiac Center and Muassat Group, and his talk about acute coronary syndrome management. He's going to give us 15 minutes. So we'll take our host will take 4 talks, then we'll have a Q&A. I encourage everyone, if you have questions, just scan the code. I think there's a code, scan it, and we'll address your question to our panelists and our speaker. Dr. Had.
Thank you, good morning. And big thanks to those who have woken up early on a Saturday morning, and another big thanks to the organizers for the kind invitation. So my focus today will be on acute coronary syndromes with a heavy thrombus burden. Does this work? Do I just press this or no? I don't think it works. Oh, now it works. Right, so here we have 3 patients, 3 inferior STEMIs, 3 occluded right coronary arteries. Can I just have a clicker that works, please? Okay. No. Oh. Okay, so 3 inferior STEMIs, 3 separate patients with 3 STEMIs, 3 occluded right coronary arteries. And the question you ask yourself is, do we treat them all the same? Are they all equal? Now, the definition of a heavy thrombus burden is when you have an acute coronary syndrome with a TIMI grade at least 4 to 5 level of thrombus. Now, a TIMI 4 is when the maximum thrombus diameter or dimension is more than double your vessel diameter. 5 is when it's occluded. And this is quite important because these patients have an increased risk of distal thrombus embolization. You can lose branches, you have microvascular obstruction, you have worse left ventricular function and an increased overall mortality. So this is quite important to recognize, and it's also quite important to try and treat. Now, we're aware that you can start with a 4 or a 5, but sometimes you have a 5, you cross with a wire or a small balloon, and you have TIMI 3 flow with no residual thrombus. So you can always downgrade. So for the purpose of today's talk, we're focusing mostly on a TIMI 4 to 5 after wiring and after using a small balloon or just wiring alone. And those are those patients who still have a large lump of thrombus despite crossing the lesion. This will account for 30 to 40% of STEMI cases on current estimates. Now, your options are to proceed with standard PCI. That's what we'll do maybe most of the time or some of the time. You can consider thrombus aspiration. We consider using a GPI, and we can consider deferred stenting. But where's the data? Where's the evidence? What are the current guidelines? Well, thrombus aspiration has had a fairly bad press recently. We are all aware that it's a class 3 indication, but that's only if you use it every single time. So using thrombus aspiration for every single STEMI is no longer advised and is actually actively discouraged. But if we go back in time and we look at the trials, if we look at the TAPIS trial back in 2008, this was a single central trial with 1,000+ patients that were randomized to PCI, standard PCI or thrombus aspiration. Back then, they used bare metal stents. Back then, they used clopidogrel, 300 milligram loading doses, and they used a very large amount of GPI. So apixaban was used in more than 90% of cases. And in this study, using thrombus aspiration improved procedural outcomes. So you have better myocardial blush, better ST segment resolution, and a lower incidence of Q waves. And you have better 1-year outcomes. So cardiac death was nearly half, and rate of myocardial infarction was nearly half. So based on this, the 2012 ESC guidelines gave a class 2A recommendation for the use of thrombus aspiration in acute STEMI. You fast forward to the TASTE trial where they used 7,000+ patients, multi-center trial, again randomization, this time with a lower use of GPIs, nearly about 15 to 17%, and in keeping with contemporary practice, a greater use of drug-eluting stents. In this study found no real difference in outcomes at 30 days or 1 year, so similar mortality and similar major events. A small sub-study compared different catheters, whether it's the Pronto, Export, or Eliminate, you had a fairly similar result. And based on this trial, the subsequent guidelines downgraded it to a level 2B in acute STEMI. You then move on to the total trial, which is probably the largest and best organized trial in this form, where they randomized over 10,000 patients to thrombus aspiration versus standard PCI. Now, this study had a very good design. They used the same catheter throughout. You would cross over the wire and then aspirate. And if you're unable to aspirate, you use a small balloon and you go back and you aspirate again. You ensure that you apply suction before arriving to the lesion, and you engage the guide fully to prevent proximal embolization, and then you aspirate the guide after you're done. So what we would normally do in our standard practice in good centers. It was interesting that there was a 7% crossover from the PCI only to the use of thrombus aspiration. More drug-eluting stents, again in keeping with practice at the time. Mostly clopidogrel initially, but as the data for ticagrelor and prasugrel became available, they started using more potent antiplatelets. There was some heterogeneity, so the symptom time was longer in the aspiration group and the GPI use was lower in the aspiration group. In terms of procedural outcomes, using aspiration had better ST segment resolution, lower rates of distal embolization, but similar rates of TIMI 3 flow and similar rates of no reflow. And in this study, there was no difference in the primary or secondary outcome between the two groups, but there was a slightly increased risk of stroke at 1% compared to 0.5% in the non-aspiration group. Although if you use a landmark analysis after 3 months, after 6 months, there was no real difference in the long term. And based on this, the subsequent guidelines downgraded the routine use of thrombus aspiration to a class 3. This is where we are right now. So we wouldn't say you're never allowed to use thrombus aspiration. The guidelines do recommend that if there's still a large residual thrombus, despite crossing the lesion with a wire or a small balloon, that you are still allowed to use it as a bailout. Well, what about better catheters? What about more modern catheters? Before we used to have these manual aspiration catheters. These days available to us, we have this sustained mechanical aspiration thrombectomy. So there was a small trial, which is a single-arm post-market registry that looked at 400 patients that presented with STEMI. GPI use was nearly 30% in keeping with current practice. And in terms of procedural outcomes, it seemed to have superior procedural outcomes to what was reported in the larger previous trials. So a lower distal embolization rate, better TIMI 3 flow rate, and a better myocardial blush grade 3 compared to the previous trials. In terms of 30-day outcomes, the overall MACE rate was nearly 50% of what was reported in other trials. And there were 3 strokes, although 2 of them can be explained for other reasons, non-procedurally. So it's quite important to know that this is a small study, this is not a randomized trial, but it appears that the more modern aspiration catheter may well be more efficacious compared to the previous ones. GPIs. So initially when they looked at data from the PRISM Plus trial, they found that using tirofiban in combination with heparin reduced the thrombus burden and improved distal perfusion. So the FINESSE trial randomized nearly 2,500 patients to routine pre-PCI GPI versus contemporary PCI and found similar endpoints and similar mortality, but an increased risk of bleeding. So this is upfront GPI prior to the PCI procedure. The Horizons AMI trial, although looked at multiple things, when they looked specifically at the GPI patients, again, initiating GPI pre-procedure increased the MACE and overall major bleeding rate with similar cardiovascular events. And if you look at BRAVE 3, which is a randomized trial with nearly 800 patients, this is in the era of using high-dose clopidogrel. So previously they would load with 300 milligrams. More recently they would start to load with 600 milligrams. So in the era of high-dose clopidogrel dosing, routine pre-PCI GPI did not reduce infarct size and did not improve overall MACE. And therefore, the current consensus on GPIs is that pre-treatment, before you know the anatomy, is contraindicated. It can be used as a bailout when there is a heavy thrombus burden. With regards to whether you'd use intracoronary or intravenous GPI, it appears that intracoronary may produce a better TIMI 3 flow, myocardial blush, and ST segment resolution, and possibly a better improvement in LV function, but the overall difference in long-term MACE, whether it's mortality, infarction, or major bleeding, appears to be fairly similar. What about deferred stenting? What if we have all of our STEMI patients and we delay stenting, just reperfuse the vessel and stent them on another day? Well, there was the first STEMI trial, which is a single center open label trial, and it was a very good hypothesis generating proof of concept. So these are patients with heavy thrombus burden. These were not all-comer STEMIs. And in cases with a heavy thrombus burden, deferred stenting reduced no reflow, improved TIMI flow, and improved myocardial salvage on cardiac MR. But if you defer every patient to a later date, as in the DADAMI 3 defer, where they randomized 1,200 patients to routine deferral versus routine stenting, the routine deferral did not reduce the primary outcome and had similar target vessel revascularization. So routine deferral is also not recommended. So we go back to our cases knowing what we know now. So these are my 3 cases after I crossed over the wire. And this is case number 3. So the interventionalist will tell you that these are not all the same. The first one appears to not have so much thrombus. The second and third do have some thrombus, and maybe the third has got it in 2 locations, more proximally and more distally. So what did we do? With the first one, the thrombus burden was low. It was downgraded from a 3 to maybe a 2, from a 5 to maybe a 2. We just proceeded with standard PCI with a fairly good outcome. With the second one, we decided to balloon first because we thought, well, we can balloon. There's no contraindication to ballooning, or we thought there was no reason why we couldn't balloon, although there was a residual thrombus. And what happened was we had distal embolization and we blocked off the PLA. So we went back and rescued it with a Caterex mechanical thrombectomy device. And we took out this very large lump of thrombus. Interventionists are always impressed by very large thrombi that we pull out. It always gives you this internal satisfaction that you've done something. And once we restored TIMI3 flow and no major residual thrombus, we proceeded with image-guided intervention to the right coronary artery. With our third patient, we thought we'd go with upfront thrombus aspiration because you can see that there's a very large caliber thrombus after wiring. Once we did that, we decided to do an OCT to understand the anatomy and the pathology behind this occlusion. There was TIMI3 flow. And on OCT, there's evidence of plaque erosion, but there's no dissection or plaque rupture. And we elected to leave this patient on a prolonged GPI infusion and bring him back 3 days later. So this is the angiogram and OCT at 3 days. And you can see here that there's no further major occlusive disease throughout the vessel. And as we look at the OCT, that there's just plaque erosion, there's no rupture or dissection. The minimal luminal area was acceptable at 6.6. So we actually treated this patient medically, and we didn't stent him at all, in keeping with the erosion trial. So to summarize, 30 to 40% of STEMI cases will have a heavy thrombus burden after crossing the occlusion. This is associated with worse procedural and clinical outcomes. One size does not fit all. So all of the above are options, whether it's thrombus aspiration, GPIs, or deferred stenting, but you'd have to select your cases, and you wouldn't do it for every single case. And finally, I'd say that the modern mechanical thrombectomy device appear to have greater efficacy, although there's no randomized trials and there's no outcome data to suggest that these should be used. Thank you.
Thank you, Hani, for this excellent talk about acute coronary syndrome management, and thank you for sticking to time. Can you please kindly use the code just to throw a tough question to Dr. Hani, so we'll address it in the Q&A session. Thank you, Hani. So we saw this patient, he was stenting, and now the question and the hard question, how long should we give him a dual antiplatelet? So this is take us to the next question, next talk. Dual antiplatelet agent, what's the right duration? It's going to be addressed by Dr. Faisal Al-Ghofi. Actually, Dr. Hussein Al-Zair is supposed to give what he has. We heard that he has a baby early this morning. We congratulate him. So Dr. Faisal, our chairman, so kindly he will give his talk on his behalf. Faisal.
Thank you, Dr. Khalid, and thanks you for esteemed moderator and for the panelists. I think Dr. Hussein had an emergency, but I feel that this talk is so important to cardiologists and non-cardiologists because this is the most common question we get asked, either for patient who's going for surgery or should I continue with antiplatelet agents in general. So imagine me, the most younger and beautiful Dr. Hussein Al-Zair. So the background for this in general over the last, I would say, since the era of the angioplasty, we started with aspirin and ticlopidine. Subsequently, there has been so many advances in the antiplatelet agents, but overall, all those years, angioplasty has been, in general, connected to a dual antiplatelet agents, whether the pathology is acute coronary syndrome, STEMI, and as you will see in the slide, also for patient post-CABG. So the main concept of the dual antiplatelet agent is multiple pathway inhibition related to platelet aggregation, whether this will be the cyclooxygenase or the PDP receptors. And as we use in the upfront glycoprotein inhibitor, we are targeting a separate pathway. The main balance that we are trying to do is balancing the risk of ischemia and ischemic burden and also the complexity of PCI with the overall risk of bleeding. The mechanism of most antiplatelet agents is, as I said previously, is related to targeting a certain pathway that prevent at the end aggregation or activation and shape changes within the platelet structure. Aspirin is through the arachidonic acid pathway, ticlopidine, the older antiplatelet agent, and clopidogrel, prasugrel, and ticagrelor working through the ADP receptors. So in general, when we talk about why patient would require dual antiplatelet agents, either for angioplasty, and we are seeing currently DES. We are not seeing bare marrow stent. So unlikely you're going to see bare mineral stent, but you will see drug-eluting balloon, for which I do not have data to say how much we should or we should not prolong the antiplatelet agents. The most common indication is the acute coronary syndrome, STEMI versus non-STEMI. And also we have an increasing population of ACS who does not go revascularization. And those patients also have specific indication for that. And also we have our patient, post-CABG, patients who have stable coronary artery disease who underwent angioplasty. And also there are other indications related to peripheral artery stenting, which we will not address specifically. So the main rationale for dual antiplatelet agent is to achieve endothelialization of the stent and prevent early ischemia, which is usually in the ACS population highest among the first 6 months post-intervention. So multiple evidence for ADAPT. I'm not going to go through it, although Dr. Zaire, my colleague, summarized it beautifully, but it stems even back to the days before the stent has been used, and all data has clearly showed that the use of DAPT reduce early recurrent MI and mortality in the first year. So the standard duration of therapy has been variable, and I'm sure some of us even got confused with the recent publication. But in general, what all practitioner has to try to exercise is what is the indication for the index procedure. Is it acute coronary syndrome, or is it a stable angina, or whether it was CABG or not? And if the index intervention, the index indication is acute coronary syndrome, it is clearly highlighted in the guideline. The second task for the cardiologist or also any practitioner is to answer the question, is the patient at a high bleeding risk or low bleeding risk? So there are 3 major trials that has clearly showed that shorter duration of DAPT has been associated with equal outcome to longer duration of DAPT. Specifically Twilight, STEP-DAPT 2, and Smart Choice, and Global Leaders. When you read those articles and the discussion around those articles, one simple question arises is platform, is it all type of stent? But in general, those form clear information for those patients who are not able to tolerate dual antiplatelet agent that you do have another strategy of shortening the antiplatelet agents. So longer duration, older literature, but all stronger literature, and specifically the biggest STEMI 54 is, and the Charisma has also shown a trend to improving mortality in low-risk patient with dual antiplatelet agents. So we always stick with the guidelines, and what does the guidelines say? I think it's the guidelines still simplified. We did not see the effect of the new trials in shorter DAPT in major change in the guidelines, but specifically patients with acute coronary syndrome who are not at a high risk of bleeding, they should have DAPT for 12 months. There are then the patients who do have high risk of bleeding, and we will go over the risk score, that you can shorten this therapy as early as 1 month. So this is, I think, an important diagram. If you want to focus on the left of the screen, basically the default strategy is 12 months for all patients with ACS. For patients who have been deemed high risk for bleeding is actually 1 month is minimum. There is also data between 1 month and up to 3 months. But beyond 3 months, you could immediately de-escalate, but it has to be a stronger antiplatelet agents, mostly ticagrelor. Now, there is an indication for triple therapy, which unfortunately increase the risk of bleeding. And for those patients who receive triple therapy, I think the guidelines give the practitioner the luxury of choosing between 1 week of aspirin versus a whole month of aspirin, depending on the bleeding risk. But in general, nobody should be in triple therapy beyond 1 week to a month, and then you will go back to a single antiplatelet agents, and the only one approved to the combination with the DOAC is currently Plavix. Now, I'm not going to confuse you with the 2B indication, but there are also 2B indication that highlights other scenarios for specific patients with high risk of bleeding. So for chronic stable angina, I think it's a bit more easier. We do have the 6-month indication, and you could definitely de-escalate sooner if you have a higher bleeding risk. So for chronic stable angina, similar to the acute coronary syndrome, if you just look at no PCI, ACS indication, patient can have aspirin beyond the 12 month. If he have a prior acute coronary syndrome or without PCI, DABT for 12 months, and then you could de-escalate. If you look at in general, at the third column, which is the patient with PCI, chronic stable angina, they have not had an ACS, 6 months currently is recommended, and you can de-escalate. I'm gonna skip this. And I'm gonna move to another important slide, which is for patient. Yes, so this is I think one of the area that we do face in a daily basis is quantification of the ischemic and the bleeding risk. There are two risk calculators. One is the DABT risk score and one is the PERSISE risk score. Both are available in an application. And basically what does help the practitioner is basically to decide whether or not this patient is high risk or low risk. And I think the second question comes immediately, is it an ACS or not ACS? Those information is clearly available online, and for anybody who's interested in this can download it in their phone. So this is a busy diagram, but also goes about, in general, what goes into the discussion about dual antiplatelet agents. The risk factor that increase the risk of bleeding is in the left of the screen, and from those risk factors we can define major and minor criteria. Personally, the DABT score, I found it a bit easier to use, but either score has been clearly validated to help you decide on the ischemic versus the bleeding risk. This is the question we get asked. Well, you did the procedure, so what will make you decide dual antiplatelet agents versus single agent? And I think this is also for our colleague in internal medicine and in primary care. This is the part where we need a discussion. Where if it is not clear in the report, I think it's very important to know how complex was the procedure. Was there any left main stenting? Was there any CTO? And in the same time, although major trial that has looked at short-term DABT. As soon as you try to do subgroup analysis, you lose your power in relation to specific group like left main stenting or bifurcation stenting. So I think the summary slide, there are 3 summary slides from Dr. Zair that I think it's a take-home message. One, assess the bleeding risk. Assess the ischemia burden. The second part, discuss the complexity of the procedure and make a decision, an informed decision between you and the interventional cardiologist. There are other amazing slides in his presentation, but to keep with the theme of the presentation, I just want to stop here. Thank you.
Thank you, Faisal, for this excellent and covering for Dr. Hussein. Please kindly remind you, please put your questions, any hard questions to Dr. Faisal for this topic. So many time as an interventionist, patient with acute coronary syndrome, we do send to the cath lab, we do the cath lab, we do the angiogram, and we find non-obstructive lesion. How we manage these people? So this is lead us to the third talk. Is going to be addressed by Dr. Raed Khan from Royal Commission Hospital, which is the diagnosis and treatment of acute coronary syndrome without obstructive coronary artery, right? And if you want to be very influential in the Twitters, Raed is the the guy if you need your picture in Twitters.
Assalamu alaikum. And good morning, dear colleagues. And my great thanks to the HeartFusion 2025 Scientific Committee for the kind invitation. So I'm Dr. Al-Katshan, and my talk today is addressed one of the most pressing and often misunderstood area in the modern cardiology, diagnosis and treatment of acute coronary syndrome without obstructive coronary artery disease. We will focus on MINOCA, myocardial infarction with non-obstructive coronary arteries, more than INOCA. These real-world clinical syndromes challenge our diagnostic algorithm, therapeutic decision-making, and even the way we actually organize our cath lab workflow. This syndrome marks a real difference as the patient presented with a classical acute coronary syndrome and elevated troponin, yet angiogram shows no obstructive lesion. Historically, such cases were dismissed as a false alarm. We now recognize MINOCA and INOCA serious conditions demand target diagnosis with a clear evidence strategy. Over the next 15 minutes, we will cover the definition, epidemiology, pathophysiology, diagnostic workup, and treatment pathways. And even the prognosis of acute coronary syndrome, how to apply this at the bedside and in the cath lab. Let us start with the definition. So MINOCA, it stands for myocardial infarction with a non-obstructive coronary artery disease. This term was formalized in recent years to describe patients who fulfill the fourth universal definition of myocardial infarction, yet have a no angiographic stenosis more than or equal 50% in any major epicardial artery. Crucially, there should be no other obvious explanation for the presentation. For example, myocarditis or pulmonary embolism that would account for the troponin increase. All three conditions, myocardial infarction criteria, non-obstructive arteries, and other causes must be met. So MINOCA shows a diagnosis of exclusion, and even it's in a working group diagnosis. After labeling a case with MINOCA, we must investigate further to identify the actual cause, either plaque rupture, spasm, etc. The fourth universal definition of MI acknowledges MINOCA and essentially note depends on the underlying mechanism. A MINOCA event can be type 1 MI if it's caused by plaque rupture, thromboembolism, or with the absence of obstruction, or type 2 MI if caused by supply-demand mismatch as a type 2 MI. That's commonly seen in the patient with a coronary spasm or oxygen supply issue. The term acute coronary syndrome without obstruction is used sometimes in replacing for MINOCA for acute cases, including non-STEMI or STEMI presenting with no blockage or no significant coronary artery disease. Technically, one could also include troponin negative, unstable angina with a more than or equal 50% obstruction. While the focus in our talk will be in MINOCA, since it's met the MI criteria, it's worth noting that broader spectrum of acute coronary syndrome presentation with no significant coronary artery obstruction, which is INOCA. So let us go for the definition of INOCA. So INOCA, it's ischemia with non-obstructive coronary artery disease. Refers to the stable counterpart. These patients have a sign or symptoms of myocardial ischemia, often chronic angina, or ischemia on stress test, but when they undergo coronary angiography, there is no significant stenosis. INOCA is essentially what used to term cardiac syndrome X or microvascular angina in many cases. Mechanistically, INOCA is usually due to either coronary microvascular dysfunction, which is inadequate dilatation of the small arterioles, and or vasospastic disease. These endotypes can overlap, and risk factor for INOCA often mirror those for atherosclerosis. And it's really more significant in female. So what's the difference between MINOCA and INOCA? MINOCA key difference, that MINOCA is an acute event that patient has had an MI, whereas INOCA is a chronic condition that the patient has ischemic symptoms without an infarction. In MINOCA, the immediate challenge is confirming that an MI truly occurred and then determine why it happened. In contrast, in INOCA, the challenge is proving that patient symptoms are due to ischemia and finding the mechanism. Both conditions highlight that the absence of the blockage does not mean the absence of the disease. Both are more common in women and commonly underdiagnosed. And to be honestly, MINOCA and INOCA both lie on a continuum. That, for instance, a patient with INOCA due to a microvascular dysfunction might one day develop an acute supply-demand mismatch, which could lead to a troponin rise, a MINOCA event. Conversely, after a MINOCA patient might continue to have angina, INOCA-like course, if the underlying pathology, say microvascular angina or spasm, persists. So as we move forward, we will focus mainly on MINOCA, acute coronary syndrome context, but we'll circle back to INOCA when we need. Epidemiology and clinical impact. So, MINOCA is not a rare flaw. Across registers and positions paper, MINOCA represent around 5 to 15% of all myocardial infarction. This means up to 1 in every 6 MI patients may have a MINOCA. INOCA is even more prevalent. Studies indicate that over half of patients undergo elective angiography for angina, especially women, have no significant stenosis. This highlights a huge population of patients with ischemic symptoms, but no actually a significant coronary artery disease, a group historically neglected. In relation to the patient profile, compared with obstructive MI MINOCA, patients are more often women and somewhat young. Traditionally, risk factor can differ in prevalence, which historically contribute to under-recognition. The key message here is that MINOCA is not benign. Early misconceptions were that angiographically normal MI must have an excellent prognosis. We know nowadays that it's not right. 1-year all-cause mortality is about 3 to 5%, only little bit lower than in an MI coronary artery disease patient, and long-term follow-up show significant event rate. For example, the Swede Heart Registry of about 9,000 Minoka patients reported that 14% mortality at 4 to 5 years and 24% major adverse cardiac event, death, MI, stroke, heart failure by about 4 years. 2023 analysis in a STEMI patient found adjusted 5-year mortality nearly double in a true Minoka versus obstructive STEMI when the other causes excluded, underscoring that if Minoka is truly an MI, not myocarditis or other diagnosis, outcome can even worse than the real MI. So why the worst outcome? Under recognition and under treatment are really a major factor. So for decades, many such patients, often women, were told it's not a real heart attack, or maybe it's stress, and sent home without proper diagnosis or secondary prevention. This therapeutic dilemma has proven harmful. Therefore, epidemiologically, Minoka represent a substantial and vulnerable patient population that demand our attention. So now, with the definition and epidemiology set, let's examine the pathophysiology. What causes an MI or ischemia without a significant coronary artery disease? So first, we need to answer, why am I without a blockage? And here, reminder again, Minoka is a syndrome, not a single entity. Unlike an ST elevation MI from a significant LAD plaque rupture, which is a fairly uniform mechanism, Minoka can arise from a wide spectrum of underlying causes, as you see in this slide. This can be categorized in a coronary causes, cardiac causes, and systemic extracardiac causes. The American Heart Association traffic light pathway and fourth universal definition frame Minoka as an acute myocardial infarction that still demands mechanism finding once you have excluded non-ischemic injury and type 2 MI. So coronary causes. Coronary macrovascular, it can be a macrovascular disease or microvascular disease. A significant subset of Minoka is indeed true coronary artery event. Just not a classic significant stenosis without a plaque ruptures that we expected in MI. Many have, as we can see here, that many of them, they could have an occult thrombosis that not appear in the coronary angiography. That's why intravascular imaging, OCT, IVAS, has frequently revealed that in a significant fraction of Minoka, especially those with ECG or wall motion signs of a coronary supply issue, there is an evidence of a small plaque rupture or erosion, leading to an non-occlusive or transient thrombosis. In the HARP study, they found that an OCT evidence for a culprit plaque in almost 46%, about half of those patients, and interestingly, most of them were in a female. So the other epicardial causes, it could include coronary spasm, intense vasospasm, even can temporarily occlude an artery and cause an infarction, even with a normal angiography later. And there is also what we call it SCAD, spontaneous coronary artery dissection, a non-atherosclerotic tear that led to a lumen compression, which could end by mismatch ischemia in type 2. Coronary microvascular dysfunction is another cause. Finally, a coronary embolism, a clot from the heart, or actually a paradoxical embolism or thrombosis due to hypercoagulable status can cause an MI without underlying coronary artery disease. The angiogram might show a subtle occlusion of a nothing or nothing if it has life. Cardiac causes could include myocarditis, and not all Minoka patients truly have an MI. Some are LOX-like. Takotsubo syndrome of stress cardiomyopathy is a prime example for that. They could present with an ECG changes associated with an troponin leak. Similarly, myocarditis, viral or other, can mimic an MI. Chest pain, troponin elevation, and even regional wall motion abnormality in echo. Other cardiomyopathies, like an trauma, could cause an troponin bump as well. There are sometimes called Minoka mimics, hence not Minoka once identified. Yep. Actually, being the screen is here, it's a little bit confusing. So let us go for diagnostic workup. So and still the differential diagnosis includes the other systemic causes like anemia and other causes which is not cardiac related. Just to say that the complexity explains why Minoka is challenging to study and why stepwise multimodality workup is very essential. So we have to phenotype first, then tailor therapy. We will walk through the algorithm quickly now. So the diagnostic workup diagnose the cause of Minoka requires a systemic multi-modality approach. So we cannot just, after a normal angiogram, saying nothing to fix. We need to pursue the underlying diagnosis actively. So first, recognize and trigger workup as soon as you have a patient with an acute MI and the coronary angiography show no significant coronary artery disease. It's important that the CAS team and treating physician do not simply conclude normal coronaries, nothing to fix. So this is like an Minoka, likely a Minoka now if you didn't find any significant coronary artery disease. So let's find out why it's happened. So exclude obvious non-coronary causes initially. Use the clinical evaluation to rule out the mimic right in the cath lab or immediately after perform through transthoracic echocardiography or do an LV gram during the angiogram, which could even helpful and might show in echo you could find some finding that give a clue about the differential diagnosis. Check the patient clinically for the differential diagnosis. Going through the algorithm, imaging modality is very important in those patients with expected Minoka. So actually, maybe one of the most important things that we have to go through, to be honest with you, speaking about coronary artery disease and with no obstructive lesion, it's a long topic. Whatever was just published recently, the PROMISE trial, was a significant change in how we treat the patient with Minoka, and it showed one of the most important findings that a good portion out of those patients had a Minoka secondary to what we usually underestimate spasm and endothelial dysfunction. So finally, friend and colleague, if promised, give us a spark, let's build an engine. And I believe we need to have our registry for the Minoka, which could explain to us more fact about our Minoka patients, mainly that we have a little information about our community underlying causes of Minoka. Thank you, everyone, and see you soon. And GIS, please be with us.
Shukran, Rai. Thank you very much. Actually, it took part of Dr. Hamid talk time. So move us to our next topic, ST segment elevation in MI. One of the KPI how to improve our management is to measure the door to balloon. So Dr. Hamid going to address the pathway to improve door to balloon time. Dr. Hamid Al-Ghamdi is intervention cardiologist at Saudi German Hospital, Saudi Arabia.
Assalamu alaikum. Thank you, Dr. Khalid, and I demand my time plus 2 or 3 minutes on top. Good morning, everyone. So this is, it's actually a story to tell. I won't bother you with so many studies and data. It's just, we'll go back and look what we have done in the last 25 years. It's an amazing story of how modern medicine basically can evolve and contribute greatly into betterment of human outcome. This is a direct quote from 1996 American College of Cardiology and HA guidelines regarding perfusion. It says exactly that primary PTCA may be performed as an alternative to thrombolytic therapy, provided it can be accomplished in a timely fashion by persons skilled in the procedure and supported by experienced personnel. Prompt access to emergency cabbage must also be available if primary PTCA is to be undertaken. So that's a lot of requirement for PCI to be considered. And again, it's alternative. After that, the update back in 1999 basically did not change greatly compared to 96. So still, PTCA was considered mostly as an alternative to thrombolytic therapy, not as a frontline therapy for those patients. Around that time, we had sort of an important milestone, which is GUSTO trial. So the invasive part of GUSTO, which is GUSTO 2B trial, showed unequivocally that those patients who had reperfusion therapy with PTCA in a timely fashion, they had an amazing outcome. And you can see clearly that the outcome, basically, in terms of 30-day mortality, strongly correlated to the time of opening infarct-related artery. So you can see those who had it opened within an hour had an amazing outcome, around 1% mortality, compared to those who had it open more than 90 minutes, which is almost more than 6-fold increments. Not only that, but it showed in about less than a third of those patients, probably 20% of those patients who were basically assigned to undergo PTCA did not, for multitude of reasons. Those patients had much worse outcome at 30 days. You can see 14% poor outcome. Not only that, but when you looked at the data at that time, when some of the major hospitals in the US basically started adopting PTCA as the viable option of reperfusion, you can see that over a 4-year period from 1999 up until 2002, there wasn't significant improvement. It's dead flat in terms of door to balloon time and also door to needle time, no change. Okay. And you can see that those patients who had timely, reperfusion in a timely fashion, it was almost 35%. And again, did not change over a 4-year period. And around that time, we started basically having mounting evidence, more and more evidence to support the utilization of primary PCI as a gold standard therapy for those patients. Now, somebody might argue saying, well, that's in the old days. We did not have lots of the new fancy antiplatelet, anticoagulation, fancy stents that we have. Do those findings back then stand in current era? Absolutely. it's all those patients. This is a contemporary data came from STEMI registry in Korea that showed, again, time is of a great essence in the outcome of those patients. Delayed therapy associated with significant poor outcome. So 2004, and that was actually a significant milestone in therapy when the AHA and ACC basically released their updated STEMI guidelines, and they basically put STEMI as the corner, or PTCA as the cornerstone for therapy in STEMI patient. And I'm sure all of us remember this fantastic diagram from those guidelines that clearly basically shows you the pathway and how we treat those patients from the onset of symptoms all the way to reperfusion, including great emphasis in the use of EMS in terms of transport and triaging of those patients to proper hospital equipped with PCI. And they include basically significant emphasis on time interval. And they call that those patients should have the arteries open within 90 minutes. And they, because 90 minutes basically support a good outcome. Unfortunately, again, as I showed you, that the uptake of the guidelines and recommendation, it's well known in our business that it takes time. So it continued basically to have very modest and suboptimal uptake of primary PCI, and also on top of that, suboptimal timing. And that led basically the AHA in early 2006 to basically release their national STEM initiative called Mission Lifeline. And I will show you at the same time, ACC had another initiative as well to improve outcome of those patients. And both initiatives basically, at the end of the day, supported each other and basically encouraged greatly sticking to the guidelines and having STEMI patient streamlined to a proper hospital for proper early management. These were the guiding principle of the initiative of the HA. And that basically led to a conference that took place in Boston early 2006. And that conference was 3 days conference that included all stakeholders, okay, in the STEMI therapy. And from that conference, basically, they had lots of protocols and policies that would later prove very effective in the management of those patients. Again, as I said, ACC at the same time had their own initiative called Door to Balloon Alliance Campaign, and with a very simple goal to get those patients door to balloon to less than 90 minutes, and at least 75% of those patients in non-transferred patient. And again, at the same time, this one just focus on door to balloon time. But the AHA initiative basically looked at the process as general, okay, including the STEMI from early onset, the process of transfer, hospital, etc. These are the strategies that were recommended by ACC at that time. The first ones basically were key strategies, and the last one, it was optional strategy early on that later on I will show you that proved very effective as well in getting to the target of that campaign. So what was the outcome of the mission? You can see this is a busy slide, but it showed you from when we started collecting basically data to see the outcome. And year by year, the number of participating hospitals basically increased, but you can see in all parameters assessed, there was significant improvement. Pre-hospital EKG, door-to-device time, first medical contact to device, etc. It was significant improvement year after year. The summary of the first 5 years is this slide. There was 26% absolute increase in the use of pre-hospital ECG by EMS, 28% absolute increase in primary PCI among patients transferred from non-PCI capable hospitals, 50% reduction in patients not treated with perfusion therapies, and 75% achieving door-to-device time within 75 minutes. So this is the power of having good process and policies in place. this translated into better outcome. You can see this diagram. If you were to exclude those patients who had cardiac arrest and presentation, so this is obviously poor outcome to start with, but when you excluded that, you can see significant improvement in mortality. You can see 2080 was 5.3 down to 3.7 over just 4-year period of time. This is a huge achievement. But the funny thing that, in 8 subsequent years, there was no significant change. They achieved the target and sort of numbers plateaued. There's no improvement, okay? And it's an important thing that we should always keep it in mind, that we should continue to strive, okay, to stick to the guidelines and improve the processes and protocols that we have. This is again the outcome, and we looked at the door to balloon time based on the ACC campaign, a very significant improvement. Look at the, not only sticking to the 90 minutes, but also when you look at the outcome, when you consider those patients who had prompt therapy within 75 minutes, also there was a significant improvement, because also there is a measurable mortality advantage if you can serve those patients even less than 90 minutes of time. What about our outcome? Now we'll just show you 3 studies locally, 2 locally and 1 regional, just to compare what we were doing compared to the US. And I use mostly data from the US because it's similar to Saudi. It's a big country. We have a good number of population, not very close to the to primary PCI centers. So that's a good test to the system in place serving those patients. The first one is Space Registry, it's the oldest one in the country, about 5,000 patients. And you can see the STEMI patient represent a good portion, okay, more than the Western counterpart. Around 42% of those in the registry had STEMI, and only 5% used EMS, and unfortunately only 17.5 had PCI. So I don't know what was the outcome of those patients. How many of the 17% had actually good treatment within the appropriate time allowed? Okay. What about in the region, Gulf? So again, the first one was back in 2005, 2007. This was the extended from 2008 to 2009, around 8,000 patients. More utilization for ambulance, probably driven by the Gulf data. That included all 6 countries. 22.3 had primary PCI, and around half of them actually, they had the treatment within the recommended time frame of 90 minutes. Coming back, what about more contemporary data here? This is STARS 2 registry from the country that included around 50 hospitals. I believe some of my colleagues in this room were part of it. And that extended collecting data from 2021 to 2023, around 2,700 patients. Again, very high percentage of STEMI patients, around 50% of those patients with MI. Again, still poor utilization of ambulance, 8.5. Around half of them underwent PCI, and those patients actually who self-presented to ER had better outcome. What do guidelines tell us? Guideline has not changed compared to the very first one back in 2004. Still, we should have regional STEMI of care. We should have primary PCI as the cornerstone of therapy for those patients. It's class 1A indication within 20 minutes, provided that we do it in a timely fashion. What about transferred patients? Still, if you can serve those patients within 120 minutes, this is the preferred therapy. No question about that. But if we cannot stick to the time, then fibrinolytic therapy becomes actually class 1A indication. So that's an area that we should focus on, because this is a real test to our system. One slide about the importance of EMS. It should be an integral part of any process that we have. We should invest greatly in this. Why? Because we all know that STEMI patients, around 10% of them, it's estimated that they might have actually out-of-hospital cardiac arrest. And if it witnessed arrest with shock of rhythm, still they have good outcome, to the extent that those STEMI who had shock of rhythm, who gained full conscious, okay, they have almost similar outcome to those who did not have cardiac arrest. And again, the importance of EMS, it will help, deliver those patients to the right hospital. I won't dwell much on the barriers of implementation because I think every health jurisdiction, they should have their own assessment to know their limitation. But broadly, it's divided in three main areas: non-modifiable, modifiable with difficulty, and totally modifiable. These are just an example. Non-modifiable would be geography and atmosphere and traffic. Modifiable basically has something to do with the patient and availability, and with difficulty. Modifiable basically would be having just, protocol in place and plans between hospitals and different team caring for those patients. I will just show you a few things that help basically change the outcome. For example, 2 minutes. Impact of public awareness initiative. They noticed that in Mississippi area, their numbers basically were a bit late. And they attributed that to the fact that most of those patients, they self-drive to the hospital. So in 2012, they initiated very aggressive public awareness campaign. And the MSUs jumped from 43% to 55% from 2010 to 2016. And that reflected in the outcome. Those patients basically had significant reduction in door-to-balloon time and improvement in mortality. It dropped from 6.8 to 4% over 5-year period. This is a study basically, remember that the early strategy and recommendation by ACC, which is Door-to-Balloon Alliance, they basically left out pre-hospital. It was optional. This data came from 10 busy STEMI program in the US, and they basically redesigned their program to have STEMI receiving centers dedicated, and they included pre-hospital by EMS as a mandate. And you can see before the implementation, you can see in the far left-hand side, the percentage of those patients treated within 90 minutes was just over 40%. But when they implemented, pre-hospital EKG and triaging those patients to these designated centers, you can see the outcome. It's an average of 86% within the 90 minutes. Not only that, but some of those patients receive therapy within even 30 minutes and 45 minutes, leading to better outcome. I will jump this. This is just a look at the recommendation for regional STEMI program. I looked at that. I compared it with the availability at our own when I used to work at MOH, because it's the only well-established program in the region, which most of the recommendation apply to with a bit of limitation when it comes to the MS utilization and training. And these are all known to us, measures that were introduced in the ACC and AHA campaign to improve door-to-balloon time. Now, I'll just forward to I'll share with you these two novel approaches to reduce further door-to-balloon time: emergency chest pain center and integration of AI in the care of those patients. So this is a fascinating study recently published. They looked at the outcome of those patients who were treated in a cath lab that basically was built an emergency room that came from Ohio in the US. And that's over 20 years of experience, because one of the hospital there, they had a cath lab in ER, and they looked at the outcome, okay? Because you basically significantly shorten the time. You can see around 15% of those patients had therapy within 30 minutes. 30 to 60 minutes, almost 40%. And you can see the impact of that one on mortality up to 10 years. You can see the red column is traditional cath lab, and the blue one, basically those treated in emergencies. So I'm not suggesting that we should open cath labs in emergency room, but when we design expansion of our services or a new hospital, we should take this into account. It should be a quick access to cath lab. Okay. This is a very recent data. I'll just show it to you, and I will conclude. That's the integration of AI and EKG analysis. We all know, those who were part of primary PCI program, we struggle sometimes with diagnosis, okay? Atypical presentation, unusual EKGs. Sometimes we deal for people from outside hospital with limited experience in interpreting EKG. When you integrate that, this is a program called Queen of Heart that integrated AI in the EKG interpretation, and that basically led to a much significant improvement in sensitivity and significant reduction in false activation of cath lab, and that's all we need as interventional cardiologists. I'll sum up with this slide, and this is what I think the ideal STEMI care system should look like. We should have an appropriately engaged and aware public. We should have STEMI care based on regionally coordinated programs. AMS, in our region called Red Crescent, should have an integral role in this program, and we should have an integrated AI in our machine to help basically with early and proper diagnosis, and we should have an optimization of cardiac cath lab accessibility, and finally, we should have a regular and rigorous audit and surveillance of our own STEMI program outcomes, which is extremely essential to good and sustainable outcome. Thank you so much.
Thank you, Hamid. Thank you very much. Now we have great 4 talks. Now please kindly, if you have any question, now we're going to have a Q&A question now for the panelist and for the speaker. Please kindly, if you have any question, just throw it in the QR code, or if there is a mic, you can ask direct questions. So there is a mic rounding. Maybe I start with the first question to Dr. Faisal Al-Goufi. May I ask you a question?
Yes.
I start to kick off the question, but please, panelists, audience, this is a 5 to 10 minute Q&A question. Regarding the dual antiplatelets now, do you have any preference between clopidogrel, prasugrel, or ticagrel?
Please.
If you're going to use shorter duration or any of them?
I think ticagrelol is the default for a shorter duration, as there is a lack of, in my opinion, studies that address this specific issue related to Plovix. And prasugrel in the guidelines has equal efficacy to ticagrelol. But if I am going to de-escalate, I usually use a more potent antiplatelet agent.
Okay. Fadal, mic here, please. Introduce yourself and your center and your question, and to whom you address the question.
Thank you. Dr. Ahmed Al-Qudaimi, Saudi Baptist Cardiac Center. I will just ask Dr. Faisal. Regarding the dual antiplatelets, the durations, we know our population are not that smart population. They are not sticking to the diet. There is no good exercises, and most of them, they have not achieving the control goal of management regarding diabetes and dyslipidemia. And I think applying a short duration and dual antiplatelets is not that ideal idea in our population. And I think to stuck to the 12 months is the proper one. What do you think?
What I think is Dr. Hussein Al-Shayr should have been there in the morning. Just kidding. I think you bring it back, Dr. Ahmed, to an important thing that faces us, clinical judgment and making ischemia versus bleeding risk. But I do believe the newer, stronger antiplatelet agents provide us with some great anti-ischemic risk. And remember, most of those data include a mix of patients with at least 30% diabetic. Maybe our population lack the control, but for the blanket statement of everybody should be in 12 months, I think it's safe in low risk bleeding patient, but in high risk bleeding patient, it is more exercise for us to do, to go the calculation of the score and look at the bleeding risk of the patient.
Good. Dr. Abdullah, then Dr. Fahd.
Just I have a question to Dr. Hani here. Was excellent presentation regarding a difficult situation we see in the cath lab when you have very large thrombus burden. But regarding the when you will decide that you will stop and reevaluate, any kind of guidance? Because you might say, I will do aspiration, I will do intracoronary 2B3 inhibitors. Would you try intracoronary thrombolytics, for example, in those patients? So decision to make when to decide to stop.
I think the once you reperfuse the vessel, Because, you know, sometimes you pass a wire and the vessel's reperfused. Sometimes you pass a wire and it's fully blocked. And then what do? Do you dilate or do you use a thrombus aspiration? I would normally want to see flow into the distal vessel before I decide. So if I pass a wire and there's flow, and then you see a big lump of thrombus, then you need to make a decision. And at some point, if I showed you those three cases, the second case, I said, well, class 3 for thrombus aspiration, I'm going to balloon. And you balloon and this big lump goes all the way down to a branch and blocks off the branch. So I think once I see flow distally, and if I see a very large thrombus, I would actually aspirate. And that's actually with the guidelines. It's not a class 3 if it persists after reperfusing the vessel. And I currently use only the mechanical thrombectomy device because I've seen the efficacy is superior. There's no trial data, it doesn't change practice, and there's no randomized data, but I found it to be much more effective at removing large thrombi. The difficulty you say is, okay, you've done this, and there's still a lot of thrombus. And the next question is there flow or is there no flow? So large thrombus with no flow, you give a GPI, it just bounces back. It doesn't do anything. And if you have a large thrombus with no flow, no matter what you do, you thrombect, you balloon, then your only option was either to leave it alone or give intracoronary thrombolytics. And my personal experience with intracoronary thrombolytics was fine initially until I had one patient with an intracranial hemorrhage. And that just makes you think 3 or 4 times before you give it again. And that patient was young and he had a life-changing intracerebral hemorrhage with a thrombolytic. So I'm always very cautious. Your patients already had the heparin, their ACT is above 300. You may have given a bolus of tyrofibine or something in the case, and then you think, oh, there's no flow, what do I then do? Which also makes me go back and say, if I don't see distal flow, I don't initiate the GPI until I see distal flow. Because if you've given a bolus of GPI and then you give an intracoronary lytic, then you're just asking for trouble.
Let's have Dr. Fahd question, then Dr. Hamid. Fahd.
Thank you. I'm coming to Dr. Hamid. Dr. Hamid, thank you very much for your presentation. I think you are addressing very much important challenges. Considering the current transformation system efficiency in country, you know, what you mentioned is already implemented in many countries. In Scandinavia, it's well established almost 15 years. And most of these cases handled by primary care setting, actually. So what I'm suggesting, you know, the leadership at KFUPM, they are taking initiative to support any AI solutions that can improve the healthcare system. So maybe it's a good time now for the Eastern Province as a suitable place to take the initiative and, you know, create focus team where they can build this, you know, concept and run it in several centers. Then it can as a proof of concept. And yesterday we had 2 speakers that they talk about, you know, platform trying to retract and monitor those patients. So the structures and the momentum is really now. So I think since you start this, I really encourage taking this initiative to next level to implementations because it's really important.
Sure, I will convey your remarks to my colleague at the cluster because Bioengineering Center is the one who overseeing the real regional program. Every single hospital in the area, I'm sure they're doing great when it comes to 90 minutes because that's patient of their own hospital. But the outcome actually show clearly patient across different hospitals, even within, you know, small geographical area because despite having multiple cath labs. So AI will help some of the gaps in care that we encounter. Just quick note on the large burden clot. The first strategy is very well known, okay, provided that when you open the vessel, you have distal flow, so you can deliver your medication. The problem with the first strategy is when you look at it over the last few years, multiple studies with different samples, with different actually time, some of them few hours deferred, some of them up to 7 days. So that's why the result is not always consistent, but still probably it's the best strategy to defer if you have large residual clot.
Good. May I comment about the STEMI programs? Now Ministry of Health is moving from, and I need your input, Dr. Hamid, from door to balloon to call to balloon now. So to include the EMS delay to count on that. So can you elaborate on that? Are they gonna? Because we heard that this is the new initiative from Ministry of Health and is going to be measured to differentiate from call to balloon rather than. Do you have any input on that?
So I think that's the ultimate way. Cold to balloon is, we're talking about the ischemic time, which is, I think if we can capture that in a more systematic way, and I think that will even further add to the outcome. Some of the issue that we face, and that's probably the reason for that initiative, is public awareness, poor utilization of EMS, which, well, I think personally, if we can, tackle these two issues, will add greatly to the outcome of those patients, because we're not sure of cath labs. We have multiple cath labs in the area. Some of them, they're just adjacent to them, 5 minutes from each other. It's just how to capture those patients, how to get those patients to, seek help in good way, in a timely fashion. Yeah. So I'm looking forward to that initiative.
And the echo that the AI is going to help a lot, and as you mentioned, in the diagnosis, the early diagnosis, especially in the remote area where you need to fax the ECG or WhatsApp the ECG. The AI now, with the over 98% of accuracy in diagnosis of STEMI.
So a quick word on that. One of the issues that we face, and if we deal with regional program, is we don't have enough experienced and trained ER physicians. Sure. Most of the ER out there, basically in the community, they're run by non-emergency physician and suboptimal training. That's one of the major gaps. That's one of the reasons we get actually false activation of the cath lab. So AI, I think, will do marvelous in that area.
Final comment from Dr. Faisal before we move.
Dr. Khalid, if you, thanks for controlling the time, but this is an important question that I kept for this time, and I want everybody's opinion, because this is a most common clinical scenario related to Minoka. Dr. Raed and Dr. Hani, for those patients who has been diagnosed with myocardial infarction with no obstructive disease, and we have no suspicion, or we have been screening them for myocarditis and for other etiologies. I want to ask the question, even for the panelists, how would you go about dual antiplatelet agents versus single antiplatelet agents, assuming you did your imaging, if there is an indication for imaging, and you didn't see anything? I'm going to start from Dr.
We'll start from Raed first, then Hani, then the panelist.
So this is a great question, Dr. Faisal. Actually, the evidence about that, it's already established. The Swede Heart Registry, which is actually included 9,000 patients, it showed clearly that the benefit of dual antiplatelet therapies depend on did you reach actually the real diagnosis or no. But in general, using the dual antiplatelet therapy blindly, as you use one blanket for all the patients, it's not really of benefit. The other point is, on the other hand, you shouldn't immediately stop the dual antiplatelet therapy if you find that there is no significant coronary artery disease, no blockage more than 50%, because you cannot afford, you miss a patient who really, in a case of ischemic heart disease, and he had some kind of coronary artery disease, you will still establish the diagnosis for it in the future. Like as we speak, OCT could prove that there isn't a finding, like in a SCAD, we miss it, small thrombus, we miss it, small plaque ruptures with actually thrombus that we cannot see it in the two-dimensional angiography. And finally, the most important study is PROMISE, which just published 1 month ago. And it showed a very interesting finding. The most important drug, you don't want to miss it, in any case of inoka, is statins, not the antiplatelet therapy. And interestingly, we believe that maybe the real atherosclerotic disease is something that we miss on those patients, but they find no. The most prevalence is actually for microvascular disease, not the atherosclerotic disease.
So you answer the question, how duration of dual antiplatelet, single or
You should
double?
keep the dual antiplatelet therapy until you find the diagnosis. And actually, even for the issue of the AI, there is an established program for those patients with Minoka that they actually control the algorithm by AI to guarantee that every patient is go through the algorithm and you don't miss any patient. And one more important message that every patient with Minoka should have CMR.
Hani, short answer. So we can go to the panelists back.
I divide my patients to 3 people. Type 2, so severe anemia with systemic disease, I'd exclude them from anything. Myopericarditis, if you prove that on cardiac MRI, that's another situation, you then go down that route. But if you do a coronary angiogram and there's no major obstructive disease, but there's mild, or it looks like there's mild disease, I would always use an OCT, because what you're looking for is plaque erosion, plaque rupture, and SCAD. And I think I base my antiplatelet therapy on these 3. So anemia, systemic disease, I might give no antiplatelets if the hemoglobin's 6 and they've got a type 2 MI. If it's myopericarditis, I go through that pathway. Usually it's high-dose aspirin plus non-steroids plus colchicine and all that business. And if there is plaque erosion, plaque rupture, or any suspicion of coronary disease, then I would give DAPT in that scenario.
Okay, Dr. Ali.
I think everything was said. I mean, excellent answer from Dr. Khan. I agree with Dr. Abdelhadi. And same thing, I don't think that DAPT is a benign treatment. I wouldn't give it just a blanket for everyone, unless you have a reason. And I agree, imaging has a major role. MRI, definitely the first step when you're not sure. And I think the diagnosis of myocarditis or perimyocarditis or myopericarditis, or now they call it the cardiac inflammatory syndrome, is actually much more prevalent than we think. So we do see mid-wall enhancement rather than subendocardial ischemia, and we often diagnose it Minoka. In those cases, for sure, I don't think even aspirin is necessary, but you need to have a reason, in my opinion, to give DAPT.
Okay. Dr. Manuel?
No, I agree, and I think excellent talks and excellent replies. I think MRI is critical to the management of these patients. In the cath lab, if there's no obstruction, they have an MRI scan, a D-dimer, and I think an MDT team will also play a big role in this, not just cardiologists, but also endocrinologists and renal physicians to be able to actually exclude, because Minoka is a diagnosis of exclusion, once we've excluded all the other things. But antiplatelet therapy is key, and I think that's where, again, the bleeding risk of the patient plays a role. If they're high risk of bleeding, then you try and avoid that if there are obvious reasons for the Minoka. But if they're low risk of bleeding, I think you can continue antiplatelet therapy till you get your diagnosis.
Dr. Fahd, you have any comment?
Thank you. Again, what's happening, we're trying to do now, it's already done almost 10 years. I think, there is no specific guidelines. We know European guidelines and North American guidelines. This is in the practice today. But I think the most important thing is now, personalized medicine does not treat the disease, treat the patients. So I think patient from patients is different. Though they are having the same disease, the same diagnosis. Personalized medicine is very important. Comorbidity factors play a strong role. So patients A totally different from patients B. You will see those patients, they're responding. So even the genotherapy now is becoming so aggressive and very specific. If you look to these applications in other diseases, cancer, imagine this in cardiovascular. So I think this is also, again, call for creating something in cardiovascular that we can personalize our patients, their need for even for medical device implementation, reactions to the device, to the patient's organs, to the device. It's huge science, which is, I think, it's the time to initiate now. This is my suggestion.
Abdullah?
Well, I think they said all the points. Regarding the duration, I would give usually for 12 months as a default. If I exclude the other causes have been suggested, I would stress in the MRI, so we use them in every case of Minoka and the baseline, and also you can repeat later in 3 to 4 months to see if there is any scar to guide your therapy further, but usually for 9 to 12 months.
Okay, I think the answer of where's Faisal who asked the question is kept. So I think it's depend. I agree with you. Precision and personalization on that. There is no one shoes fit all foot. I think we'll move on to the next 4 topics we have, and we see Dr. Ali Shiri is eager to give his talk. Dr. Ali Shiri is intervention cardiologist in JHAH. So on his talk is going to give us talk about stable angina treatment outcome.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. Thank you, Mr. Chairman, and thank you for the invitation. My talk should be hopefully quick because I think the answer is not very difficult. But I have a question for the panelists, and I hope we will hear their answer at the start. So I'll be talking about the chronic stable angina or chronic coronary syndrome. We have an acute coronary syndrome, now we have a chronic coronary syndrome, which is the chronic stable angina. We'll talk about the treatment options and if we have any supporting evidence for that. I have no conflict of interest. Saudi Arabia is probably one of the highest countries in the world with coronary artery disease. And you can see that only Saudi Arabia, the Gulf area, and Egypt has the highest percentage of coronary artery disease worldwide. And if you look at the diagram here, we have more than 7,000 cases per 100,000. This is a huge number. So we're talking about maybe almost 7% of the population, they have coronary artery disease. And the major reason is because we have a lot of diabetes mellitus cases, and we have a lot of smokers. Now, the overall conception is people are starting to do more exercise and to take care of themselves a little bit better, but still we are one of the highest countries in the world with ischemic heart disease. Now, this is a question for the panelists, and I'd like to have your opinion, if you don't mind, Mr. Moderator. 55-year-old male, he's a smoker, dyslipidemic. He presented with class 1 angina. His medications include aspirin and bisoprolol, 2.5 milligram daily. Had a treadmill test, which was positive at 8 minutes with mild chest pain, and his ejection fraction is 50%. This is his coronary angiography, moderate RCA disease, and a critical significant mid-left circumflex disease. He doesn't have, take my word, he doesn't have a significant LAD disease. Question is, after the cath, what would you do? We'll give you 1 minute, panelists, to tell me what you think. I can't. Sorry, I'll come back. Sure. So, excellent. So, medical therapy.
I agree with him.
Medical therapy again?
I agree.
I agree. Medical therapy.
I think if he's already on the table and you have significant circumflex, I would, and he has angina. I mean, CCS class 1 is asymptomatic.
Well, he has mild angina.
Yeah, then I would. PCI.
You're there, you fix it.
I would fix it.
Okay, so 1 for PCI, 3 for medical therapy.
So I will balance it. I will go. I'm an interventionist, so I'll go for PCI for a couple reasons. Significant disease is a codominant or dominant, I cannot tell here, vessel. Is very straightforward, simple stenting and very large vessel. So I think BCI will treat his symptoms. So I will go with the BCI.
Okay, fair enough. So you have to know that they're all interventionalists, and we have what we call an oculoreflux. So we see a lesion, we can't leave it. All right? But we'll go through the evidence and see if this is the way. But remember, if you see it, this is a bread and butter case. You see it every day. And I think most of us will fix it. Whether this is the right thing to do or not, we will come to that. Now, angina pectoris is basically due to obstructive coronary artery disease. And the guys have just spoken about the INOCA or MI or unstable angina or angina without significant obstructive artery disease. And the aim of treatment in chronic coronary syndrome or chronic stable angina is basically to relieve symptoms if they have, and of course, to improve survival. The term chronic stable angina has been recognized for people who have stable chronic angina for at least 2 months, with episodes that are provoked by same level of exertion or stress. This is the chronic stable angina. Once they get their chest pain with less exertion or comes at a lower workload, then they move into the unstable angina and they move into the acute coronary syndrome category where it has its own different treatment. The pathophysiology is very simple. It's a demand-supply ratio. When you exert yourself, less oxygen supply because of the stenosis, they get chest pain and they get ischemia. And by the way, most patients, when you ask them about chest pain, they tell you, we don't have chest pain. And they're right. It's not actual pain. It's a pressure-like. Okay, but it's not a real pain except if they infarct. Now, the chronic coronary syndrome is equivalent to the stable ischemic heart disease acronym they use in the United States. Those terms include both typical angina, ischemia-mediated dyspnea, which we see a lot, especially in diabetics, and of course, silent ischemia. Now, you have to remember that it's a very complex disease, and you really, in the treatment of chronic coronary syndrome, you have really to involve the patients as well. Shared decision-making is the cornerstone of the whole thing. So you have to put in mind the symptoms of the patient and their quality, what their cardiovascular risks like, what is the treatment options available and the investigations available, and a very important cornerstone is what is the patient preference. We offer cardiac cath and we think this is the treatment. Patient denies that, or he doesn't want a cardiac cath. And we're actually seeing more and more patients with chronic stable angina who will challenge you. Why are you going to do the cath for me? What is the benefit of putting a cath and putting a stent for me if I have minimal symptoms or no symptoms? And they are absolutely right. Now, just a reminder for everybody about the Canadian Cardiovascular Society classifications for angina. Class 1, no angina or minimal angina on ordinary activities. Once you start getting angina on walking more than 2 blocks or 1 flight of stairs, then this is class 2. If it's less than 2 blocks or less than 1 flight of stairs, this is class 3. And of course, if you have it at minimal activity or at rest, this is class 4, and this is the standardized protocol we use. So why we treat angina patients? We treat them to improve their symptoms, number 1. 2, to prevent cardiovascular events, including cardiac death or MI. And of course, during this interim, you try to identify the high-risk patients where you should go further and investigate earlier, including cardiac catheterization. The treatment options we have are beta blockers, nitrates, calcium channel blockers, and ranitidine. You have to know that we will talk about the COURAGE trial later on. The COURAGE trial, when they investigated patients with chronic coronary artery disease, and some of them went on the medical therapy, the others went on medical therapy and PCI. The medical therapy arm included everything, included beta blocker, calcium channel blockers, and nitrates on everybody, plus of course statins and antiplatelets. So if you think about your patients, how many of them are we putting them on a combination of beta blocker, calcium channel blockers, nitrates, and we reach their targets on LDL cholesterols, and then we decide whether we need to proceed with intervention or not. I think we have very few patients that are reaching that stage before we make up our mind. Now, beta blocker quickly, they work by reducing the oxygen demand and the heart rate. They're the first-line therapy in chronic coronary artery disease. The guideline recommended combination therapy, you can combine them with calcium channel blockers or long-acting nitrates if need. However, this combination has not proved to reduce ischemic events or angina therapy compared to monotherapy. They definitely improve survival after MI, but this benefit has not been proven in patients with chronic stable angina. Now, you can use any cardioselective beta blocker, use any beta blocker. There is usually not significant difference between any of them as long as you use beta blocker. Sometimes you run out of bisoprolol. You don't have a beta 1 selective. You can use the non-selective ones. The dose of beta blocker should get a heart rate below 60. And we see a lot of patients coming to the clinic, they are on beta blockers, their heart rate is 80s. You did not reach your target. You really have to get their heart rate down to 60s and below. And if they exercise, they should not exceed 75% of the heart rate that causes symptoms. So if they get symptoms 140 at 140 beats per minute, then they should aim for 75% of the 140, not like normal people, 75% of the maximum tolerated heart rate. Definitely, they're contraindicated in vasospastic angina. If you have syndrome X or vasospastic angina, don't use beta blocker. They may get their things worse. Calcium blockers are similarly effective. They give you the same benefit, monotherapy like beta blockers. Beta blockers may be particularly useful in blunting the reflux tachycardia if you use dihydropyridines, okay? If you use something like nifedipine for the blood pressure control, that gets reflux tachycardia. So the addition of beta blocker on top would be a good thing to consider. Nitrates, very important, long-acting nitrates, they work in combination with the others. You have to give them a nitrate-free period, as we all know, 4 to 6 hours per day, and they're available in a spray or sublingual form or long-acting dihydrate or mononitrate. So this is a third-line agent we would use. One thing to use is the ranolazine. We don't use it that frequent. Its mechanism of action is actually not known, but it does improve the sodium and calcium derangements that happens in the myocardial vessel. At the same time, it's being found that it will improve the glycemic control in diabetic. It's a very good drug, it is in the guidelines, and maybe we should use it more. I'm not sure how many hospitals they have it, but I think it's one of the drugs on the block that people should probably be using. Watch for QT interval if you give them ranolazine. Aspirin, you all know, it reduces the risk of having an MI by 33%. The dosing is not different. If you're going to use 81 or 75 or 325, there is no difference between. Actually, you get more side effects if you use a larger dose, but the minimum is 75 or 81 milligram. Now, if you treat them, you're expected to prevent about 10 to 15 vascular events for every 1,000 patients you treat. The clopidogrel or Plavix is a reasonable option for patients who cannot use it, and currently in the interventional literature, we are moving away from aspirin as time goes on. So for long-term therapy, I am preferring to use Plavix rather than aspirin, but maybe we'll come at a stage where aspirin is not going to be the first choice. Dual antiplatelet therapy, you know the indications for it. Post-PCI, acute coronary syndrome, and we just talked about it this morning. In patients with history of MI or PCI or recent CABG, dual antiplatelet therapy is recommended. There are new data now that using dual therapy for post-CABG patients improve the patency for over a 1 year time if it's used. ACE inhibitors, we all know it reduces the risk of stroke or death or MI by 20%. It should be used in anybody with an ejection fraction less than 40% as per the guidelines, or if they have diabetes, mellitus, or chronic kidney disease. LDL cholesterol, no-brainer. You have to get their numbers below 50% with their initial admission number or below 70. And yesterday we had a lecture telling us the moderate risk, the high risk, and the very high risk, and their targets, and I don't have to go through this one again. Now, would you do a stress testing? Probably, if you want to really qualify the patients for a better. I'll go quickly just to show you the evidence. Use this one, A, B, C, D, E's. A is aspirin, anti-anginal ACE inhibitors. B is beta blocker and blood pressure control. C is cigarette and cholesterol control. Diet and diabetes for D, and education and exercise. So remember those ones, A, B, C, D, E, for everybody who comes to you in the clinic. I think this makes you remember the numbers. Now, quickly, when to consider coronary angiography, and this is what really matters for all of us here. You do coronary angiography if you have high risk non-invasive testing. If you have, remember that all these studies that were done before, they exclude left main disease. So before you treat them medically long-term, exclude left main disease, exclude severe LV dysfunction with an AF less than 30%, because these were not entered in the studies. If you have those two factors away, then you can treat them medically. So if you have a large area of ischemia, more than 10% on the PET or the SPECT, if you have transient left ventricular dilatation on the SPECT, if you have high features on the ECG, like ST elevation, this is somebody you really have to go. If you have a drop in the left ventricular function with exercise, or more than 2 wall motion abnormalities out of 16 with inducible ischemia at a low workload, these are the ones that you really have to go. Of course, if you have unstable angina, you have to do them right away. If you have symptoms not controlled on good medical therapy, I'm not saying just medical therapy, good medical therapy, adequate dose, adequate responses, and they still have symptoms, then you should consider cardiac catheterization act. And if the ejection fraction is below 45%, and some studies say 35%, then you should consider going for an angiography and invasive strategy. Quickly, this is the same one again. Revascularization, I will talk about the studies quickly because I think I'm running out of time. Revascularization should be reserved for those with symptoms that interfere with lifestyle despite optical medical therapy, and this is easy. Coronary anatomical findings that indicate that revascularization provides survival benefits, especially if they have a left main disease, if they have three-vessel disease, ejection fraction less than 40%, and if they have two-vessel disease, including proximal LAD more than 75%. So these are the three categories that we really have to worry about. Everybody else should be treated medically unless they fail. I'll go quickly on the COURAGE trial. COURAGE trial came out in 2007. They included almost 2,000 patients, and they categorized patients into two groups. They all had an angiography, significant disease more than 80% with no evidence of ischemia, or more than 70% with positive MyView or positive treadmill test. Two groups, one got treated with PCI plus optimal medical therapy, the other one was optimal medical therapy. At the end of the study, there was no difference between the two groups in the primary composite endpoint of death, cardiovascular mortality, and readmission. At 5 years, there was no difference, and a prolonged follow-up at 12 years, there was also no difference. Remember, these patients were treated medically well. They were all on anti-anginal medications, their heart rate was controlled, the risk factors were all controlled, and this is why PCI did not show evidence. Now, the other problem is this study was a bit early. Only a small percentage received a drug-eluting stents. Most of the PCI patients received a bare metal stent. FFR, IFR, hemodynamic assessment were not there at that time. So this is the foreshortening of those two studies. Again, I will just go quickly because of the time. FAME trial, you all know it, okay? They compared people with FFR-guided PCI versus medical therapy, and at the end of the study, there was no significant difference even with those who were FFR positive if you treat them medically. So medical treatment is the mainstay, even if you prove they are hemodynamically significant by FFR or IFR. Again, this is the same one. Now, ischemia trial is the most important one. 5,000 patients, they all have moderate to severe inducible ischemia at non-invasive testing. The initial strategy was PCI/CABG plus optimal medical therapy versus optimal medical therapy. They were followed up for 3 years. The intensive strategy or the invasive strategy showed no benefit over the primary outcome, including cardiovascular death, MI, resuscitated cardiac death, and hospitalization for unstable angina. Remember, all those patients, they got screened for two things: left main disease by CTA and echo to assess LV function. If you have more than 50% left main or your ejection fraction is less than 35%, you get excluded from the study. So I think once we have those two things away, you probably can treat medically with no major issue. Now, they have an extended ischemia trial, which was followed up at 7 years and still shows the difference. Interestingly, those patients, they were about 2% improvement in the MI in the invasive group. However, there was about 1 to 2.5% of non-cardiovascular mortality in those who underwent the invasive group. And the reason for that is not known yet. Is it cancer from radiation? Is it something that is happening? I don't know. Anyhow, Dr. Khalid is telling me to stop. So 2 meta-analysis, 10,000 patients, the first one, 12,000 patients, again, compared invasive versus non-invasive strategy, and there was no difference at all between the two groups in chronic stable angina. So my take-home message at the end is medical therapy is the mainstay of chronic coronary syndrome. Targets should be achieved as much as possible, and revascularization, except in selected group, does not improve survival. However, it does improve symptoms. One word of caution: if you have a patient who is not really responding to the medical therapy, don't ignore his symptoms. This is the one that you should really go ahead and do a cath for him and maybe do a PCI, especially if they have persistent. Thank you very much.
Shukran, Dr. Ali, for this excellent review on management of stable angina. So we'll keep question. Please, if you have any questions, just throw it out. So we're going to have another Q&A question. As Will said, if you cannot measure it, you cannot improve it. And JHAH, one of the earliest hospitals that joined the NCD registry, and Dr. Faisal Gofi will give us outcome measure in coronary artery disease insight from the NCDR.
Good morning again. I'll try to make some times because I know Dr. Khalid is going to give me the sign. It is very important, and I think the purpose of this message is not to say that we are part of NCDR, not NCDR, is actually to generate a discussion among ourselves in the community to ask the simple question, how can we create a national data that we benchmark ourselves against? So nothing to disclose to this talk, but what is the most important thing for us, have a safe and effective procedure and know that our procedure in 1 month and 1 year made a difference. So it is an important measure is the outcome. Basically, the NCDR or any registry, for example, in Canada, we had KHAH for both surgical and BCI procedure, but the presence of an outcome or data will provide you with a culture of trust between you and your leadership to show that what you are doing is actually in keeping with the benchmark. More importantly, it improves the patient safety and the clinical effectiveness, and it reduces the variation in care, support evidence-based, because it not only give you data, it will give you gaps in your system that you should improve, and it provide teams accountability. So the National Cardiovascular Data Registry is basically data out of the US benchmark within North America, and it has multiple centers currently outside North America. Unfortunately, currently they don't benchmark Middle East to Middle East, they benchmark everything to North America. Multiple modules, STS, TAVR registry, cath PCI, ICD, and ablation, all with one purpose, safe and effective care, and to give you data to improve your patient journey. So we'll go about some of the example of what getting, I will show you a real report, but what is giving to us every quarter. It will tell us about our mortality, stroke, bleeding, chronic kidney disease, or nephropathy. It will measure also our door to balloon time. It will give you data about radial versus femoral. And more importantly, it will benchmark you if you want a cross center. That's part of the standard. But it also can provide you with operator performance should you ask for that. Also, more importantly, appropriateness criteria, because I am following after a stable angina talk, it will tell you if the therapy or the PCI that you did is appropriate according to the appropriate use criteria. So, more importantly, in general, when you have any outcome related to cardiovascular or non-cardiovascular, let's look at any gaps within your system and implement plan, as I will show you on some of the quality improvement project, and at the end of the day, provide feedback to your department and to your leadership. In general, the data give you any data, whether it's STS or NCDR, it will give you something about your observed versus your expected outcome, what is the national percentage ranking, and if there is any gaps over time, and it will give you some information about outliers and what they mean by that. You are doing excellent in 3 quarters and suddenly 1 quarter jump. There gotta be some way of explaining those data compared to the previous 3 quarters. More important for us in Saudi, and we always hear that when you go to meeting, our patient is different. And that is one of the gaps that I do believe in any data that is generated in the Middle East and not benchmarked in the Middle East, because you are benchmarking to a different population with different risk profile. But luckily within the STS and within the NCDR, there are general benchmarking risk factor that is mostly applicable to most patients: diabetes, risk of stroke, bleeding, and chronic kidney disease. I'm going to skip over that because I will address that in a barrier by giving you an example. But for any registry, if you really want the most information of that registry, it's about the truth of the source of information that you feed it. And electronic medical record has been detrimental in that, but it's also important that you have or you employ people who basically look at those registry and make sure that this information is correct. So the NCDR, I'm giving the example of the NCDR database for coronary angiography. Mainly it divides into multiple metrics, but some are related to performance, some are related to quality, and some, as I mentioned, related to the appropriate use criteria. What is being reported, for example, to the leadership or the C-suite level is most of the time related to your adjusted mortality and, in general, your PCI mortality for ACS in general. Other thing we report to ourselves as a department, as I will show you, how are we performing in relation to quality metrics? How many patients leave the hospital with aspirin? How many patients leave the hospital with DUAC? what is our length of stay? These are important metrics for us as quality to, again, improve upon ourselves. This is an example of an older report, but basically how do they report the data for you? You look at major adverse event, which is basically any patient who had any complication related to PCI during the index admission. Even if this patient had other mortality reason, this is still counted as your 0 to 30 days mortality. And basically, if you look at the right of the screen, they'll show you where is your hospital and where do you stand in hospital with similar volume, let's say between 200 and 400 PCI per year, and how do you compare to 50%, or where are you in the 50th percentile? This is the result of the 50th percentile, which is the 2.78. So this is an important quarterly metric that we look into closely. And then there are other, there is the other important metric for us is the mortality, standardized mortality for everything that happened with your patient, whether it is related to stent thrombosis or other hospital encounter. And again, it shows you how do you stand and how do you perform in relation to the 50th percentile of the US registry. One important thing about this metric, and this is one of the, I will say, peculiar thing about the NCDR. If you look at your quarterly data, sometimes you'll get surprised, and the NCDR keep giving you what we call the R4Q, the result or the average of your last 4 quarters, in order to not to get you fooled with one result, whether you are scoring 0 mortality or 5% mortality. This is not important compared to your R4Q, which is a rollout of your previous 4 quarter in order to have more meaningful data. Other things to look for is whether you want to have a stroke. This is a performance measure which we ensure all our patients has to be referred to cardiac rehab. So in order to ensure that this happen, we generated an automated order that everybody who undergo a procedure with a CABG or whether it's a PCI, they have an automated referral to a cardiac rehab. So I will share with you how did we use this data to improve outcome. This is again is a multidisciplinary approach. It's not actually done by physician, it's by nursing and cath lab team that actually identify gaps and then try to come with an actionable items in order to improve the gap. I will direct your screen, your attention to the left of the screen. Look at our hospital contrast-induced nephropathy metrics, 12.54. And in that, for example, quarter, the 50th percentile was 6.6. We are almost double the contrast-induced nephropathy risk. So we gathered the team, we looked at our MRN number, what does happen or how can we prevent this? So we come up with a strategy. One, starting with a high-risk calculator. Before you walk into the room in the cath lab, your technologist or your nurse come up to you and say, listen, his calculated CIN risk score of this, your total amount of contrast is this. So it's basically to give you an attention. Then we looked deeper into our hydration protocol, post-PCI order, and we implement 3 protocols, one directed by the LVDP, one directed by whether or not the patient had a pre-existing chronic kidney disease, and basically it's a click. And the last thing is to implement post-cath creatinine for everybody, whether he is inpatient or outpatient. How did this changes in the metrics or this action changes reflect on our metrics? You could see in the right of the screen, within 3 months, or in fact within 6 months, we can see a drop of our CIN. In fact, we beat the 50th percentile. Another important thing we look for is what we call the length of stay. We always look for it, and it's very important for us to make sure that we have a metric that we follow our patients. So within the NCDR, and in fact within any registry, and I remember, for example, in Canada, we use the Cadillac risk score as a way of risk stratifying which patient should go post uncomplicated STEMI. So the NCDR give you your length of stay in relation to the patient who had STEMI, and they are classified as uncomplicated. And if you look at the left of the screen, our hospital, 2.29 days, versus hospital with comparable volume, 2 days. And in fact, 50th percentile is within 2 days. Still, we have not met this yet, but it's a work in progress. by basically educating the staff, empowering the nurses to raise the question, why is this patient still in the hospital? His risk score is low. So this is very important. We keep monitoring this length of stay in order to see or seek ways to improve this metrics. So in summary, we need outcome not to show it or not to look at it, but to have an actionable items in order to make sure that those outcomes translate in a better patient safety. More importantly, the more you are honest and accurate in giving this data and feeding this data, the more you have meaningful information. It is very important that physicians, nurses, and all inter-hospital disciplinary team should be part of this process. I give you an example. This information in my hospital shared in a quarterly basis with the risk management, so they can help me to identify any gaps, and they can be one of my tools to improve the process. So thank you.
Shukran, Dr. Faisal, for this elegant presentation. I'm sure we have discussion about it in the Q&A. We'll move on to the next speaker, Dr. Ali Abu Saud from Imam Abdurrahman bin Faisal University. He's an intervention cardiologist. He will give us insight about revascularization strategy for multivessel coronary artery disease, focus on PCI. Just now, Dr. Ali Sheri told us PCI doesn't work, so convince him.
Sure. Assalamu alaikum. Thank you very much for this invitation and the lovely organization of this conference. Yes, it would be a complementary to what Dr. Ali Shehri said. We might disagree a little bit. I don't have any financial disclosures, just I'm an interventional cardiologist, taught by interventional cardiologists, so you might sense a little bit of bias. Whenever we talk about coronary disease, we have to classify it or approach it into the two major categories: acute coronary syndrome, which is ST elevation MI, or non-ST elevation acute coronary syndrome, and or chronic coronary disease. And to assess the multivessel revascularization, or the completeness of it, we have to assess the benefit in each of these categories. So I'll try to go over the guidelines and the evidence behind them. And it's a bit of a large topic that requires a full day, but I'll just try to subcategorize it. So according to the very recent ACC AHA guidelines, which are very similar to the Europeans, but maybe a little bit simpler, when approaching multivessel disease, revascularization is recommended to improve angina and quality of life. So as was mentioned I'm talking about ST elevation MI. No, when you talk about ST elevation MI, it is recommended that you complete the vascularization to reduce not only the quality, improve the quality of life, but to reduce risk of death and MI. And that comes in from several trials that looked into this with significant reductions in all major adverse cardiovascular events, starting with the PRIME trial, there was the CULPRIT trial, the NAMI trial, Compare Acute, and then finally the well-known COMPLETE trial that showed significant cardiovascular mortality improvement if you completely revascularize patients with ST elevation MI. However, there were a certain number of patients that were intended for CABG, and those were excluded. Patients that had complex multivessel disease were really not necessarily included in most of the trials, and the presence of chronic total occlusions was also excluded from these trials. So, PCI becomes, still the standard of care. However, elective CABG for patients that have left anterior descending or left main become a reasonable approach in those patients with ST elevation MI. What we know very well also that patients with ST elevation MI and cardiogenic shock should not get revascularization beyond the culprit, because that increases the chances of death and renal failure. However, when we come into non-ST elevation acute coronary syndrome, then revascularization is class 1, whether it's CABG or PCI, and it really depends on the complexity. So multivessel disease in multivessel disease, PCI becomes class 1 if in the absence of left main. And this is from the FIRE trial, which looked at about 1,500 patients at the median age of 80, and it was physiology-guided PCI. and still showed a significant reduction in major adverse cardiovascular events without really increasing complications, whether it's contrast-induced nephropathy, stroke, or bleeding, in this very fragile comorbid population. So the guidelines conclude that in patients with non-ST elevation acute coronary syndrome and multivessel disease, CABG is recommended when there is significant left main and complex CAD, and if there is diabetes with the involvement of the LAD, or if there is severe left ventricular dysfunction. How about chronic multivessel disease? We heard from Dr. Shihri that revascularization probably does not improve outcome over medical therapy. But as part of the ischemia trial, which was mentioned, there is a subset of patients that had three-vessel disease. And those were about 20% of the population. So out of the 5,000 or 5,500 patients, about 1,200 patients were looked into at the same time. And when you look at the top row, the revascularization versus conservative, there was a significant reduction in cardiovascular death and MI. Not really in all-cause death, however, and also in significant improvement from an angina perspective. Therefore, it concluded that revascularization does lower cardiovascular death and MI in three-vessel disease, and it improves quality of life without really a change in all-cause mortality, but there was no increased risk either. So, what does the 2023 guidelines tell us about chronic coronary syndrome? Patients that have angina would improve, revascularization would improve their symptoms, and that's class 1 level of evidence A. Those are for all patients. In poor candidates for surgery, also choosing PCI over CABG is recommended to reduce major adverse cardiac events, and that's considered class 2A level of evidence B, which is non-randomized trials. How about left main disease? In patients with significant left main disease who have complex CAD, CABG is recommended to improve survival, and that's class 1. In patients that have significant left main, but you feel or it's felt that we can achieve equivalent revascularization, PCI is reasonable with a class 2 indication for left main to improve survival. And in patients with diabetes and left main stenosis with a low complexity CAD, PCI still is maybe reasonable, but it's considered class 2B. So for multivessel disease that are appropriate either for CABG or PCI, revascularization is recommended to reduce all these major adverse events, class 2A. But in diabetics, CABG and multivessel disease, CABG remains the class 1 indication. In LV dysfunction, if the LV ejection fraction is less than 35%, CABG is the indicated therapy to improve survival. So, where does the evidence, what is the evidence behind all these guidelines? I'm not going to present all this data, but these are the 4 major randomized controlled trials looking at left main disease, or PCI of left main versus CABG. And they were all pulled into this nice individual patient data meta-analysis published in The Lancet that took the Syntax, Precombat, Noble, and Excel well-known left main PCI trials encompassing about 4,400 patients and looked at the mortality. And if you look at the 5-year mortality between the two, there was no significant difference between CABG and PCI. And 2 of the trials went beyond 5 years up to 10 years, showing that actually at the end there's a catch-up phenomenon, almost they're superimposed at 10 years. However, if you look at the cardiovascular mortality and the Syntax score, which is the complexity of the CAD, then you see that they're superimposed on the left when the Syntax score is less than 22 or less. But when you reach 33 and beyond, which is more complex CAD, and we're talking left main here. So whenever you have concomitant complex CAD, the curves start diverging, and then CABG seems to be better as you reach 40 or 45 with statistical significance. That being said, in PCI, and we know this very well, and we have to be very clear and honest about it when we talk and suggest PCI in our patients, for left main, there is increased spontaneous MI, more than 2 times increase, and repeat revascularization when you compare PCI to CABG. That being said, there's also the expense of stroke with CABG, especially early on within the 1st year, but then that becomes attenuated over time. Looking at diabetes, interestingly, in left main disease, we know that diabetes is a bad disease, and if you look at the diabetics in the two upper curves, they have worse outcomes, but there is really still no difference between PCI and CABG when you take diabetics with left main. That's not three-vessel disease, that's just left main, and there's really no, like diabetes didn't pan out as being a problem whether you decide on PCI or left main. How about multi-vessel disease? Now, there are more data and more trials, but this is also another Lancet publication of individual patient data of 11 randomized controlled trials of over 11,000 patients, taking into consideration all the important RCTs. And if you look at it, there is a higher mortality in PCI compared to CABG, from 11.2 to 9.2, but those are left main and three-vessel disease. If you take multi-vessel disease on its own, it's actually even maybe a bit worse. So 11.5 versus 8.9. But if you isolate the left main PCI, then you see that there is really no difference between the two. That being said, when you look at diabetics and non-diabetics in three-vessel disease, you'll notice on the right when there is no diabetes, then there is really no significant difference in mortality. However, when patients are diabetic, then they definitely fare out much better with CABG versus PCI. We come to the most contemporary, I would say, and this is the 5-year follow-up of the FAME-3. We spoke about FAME-2, but FAME-3 looked at physiology-guided PCI and CABG, 1,500 patients with preserved or not severe, excluding severe LV dysfunction and excluding left main. It showed that even though, if you look at the upper graph here, for all major adverse cardiac events, it was not statistically significant. And then when you look at the first year, because this is very important, because the 1-year FAME-3 data showed that CABG was better than PCI. However, if you exclude the first year, where there is increased revascularization and MIs, there is really, the curves are almost superimposed. So even with the most recent contemporary data, there is really no difference between PCI and CABG after beyond 1 year, and there was no difference in diabetes. Interestingly also, the only thing that would differ is the intermediate syntax where CABG is preferred, but whether low or high, maybe because of the numbers, it didn't really pan out. So severe LV dysfunction, you might have heard of the STITCH trial, which is a CABG for LV dysfunction. It took 10 years for us to show that there is a better outcomes with CABG over medical therapy. How about PCI in LV dysfunction? So this is the revived BSIS-2 trial. You might have heard of it as well. Half of the follow-up, maybe only like most patients are at 4-year median or 3.5, with the half number of the STITCH trial showed really no significant difference. Is it better optimal medical therapy? Is it still early for us to see the difference? But that's based on that, we still cannot recommend PCI for LV dysfunction. So other points to consider is that PCIs are improving more and more, and we know that use of intracoronary imaging, which was never studied in these trials, does improve outcomes. Bifurcation PCI strategies also differ, so the outcomes also might be different, and we're underpowered to detect that. 3, the completeness of revascularization. We know that the more complete revascularization, the better the outcomes. But in randomized controlled trials, complete revascularization is achieved only about 50% of the time, whether it's CABG or PCI, and in real practice is actually closer to 1/3 of the time. This is a nice, busy slide, but I came across, recently published, of the trials comparing CABG and PCI over the past 2 decades. And if you look at the earlier trials, there was a lot of trials that favored CABG. But when we moved into the more recent trials, we see that a lot of trials not necessarily favor PCI, but show no difference. Not only that, but even the ones that showed initial favorism for CABG, with time as we continued follow-up, such as the syntax and the FAME-3, we saw that PCI became non-inferior and probably similar to CABG. There are 2 different therapies, of course. PCI has a lot of early advantages. It's less invasive, fewer procedural complications, so less strokes, less large MIs, less atrial fibrillation. CABG, on the other hand, is more durable with fewer adverse events, at least within the first year or beyond the first year. But ultimately, there is really no major difference in long-term survival, MACE, which is the composite of death, large MI or stroke, and or quality of life. So the approach should be patient-centered, and patient preference should be taken into consideration. There are other psychosocial and maybe even, I would say, cultural factors. So what is more important to a patient? Is it death or is it stroke? For trialists, of course, mortality is the thing that we look for, and we all talk about is all-cause mortality and cardiovascular mortality. But for many patients, if you ask them, about stroke and death, they would rather die than have a stroke. Other things such as the interruption of life, from 1 month to 3 months, there's a lot of life will be on hold. People that care for families or have their own small businesses and things like that, that might be a major issue. We know that actually even rates of depression within the first year after CABG are higher than PCI. And there are faith and beliefs. You talk to many patients, you talk to a 70-year-old and tell him, we would do CABG and give you like another 10, 15 years. And he would say, دكتور يعني أنا ما أبغى إلا أروح المسجد وأرجع. So they only want to go to the mosque or do very, very minimal things. So then you have to take their preferences into consideration. So I'll conclude. Take-home messages. Complete revascularization does improve outcomes in acute and chronic coronary disease, pre-vessel disease. Multi-vessel PCI outcomes are comparable to CABG in the absence of complex anatomy, diabetes, and significant LV dysfunction. There is certainly risk of repeat revascularization and spontaneous MI in PCI compared to CABG. CABG is certainly favored in complex disease, diabetics, and LV dysfunction. And approach should be patient-centered, and the heart team should be at the heart of the decision-making. And thank you very much.
Thank you, Ali, for this overview. Of course, this is approach to multi-vessel from focus on a PCI from interventionalists. Just to be fair to the group, I think there is another strategic approach to multi-vessel from a surgical view also to balance this. As you concluded, the heart team is very important, crucial here. So we end our session now with a final talk by the role of the heart team in contemporary clinical practice. It's going to be presented by Dr. Walid Al-Harbi from King Saud University. Dr. Walid is the director of Cardiac Center, and he is the president of the Saudi Intervention Society. Welcome, Mr. President.
Assalamu alaikum jami'an. Thank you for the invitation, Dr. Faisal. Dr. Faisal is a teacher and a mentor of mine, and Dr. Khalid the same. We worked all in the same center in Calgary. So I'm going to talk, usually we say multidisciplinary heart team approach. And before I start about the talk, I'm going to ask a few questions. Show of hands. Who is happy with his own institution heart team discussions? Okay, very good. Okay, and the next question is that who does voting during the heart team discussion? Okay. Third question is that who does shared decision making in the heart team discussion? Okay, so those who raise your hand. So do you bring the patient in the heart team discussion? Or you assign one from the heart team, goes to the patient and tell him the consensus of the team? Second? Okay. Okay, good to know. So I'm gonna give my opinion. It's not representing King Saud University, it's not representing SASIS. It's pretty provocative, but we'll see how things goes. So a heart team concept evolved. Actually, the conception of it was during the syntax studies and also in the TAVR trials. And based on that, they developed the assumption of the team-based care. And the heart team is about a surgeon, which before this, the surgeon is the gatekeeper. Actually, he decides, and in addition, he says what's modality of treatment should be. And since that syntax study, things changed and developed more comprehensive heart team discussion between a cardiac surgeon, interventionist, and general cardiologist. But you can see here in 2013, the patient was not part of it. It's not part of the shared decision making. They tell him, this is what we decided, you're going to go for that. And then things evolved over time where the shared decision making process happened. And then with time, now we are at 2025. We can see the team got bigger, more expert opinions. You don't have only the three members. Actually, it's becoming more experts in the team. The question now comes is that you have many experts. You're going to have a better judgment with everyone input expertise. But that works when it is not a crisis setting. But if in an emergency, in a crisis setting, that doesn't work. You want one chair who really make that decision process. And it's not only coronary or structural. There is multiple teams. You can see with time, the value of heart team, multidisciplinary approach, evolved in every aspect of cardiology. Cardioobstetrics, shock teams, coronary, peripheral, transplant. So you can see these time evolving with the concept of a team approach. If you go further, that things got better, that now you can do it even from your office or home with a metaverse where you see your angiogram in front of you, echo on your right side, the left side. You have all the clinical data of your patient, and it's already been developing, and it's going to come soon to your institution. So it's a process you go through from assessment. You have a very standardized structure where you're going to be presented. You present it to the team and the core team and the heart team. Based on that data, they make a clinical reasoning, you make a decision, and then you go to your patient and tell him that's what the consensus, what do you think? Then you develop your shared decision-making process with your patient, and etc. So your ultimate goal of the heart team is patient outcome. You want to do the best outcome for your patient. And that's what we want to do. And in our institution, when in 2020, I realized there's variation in how we communicate to the patient about it, and who are in the heart team should be as a minimum essential members. And we made a decision that really you need to have exactly what it, very specifically, without any compromise with this minimal data information, should be documented in case you change decision after discussing with the patient. So we assigned who we're going to be, and what is the outcome of the plan from that, and how we're going to notify that patient. So this is all good and well, and that's what we do. And is this the best thing? The issue with this is that we are really improving processes, but are we improving outcomes? Slides are not clear, but there's a lot of elements of each and any quality improvement to see how you're doing. And beautifully said by Dr. Faisal. But all the studies that have been published about heart team, it's about processes, but not correlated with outcomes. Do we have any RCT evidence of heart team discussion, multidisciplinary discussions approach is valuable? We have none on outcomes. We have in processes that is not randomized, but this is a study where they look retrospectively between a heart team versus interventionists. As mentioned earlier by Dr. Ali Shihri, that we're biased with interventions. And the study showed about 30% discordance between the heart team decision and the interventions by itself. So tell you the value of heart team. And for the heart team approach for complex, usually with validated risk scores like syntax, we have a different score tools. It really help you in making that decision. And then came AI. And AI, very valuable in helping actually to be part of them of your heart team now. And ChatGPT, they did the study, and actually it's almost as it does as good as a heart team. If you train the training method of the model is this is based on the old even LLMs. And the newer one, the training methods that Meta developed recently actually make it very accurate and more faster even to learn and become more accurate in the heart team. And this is a recent study that it published in the European Heart Journal Digital Health, and they looked at the different prompting techniques with ChatGPT, and actually it showed it's equal to heart team, more favoring surgical approaches and coronary compared to intervention. So the heart team plays a central role, not only on coronary, it can be in different aspects of cardiology, to provide most up-to-date and informed treatment recommendation through multiple expertise of the team. But the challenges that we're facing now is that we don't have any evidence that showed outcome favors multidisciplinary heart team, and that's a research gap. We don't have a best practice how to conduct a heart team discussion. If you have conflict between members and there is no consensus, how are you going to approach to the patient? How are you going to tell that to the patient? There's more scenarios coming out, more complex, more, it depends on the expertise of the center, and when to say, you know what, this is my limit, I have to refer to another institution or not. That's another challenge of the heart team if you rely on it or not. And we have three things: the clinical profile, the new technology that's available in your institution or in the country, and what is the evidence-based validation of those interventions. And that's what the heart team tried to incorporate. And when you try to determine the benefit risk for your patient, it's not easy. You have multiple cognitive biases that you're going to face, in addition to the patient biases, what is the best for him. And that's what I think AI will going to come. It's going to really close that gap. It's going to try to have the better benefit based on a large data with the least risk based on the ongoing data as a pragmatic randomized trial. And that's the shift in all AI solutions, is trying to be dynamic on analyzing data and learning and trying to develop a constructed decision-making so it even gets better than the heart team as a whole. Not only that, there's coming a simulation, like in airplanes. You simulate your trip. You predict what weather is going to happen. If it's going to be bad, how are we going to do? And that's what's going to come. And the DASI simulation is very accurate, is now even reimbursed in the US FDA to help you in your decision making of what is the risk possible for the patient and what is the best for him, whether surgical or percutaneous, for example, in a TAVI patient. You even can predict what are the stress on the leaflet, on the aorta, with a finite element analysis assessment. So all these going to be incorporated. Clinical tools to assess, predictive simulations, all going to come together, and I believe in the coming years it's going to even be better in deciding compared to heart team discussion. The issue is that the one who's presenting the case in the heart team, who knows the patient the best, have better perspective than people on the phone or virtually or they haven't seen the patient. and that decision making might be compromised. For example, in a frail patient or with multiple comorbidities, sometimes it's said on the meeting that it doesn't seem that bad, but if you see the patient, you change your mind. And that's where I believe the time will come, the patient going to be part of that heart team discussions. There are scenarios that heart team approach cannot be inappropriate, and the most important thing is in a crisis setting. You don't want to get people, because you're time sensitive, to make a decision. Sometimes you really, one person make a decision if you're really have in a time sensitive situation, and a patient in shock. Sometimes the shock team even, I'm not sure about how helpful in emergency situations. So think that not always a team discussion is good, the best thing. It's a good habit to do it, but in crisis setting, do not rely on getting all the team and delay things. And it's better that to develop dynamic, algorithmic approach, and that's what's going to come with AI. It's going to help minimize the confounders and the decision making and cognitive biases. And the heart team approach, as usual, where we try to develop a standardization, and that's in every institution, try to do that the best. And at the same time, until evidence comes out, develop methods to be a construct and how you conduct your heart team. It's not easy, but it's doable. You can emulate what happened in the business meetings, in the boards, where they have standardized how to make decisions, what is the minimum data set you should be discussed about, when there is a conflict, what you're going to do. And that's what I think the future of study is going to come, and AI, we're going to remedy that. And this is a good approach. I'm not sure it's not clear on the slide, but there's a 5-step approach that I can share with Dr. Faisal later on to spread it, that how to develop a structured heart team construct to discuss about any case scenario that you're going to face with your patient. Thank you very much.
Thank you, Dr. Walid, for this excellent talk. Now we have question and answer and panel discussion. Please, if there's mic around, run. May I start with commenting on Dr. Walid's very nice elaboration about the heart team. And I think, as you mentioned, there is a variation in heart team in different centers, nationally and internationally, how to proceed it. And there is multiple influential, but I think you also added in the heart team, you need to know your local data and your local expertise, the surgeon, the interventionist, and the other. But because this is a factor, not because a Cleveland clinic surgeon did this and his outcome, you implemented, you replicated in your center. And I think that's very important to collaborate, because as you stated right, you have to the patient in the focus of all our discussion and the patient. In our center, that the treating physician, he's the advocate for the patient and he's the one making it. The heart team discussion is an additional information for him, but the treating physician, usually he go with the decision, he go with the surgeon and interventionist together to discuss the outcome of the meeting because we don't want the interventionist bias. He tell him with just simple procedure, and the surgeon, he will cut your chest, and you know how to be present to be both views and both presented to the patient. So with that, Dr. Muhammad.
Just to have a comment for Dr. Faisal, talk about benchmarking, and I think it's a key for centers to join those registries, because you need to know where are you, and then always improve your outcomes. And the good thing about these places, and they benchmark against like 150 heart institutes in the world. And actually, Dr. Faisal, we joined actually since July STS for pediatric and adults, and also for NCDR for cath and heart failure. And I think it's a key for all centers to join those. It always helps you, and even with minimal things, if you could say that your patient stayed 2.2 days, before, if you don't know, if it's 3 days, you think it's fine. But now you know actually 2 days is less. You need to actually go and improve what are you. Sometimes it's actually minor changes that helps you to discharge patients. I have another question for the heart team, for Dr. Wali. This is excellent. But I still believe that heart team and discussion, multidisciplinary, is a key, even in emergencies. What we have done even over time using virtual, sometimes middle of the night, if a case come, they actually send an email or text, and whoever is actually around will join the discussions. And I think that the decisions that comes from multiple teams is always better for patients.
Okay, Dr. Abdullah.
Thank you, Dr. Waleed, for this excellent lecture actually about the heart team, which is, again, different standards. The artificial intelligence, you talk about use of artificial intelligence. Nowadays, patients also have approach to ChatGPT that can get the opinions from the also artificial intelligence, and they come to you. I have seen recently one patient who went through artificial intelligence, ChatGPT, and he is coming and say, they advised me cabbage in other center, but the ChatGPT told me it's possible to do BCI. So again, the concept of addressing the options to the patient, I'm in the favor of having every doctor, the intervention should talk to the patient, and also the surgeon talk to the patient about the both approaches, especially after the heart team, because the patient might not accept the heart team decision, and he might have different opinions. So how to address that? I think the surgeon should talk to the patient, the intervention from his point of view, or the attending physician, and then you come up with the best approach to the patient.
Good, thank you. We have a question there.
Thank you so much, and thank you to all the presenters for a fantastic series of presentations. My name is Dr. Anam Khan. I'm based in Toronto. I have two questions, or one question and one comment. The first is for Dr. Faisal. Thank you for sharing the registry. I'm wondering if there's perhaps now or in the future any plans to connect the data in the registry to patient-reported outcomes, whether they're specific to cardiac care or more broadly like SF36, more general sort of patient experience data. So that's my first question. And then my second question is for Dr. Waleed. One of the areas that I work on is interprofessional collaboration, and I absolutely agree with you that multidisciplinary teams are the future of healthcare. And I think there's lots of ways to measure that collaboration that can be borrowed from other areas. Primary care is a very good example. And would 100% agree with your comment that the patient is the North Star. They have to be guiding they have to be at the core of decision making when it comes to multidisciplinary teams, because really the care is about them. Thanks.
Okay, thank you. Dr. Faisal.
Can you hear me?
Yes.
So this would be our dream, to link it to the patient level data. I think we discussed data yesterday. This would be the next step. But at this stage, as Dr. Al-Aklabi was mentioned, we are at a stage where individual center does not know how they are doing. So even within Saudi, because this has been a rich discussion yesterday about data, all outcomes, all therapy are based on North American data for all outcome measures. We do not know how we are benchmarking unless we have real data over the next couple of decades. So I agree with you, this is our dream, to drive this to the patient level data.
Dr. Waleed, do you have a comment? And give the mic to Dr. Waleed.
I totally agree with what you said. It's just I wish we have a construct in how this discussion should be ran. And I think with AI, it's going to help us to try to bridge the gaps on how we really make it systematic and consistent, whatever the center you are and whatever the expertise of that center.
Dr. Faleh.
Thank you very much. Again, very interesting discussion and very needed, actually, I think, initiative. Dr. Waleed, I don't think it's difficult to create, policy, regulations, procedures, but the most important is to have your own data. And this data has to be validated. This is the only convincing way for the team to participate and to let them agree. Otherwise, all what we do now, honestly, it's very much based on publications from North American or European, which is the only source that we have now. But we have same clinicians competencies, but we have also very different patients. Therefore, I think building our own data, validating this data is the key. I want to add one more thing. KFUPM signed strategic agreement with Johns Hopkins, and this is the product of this agreement. And we had a meeting with the president and the vice president for innovation and research, and they clearly stated that they are willing to support any impactful initiative. I do believe this is your time and this is your best chance to get, because they have very smart engineers here. KFUPM is top-ranking university, smart engineers. I am working in medical device, which is very high complex device, but they are contributing in very strong way to this device. So I really encourage, taking this initiative to implementations and, starting by Johns Hopkins Hospital, combine maybe other centers that they can take this to, I think, reality.
Great. Dr. Ryan?
Thank you, Dr. Khalid. One comment, one question, one initiative. So the comment is regarding the AI and the dilemma of the patient, and actually we have to differentiate between different modules, like the large language modules that the patient is used, and the other, what we should use, which is the big data learning modules, which is really giving a different answer. The question is, as a senior and center director, Dr. Khalid, the dilemma of the heart team discussion, like the team discussed and they finalized with the one suggestion that the cabbage is better for this patient, then the patient for any reason he refused, then the other option is the PCI. But in your opinion, that the PCI is not the best for him, you proceed and do what the patient wants, even if you are not believe that is the best for him. The suggestion in relation to the heart team, and being that you initiate EPIC years ago, in the Eastern proven, actually not all the centers have all the part of the heart team. For example, we are on the Royal Commission. We used to get help from Dr. Fahd Makhdoom and other colleagues to initiate a heart team. Why not to have a heart team which is actually representing the region, the area of us as a part of EPIC? Thank you.
Thank you. I think as illustrated by Waleed and all the others, I think the patient should be the core of the heart team, and his wishes is well respected. You tell him the options of the heart team, and then the patient has the right to say what he wants. But provided that every views was presented to him in the right way. And then I don't think it is wrong that you go with the patient wishes, even if it's not with the heart team opinion. And I want Waleed comment on that also. But it's a great initiative if we have like a regional heart team with a wider experience to see.
So patient preference is really not easy in the shared decision making, and that's why even a field that developed addressing that issue. For example, in coronary, we might be not an issue, but for example, in TAVI, a young patient comes to you and said, I'm not going to go for surgery. Is he going to say patient preference? He can't. So that's the issue, and that's what the research gap, and I believe Dr. Fahd comment about if we can develop an alliance between Saudi Health Council, the National Center for Health Registries, they have a center for that, and a mandate, and collaboration with Saudi FDA regarding devices, and collaboration with, for example, Saudi Heart Association to lead this data registry, and also is going to help us in developing AI models that help us in that decision making. And we come to the patient. For example, you mentioned about ChatGPT. Now, it depends on your prompting and how you prompt it and what is the data you put it in. And ChatGPT will not take over medicine. I think it's going to be another application called precision medicine, but it will come. It's going to facilitate the decision making for us. For example, the DAPT score is going to be incorporated in the patient data to make what's the best antiplatelet duration therapy best for the patient. But shared decision making is not easy, and I foresee that AI going to be part of the heart team, and the patient going to be at the center of that discussion rather than waiting for the outcome of that discussion.
But again, Waleed, as we mentioned, when you say the patient at the center of the heart team, what to do with this patient that say not for surgery? What are you going to do with him? You're not going to do nothing for him?
That's what I'm saying. It's a very difficult. We
I
have no guidance. And that's the issue. The guideline doesn't address it. There is no evidence research on that. What is the best process to do that? That is best for the patient outcome. And that's the major research gap that we have.
But the
I don't want to say my personal opinion.
Patient wishes is the center of that discussion, should be. You agree with that? The patient decision and his wishes should be in the heart team.
I don't agree with that because he's limited with data. His decision based on what he perceives. It is incorporated, but it's not the sole decision maker.
But that I'm saying,
I had patient come to me in private, 35. He said, "No way, I'm going to go for surgery. Severe bicuspid aortic stenosis." Would you? 3 surgeons saw him and still insisting on TAVI. Would you do it?
So what do you do with him? You tell me what you do.
I refused to do it.
So
it is harm to him.
So what are you going to do with him?
That's the reason I'm giving that talk, is that we still have a gap in how guide us in those gray zone of decision making with the shared decision.
Good. Hamid.
Just a quick note on the, when we say shared decision making, is based on informed consent.
That's right.
Informed consent, to transfer that informed, status to the patient, we should be informed ourselves. And in the lack of data in our patient, okay, in terms of their tolerance of surgery, even actually potential survival, comorbidities, okay? We don't have the data. So we just compare our patient to a totally different population, totally different health parameters. Up until that moment that we get our own data, it will still be difficult actually to know what to do.
Great. I will, final question to Faisal about the DCF. Faisal, now, as you know that the data what we got is about, as you mentioned, garbage in, garbage out, about the accuracy of the data, validation of the data. How you assure that in your center to do that?
That's an excellent question, and that's why I highlighted, if you want to use the data for outcome measure, it has to be a clean data, and that is the job of the whole team, not me. There are data manager, there are cath lab technologists, and whenever we receive the report and we see an abnormal finding, then we dig deeper in each MRN number and see whether that is actually reflective or not. And the NCDR or any registry should give you the chance to correct according to a correct data and probably adjust your data. But my observation, for example, for most of the quality metrics, unless you feed it a good information, it's going to fool you. Either you are doing very well or probably you are doing very poor. So it all depends on how you give the correct data.
Great. So I think we are...
Can I just ask a question about that? So I think it's great to improve our outcomes, but do you feel or do you think that there is a potential downside of you trying to, one, maintain or kind of avoid these risks? So you will really select, refuse, for example, taking on complex cases. What you mentioned about the AKI in contrast to nephropathy, anybody who has a creatinine of 130 would, oh no, let's not do him. What I'm trying to say is being potentially risk averse just to try to do that. Would that be an issue that you encounter?
I think that's an amazing question. I'm not going to take a long time in answering it, but I could tell you one thing. We have to look at it from our perspective as an operator, because unless you have a tool to tell you how you are doing, you're probably going to take on high-risk cases that should not be taken in the first place. And in the same time, if we do not have this tool, low-risk cases that you are not doing very well, probably you're not going to know how you are doing. Correct. So this is an important thing, because your administrative can come and say, oh, this quarter your mortality is 4%, but I took a 90 years old with an anterior STEMI, I took a left main disease. That is a valid concern, but I still believe this tool is the most important for us as an interventional cardiologist to tell you how you are performing and how you're benchmarking.
But I think those is also risk adjusted. So you know what they are. If they're high risk, it tells you it's high risk. So all the risks are actually included.
With that, I think we're half an hour behind the schedule. I'd like to thank all the speakers, the 8 speakers. I'd like to thank the panelists, and thank you all for staying. And as you see, for the discussion is still diversity debate about it, and that's why we created that discussion. And I'd like to thank Dr. Faisal, and also, and I think the conclusion, we have to have data, we have to have our local data to make our precision decision. And that, with that, thank you, and I think we are going to have a break now. Thank you very much.
Hello, everyone, and welcome back. I would like to thank Dr. Khalid and all the moderators and the panelists and the speakers on the previous discussion. It was such a thought-provoking discussion. I'm sure we all can agree on that. We're going to move on with the same topic of coronary artery disease. I'd like to welcome our next moderator of this session, Dr. Khalid Al-Garni. Dr. Khalid is the head of the Cardiothoracic Surgery Center at Johns Hopkins Aramco Healthcare. Joining him are our panelists, Dr. Mohammed Al-Akthabi, who is the CEO of Prince Sultan Cardiac Center in Riyadh. He is also a cardiac surgeon. Dr. Fahd Maktoum, the director of the cardiac surgery at Imam Abdul Rahman University. Dr. Ricardo Lima, he's a professor of cardiothoracic surgery at Pernambuco University in Brazil. And Dr. Walid Abu Khair, unfortunately, will not be able to join us. Replacing him will be Dr. Fahd Diaby. Thank you.
Thank you very much. Good morning, everyone. It's my great pleasure to welcome you in day 3 of HeartFusion. This session will focus on surgical revascularization of coronary disease, and we will cover some new advances in less invasive approach to coronary revascularization and robotic techniques in cardiac surgery. And then I'm going to discuss a topic about quality in cardiac surgery and the use of data to improve outcomes. So the first talk will be by Dr. Uthman Al-Uthman. Dr. Uthman is the consultant cardiac surgeon at King Faisal Specialist Hospital in Jeddah. And he will talk to us about the use of a robot for cardiac surgery procedures and the recent advances and recent outcomes with this new technology. Dr. Uthman.
Thank you very much. Good morning, everyone. It's a pleasure and honor to be here. I would like to thank the organizing committee for the kind invitation and thoughtful invitation. And I would like to congratulate you for having this merge between both brains, between the King Fahd Petroleum University and Johns Hopkins Aramco. And I think this is the start of great collaboration. So congratulations and wish you all the best. My disclosure, I'm a surgeon between the interventional cardiology, so be nice to me, please. I'm not sure how many of you like to see TikTok or TikToker. I think this is the new theme now to see the TikTok. So I'm just flipping through the TikTok 5 years ago, and I saw this guy, he's doing this. I think we should do this every day morning, maybe. If this robot could do this, it is pretty dangerous. It will be the next one on the scene. Anyway, so the timeline of progress in surgical robots, NASA is the first organization that they took care of the robot, and since then started to invade the medicine. In 1983 was the first robot surgical suits used to move the patient limbs into position during the orthopedic surgery. And the future continue to do that one. You cannot be sure how many surgical robots. It is a busy, very busy time now for the surgical robots. This is a very recent article from the Google Scholar. You could see in 2025, there is more than 1,195 organizations that or universities around the world investing in robotics. So this is very important to see. In the past 5 years, almost 40 companies per year, but this year, 100 companies per year. Last year, 2024. The 51 addition in the past 6 months, it was 13 in the vascular, abdominal and thoracic, orthopedic, percutaneous, lung, neuro, spine, cardiac, GI, everything. 23 in China, Japan, Korea, everywhere. So this is a very rich area for improvement. And how they work, some of them autonomous, some of them pre-planned, some of them is teleoperation. And you could see here how things going up. Thoracic is going up and higher, and there is a lot of investment in this area, and I think it will continue. The first surgery was in cardiac was started in 1998 by Fred Moore and his colleague doing TCAP, and then kept going for TCAP all the way to the mitral valves. This is how it looks like. It's a busy slide. You have a robot, you have a lot of people around you, you need a lot of people in a robotic room. What's about the robotic in cardiac surgery? The role in robotics, there is a systemic review. The CABG, mortality and morbidity, it's almost major, and it's almost equivalent to the conventional CABG. Adaptation from the STS surgeons, the study of the society showed that there is no difference between both, comparing that. So how did we start our program? There is always 4 levels of minimal invasive surgery, level 1 to level 2, level 3, and level 4. So level 1 is direct visions, level 2 is video assisted, and then after that you go to the robotics things, and you could cover all the types of that one. What's the success dependent on? I would like to thank my president's colleague in talking about that one. Patient selection, heart team approach, adequate training, availability and technology devices, and the personal technical capacity which comes with time. The important technical aspects is the learning curve, the cannulation and type and strategy, aortic clamps, and myocardial protection. If you do this one, then you will be good. It's one of the old pictures of our program when we started back in 2016. You could see how we did that with the endoscopic, and then we treated multiple pathology with that one, either mitral, CABG, double valves, and all of those things with a good success rate. I will not go over this one. Then we went on more to the video assisted with the micro incisions. We applied this one in the same way, and we published our data about that one, and all minimal invasive with the 3D endoscopic thing, even the tumors in the heart. We do that one, and we kept pushing the envelope for that one. This is one of our OR nurses that she came complaining with this shortness of breath and sudden fall in the echocardiogram, found that she had a huge big mass, which we resected that from the heart through endoscopic approach. I will not be this. We went on, and we did even more complex ones that endodors, and then we come to the robotics, which is the level 3. So building the robotic program has go through 10 or 15 commitment that you have to do, creating the business model, convincing your higher authority, create the business model, convince them, get the program in. After that one, you go to clinical pathway meetings, and it is very, very important to have everybody on board. Cardiothoracic surgeon, the perfusionist, the anesthesiologist, the cath lab technicians, the OR, the imaging specialist, the OR techs, interventional cardiology. If you don't have a good intervention cardiologist, or you don't have a cardiologist on board, then it's a game over. Don't do it. Clinical engineers, that they have to be on board. Online and on-site training for whole of your program, or for whole of your people in the programs. The inventory and the robotic and non-robotic instruments, the basic training at sites, consecutive day, and the clinical independence. And we started the program a long time ago. The advantage is the quicker recovery, no cardiopulmonary bypass, and better precisions. So this is one of the patients that we see quite often in our practice. 67 years old, non-diabetic, not hypertensive, present from outside hospital with the chest pain, CTO, LAD, and the tight distal LAD. And this is RCA I meant. So you could see his coronary angiogram. Majority of the places, you could see the retrograde filling of his LAD. maybe majority of the places they would do cabbage conventional with the conventional way for both of his arteries. So what we do for those patients, we do them as a hybrid technique. We position the patient in the same positioning. And then after that, we mark the patients and we do the docking for the robots. Not sure why the previous one did not work. Problem, I don't have here a mouse. Can you have this one working or? Maybe this one, the second one, maybe it work. So we put the 3 ports, same as we marked them before. One in all of them in the one line, the anterior axillary line. One in the 2nd or 3rd intercostal space. One in the 7th intercostal space. And one in the 4th intercostal space. We put them under vision for all of the ports. And then we start harvesting the memories, but before that we remove the fats up top of the heart to clean more area for your anastomosis and for area that you do. We identify the LAD here. In the recent days now, more recently in the last 2 years, we start to do the BIMA. So we start with the right coronary artery, and then we go to the left. We start with the right internal mammary, and we go to the left. Now, after harvesting the lima, we open the pericardium and we see our targets. And then you could see the needle on the top of corner of the video that will tell us exactly where we are on top of the LAD or our targets that we see it pre-operatively with the CT scan. Then after that one with the small incision, we do our either lima to LAD or BIMA. So we bring the lima to the LAD and the lima to the OM through this small incision without chest spreading, and with the, you could see here, all is the same instruments that we use in doing the regular routine cabbages. So and the robot would facilitate how you harvest both the lima and the rima, and will just put you in the right spot to do this one. And the reason that we don't do it immediately with the both robots is because we don't have a stabilizer. So the companies, they did not invest in doing the stabilizer for the coronaries. That's why we don't do it completely with that one. But with speaking with the engineers and all the people around, I think we might be able to do this and bring it back in practice. Here you could see the stabilizer. We bring it from outside. Unfortunately, we can't have it robotically. And then we find the LAD here, and we do our anastomosis from the rima to the LAD, and then the lima to the obtuse marginal. By that way, we do the 2 coronary artery, and still we have one if we need to. This is the previous patients. That's what we did. So his lima to LAD is tested, and this is the routine stuff that we do to all patients. Is before they get home, we do the complete revasc plus the lima shot to make sure that all of the patients had a complete revascularization. We published our data on the first 260 patients with the robotic assisted cabbage, and we had this diagram, how we bring that one. We do the stable coronary disease, the acute coronary disease. We discuss them in our heart team meetings, and either we do it forward robotic or backward robotic. That's mean after stenting. The results is pretty much matching the international benchmarks, and we did not. And with time, even we take more complex patient with the grade 4 LV function. Majority of them had the PCI to the RCA and sometimes to the circ if it's a small one, with the low out mortality. Our 5 years outcomes will be published very soon, and we're looking at the 10 years and 6 months from now. About all the patients, we surpass around 500 patients, The quality of life has been published in the innovations, and their quality of life is much significantly improved. We went on and we start to do the left main coronary with the robotic assisted cabbages. We had over 50 patients in our series with good results, but the most and the key success for those patients, discuss, sit with interventional cardiology and move forward. Obesity outcome, they said the obese patients, sometimes they don't get benefit from the robotic surgery. There is no difference between both, but we've done that one and we had the good results. There is no this comparison between both groups. Women's, with the robot, how they do? They do better. We had our patients compared with the risk-adjusted patients between robotic hybrid and the conventional cabbage, and they do pretty well. Less blood transfusion, less ICU stay, better outcome, and better cosmetics for them. Cost effective, always we've been criticized that the cost of the robot is extra, but we manage this one through having less instruments in the OR and less hospital stay, no ICU for those patients, except if we have bed situation. We had this one even for redos, and we use the robot for redos. Now we start to do with the hybrid, with the structural hearts. So we do robotic to the LAD and the non-LADs, the lesions, and we do the TAVI for the patients who had a problem with that one. And you know, it's the most critical disease. You have the severe aortic stenosis plus coronary artery disease. So we do have our series. So where robotic technology is going, I think artificial intelligence, it will be the second one, amalgamated in this one. So there is no turn back. Mix and robotics represent the future of surgery. Technology will continue to evolve, and we should be embarking on this one as soon as we can. Don't forget to join our Gulf Society of Cardiac Surgery. You will see a lot of innovations. It will be the annual meeting in December in Dubai. Thank you very much.
Thank you, Dr. Uthman. Great presentation. The second presentation is by Dr. Mumin Abayazid, and he's talking about innovations in motion, robotic techniques for safe and effective heart surgery.
Okay, good morning everyone. My name is Mona Bazid. I'm working in KFUPM. My main specialization is image-guided robotics. And until the slides are ready, I'm going to give an introduction about how I think robotics are developing by time. So I'm going to focus on image-guided and also AI-guided robotics for medical applications. I'm going to focus on minimally invasive surgery, but afterwards I will also get into more cardiac applications.
You can't control the slides from your...
The slides are not visible. Okay, I will continue. So unfortunately, you cannot see my slides until now, but we'll see how things will go. So surgical robotics is not only about accuracy. So robotics is not only offering accuracy to the system. So robotics actually, through robotics and AI, we are actually, instead of having the clinician in the loop but out of control, with giving them robotics and AI tools, they will be outside the loop but in control of all the subsystems there. Because you can imagine, you have visualization, you have images, you have assistants that you're dealing with, you also have a lot of tools that you need to communicate with at the same time, without also full organization of how things are going. But if we give the clinician more information and more organized way of communication through robotics tools, through AI of data, and also through precision diagnostic information, through also augmented reality and virtual reality, this will assist the clinician to do better performance and also reduce the cognitive load on them. I think it would be very difficult to continue without showing the slides. Okay.
You can continue the slides and until they fix it. If we have technical issue with this presentation, maybe we can move to the next presentation of what will
Yes,
be
I think we can switch order until this is
fixed. We can switch to the next presentation?
Yeah, sure. Sure.
Okay. So the next presentation is presented by Dr. Fahd Makhdoom, minimally invasive approaches in coronary artery revascularization. Dr. Fahd is a consultant and head of cardiac surgery at King Fahd University Hospital.
Good morning, everyone. I hope the presentation will be up. So, Assalamu alaikum, everyone. Good morning. I'd like to thank the organizing committee and my colleagues for giving me the opportunity to be presenting in front of you today. And I like the vibe of this meeting. I mean, it's something different that we're used to. Usually, it's more only medical aspect, but I think combining those two aspects in one meeting is a great way to head to the future. So my presentation is going to be about minimal invasive approach to coronary artery revascularization, mainly talking about total coronary revascularization through anterior thoracotomy. That's summarized by TC Rat. I have no disclosure. So I will, during the presentation, I'll just go through the journey where we, in our center in King Fahd Hospital of University, how did we adapt this approach and how did we evolve over the last 3 years. My colleague Uthman spoke about minimal invasive cardiac surgery, very elaborative, and so I'm just going to skip the slides for sake of time. This is the level of minimal invasive cardiac surgery as Dr. Uthman beautifully have elaborated. So again, we'll skip this. So I'm just going to talk about in minimal invasive cardiac surgery or minimal invasive coronary specifically, there is some risk and fear among the adopters that you have so many different things compared to conventional surgery. A small wound, different instrument, very long instrument that surgeons sometimes lose accuracy or control. difficult access and difficult setup, and different coronary anastomosis technique that will probably jeopardize the long-term patency and the outcome of the surgery. And this is what we care for the most. Beating heart and hemodynamic crisis, this is also something that most of the adopters have concerns about, and bleeding. If you're going through a smaller incision and you have some bleeding, this is usually a nightmare for the surgeon. But in reality, the only difference that you're going to see in TCRAT is that it is just a smaller incision. But you will use similar instrument. You will have access to all aspects of the heart to control bleeding if there's any catastrophe. And you are going to replicate all the conventional method used for conventional surgery or conventional CABG in this technique. I like to present, I like to start with this slide again, as my colleague Uthman mentioned. The heart team is very important, and to be able to perform very well in cardiac surgery, especially minimal invasive cardiac surgery, we have to imitate those similar team where they practice, and at the end they put up the show. And when you see a show like this, there's usually random or there's usually very little mistakes if it exists. So I always like to give this example, because in minimal invasive, as Dr. Uthman have shown, the room is very busy. There's many team members. Everyone has to do his job to have at the end beautiful surgery. So planning is the key to success. You have to select the patient. Depends on the program, if it's the beginning or late. Again, once you have some experience, you tend to expand the patient selection and include more difficult patient. Imaging is the key for selecting those patients, and then you have to prepare your cannulation strategy and myocardial protection and pain management. Pain management is very important in minimal invasive cardiac surgery. If the patient complains of pain, then I think we defeat the purpose of minimizing the access for the surgery. Patient decision, again, is depend on the stage of the program. So patient selection, it depends on the stage of the program. So whether you select easy patient at the beginning, and as you move forward and gain more experience, you tend to include those patients who are higher risk, difficult anatomy, difficult hemodynamics, and so forth. All of these patients get CT scan to plan for cannulation, examine the ascending, descending aorta for possible adverse or complication of peripheral cannulation. We study the peripherals very extensively to avoid complication with cannulation. Cannulation can be done either with open technique with the small cut down, or percutaneous if you are familiar with percutaneous or closure devices. I'll skip this one. So again, see the cannulation, as you can see, we adopted this technique. It's done under ultrasound guidance with the CT guidance, obviously preoperatively, it's, I think, for the surgeon, sometimes most of the surgeons will say cut down is easier and you can do it and blah blah blah. But I think percutaneous adds a lot, to be honest. I mean, it's faster. And we rarely have a patient complain of a groin incision, where in open technique, it is still an incision. There is some lymphatic disturbances. Some people will have some seroma and so forth. We adopt this now. We're doing percutaneous technique for all our cases, and it's been 3 years
we have probably, I remember 2 patients who had complication we had to cut down and fix the femoral artery. It's very easy to detect. The cannulation should be done under ultrasound and TE guidance to ensure the good positioning of the cannulas, arterial and venous. Decannulation has to be also with a good strategy. You time it with the heparin reversal for pump, and then you have to have your plan B for in case of if you need to go on bypass again, or if you had complication and you have bleeding, or you lost control of the artery. So we have our plan B embedded in our protocol, and now it's carried out by the team themselves. It doesn't depend on one single person. This is what the patient looks like on the operative table. So it's probably this at the beginning was around level 2 or 3 minimal invasive. So an incision between 6 to 8 centimeter, mostly 8 centimeter to be honest at the beginning of the program. As you can see, we planned the incision at the beginning at the 4th intercostal space. And then this is what it looks in women. And as a surgeon, and I'm sure the surgeon in the room realize how or knows how difficult to do a sternotomy or deal with a sternotomy complication with a large or significant amount of fat that's on both sides of the incision. So this is the again the incision that is done to complete to do the revascularization. It's anterior in the 4th intercostal space. After the incision is done, those are the instruments that we use, just a longer instrument than the usual, but nothing more fancy. We identify the mammary in the 4th intercostal space, then start harvesting the mammary. And as you can see, I think hopefully you can see it in the slide here. The mammary reach almost to the apex of the heart, so there's no problem with the length of the mammary if you divide it at the 4th intercostal space. The anastomosis, the pericardium is open in a usual manner, inverted T. Cross clamp is done from the left side, and then we apply 3 umbilical tapes to be able to position the heart for the anastomosis. I'll skip these technical videos. This is a video. This view is only recorded for purpose of presentation with the scope. So we don't. This is not the view we get in the OR. But this is just to present to you how do we actually access the the pulmonary vein and inferior vena cava to insert the umbilical tapes for positioning. And as you can see here, you have a standstill heart. You can reach all aspects to perform any anastomosis for coronary. So anterior, lateral aspect of the heart and inferior aspect of the heart for the PDA. And the anastomosis is done in the usual way. The coronary itself comes up to the heart. Sometimes in obese patient, if you do a sternotomy and they're deep chest, the OMs and some PDA will be very deep in the chest, and sometimes you need longer instrument to do the anastomosis. It's even easier in this technique. Proximal anastomosis are done through with the help of side biting aortic clamp after removing the cross clamp, and there's some tricks and modified technique just to measure the length of the vein graft required, but it is very easy and as well. This is the view we get to see through the thoracotomy for proximal anastomosis. And this is one of the first patients that we have. As you can see, it's around 8 centimeter incision, patient who had complete revascularization. Myocardial protection is almost similar to your conventional cabbages. The only difference that we had to cool a little bit more because the patient heart is inside the chest and not exposed to the room temperature. Pain control is very important. We spend a lot of effort actually to mitigate the pain because this incision is painful. So we always have those patients have some sort of local block to the nerve to mitigate the pain postoperatively. And at the end, we were successful with some paravertebral block to eliminate the pain to almost zero, especially in the post-op day 1 and 2, which is the most important period where those patients complain of pain. We introduced robotic-assisted minimal invasive CABG over the last year, and this has helped us a lot to expand our inclusion criteria. So we have reached now to almost 90% of all comers who come for coronary artery bypass grafting go through this technique because of the help of the robot, because the Achilles heel for the procedure was actually harvesting the mammary, and it is very difficult to harvest the mammary directly with very big obese patient or with female. It was more difficult, to be honest, because of the breast tissue. But since we introduced robotic assisted TCRAT, this difficulty have disappeared. These videos are, I think I have to give the credit to my resident, Noura, who have prepared these videos for her presentation. As you can see, so the incision is a little bit smaller because of the robotic assisted, so around 6 to 6 millimeter incision in the third intercostal space. Percutaneous cannulation stays the same as on the left side. You can see the robotic arms are ready to harvest the mammary. My robot is faster than Uthman, so you can see here it's going very fast, and the mammary is harvested at the beginning of the series. We used to spend more time, but now we're down to half an hour for harvesting the mammary, and then we open the pericardium, prepare the patient. After harvesting the mammary, the robot go on the side, and we continue on the regular way. And I'm sure you can appreciate the difference in incision. In the first half, it was a little bit bigger. 2 years ago, I looked at the incision, I thought it's small, and now I know it's big, and I get used to those smaller incision. Similar techniques, so just gonna fly through the videos. We apply the tapes, cardioplegia. The cross clamp goes through the one of the camera one of the ports for the robot, so no extra incision. Those are the tape that are applied to position the heart. Again, anastomosis are done in a similar way. You have excellent access to PDA, OMs, LAD with no issues. The mammary is longer, so and to be honest, at the beginning when I first started, I used to try to get a longer mammary, but now I just go to the 5th rib and stop, because it's usually more than enough most of the time. Proximal anastomosis done in similar way, side biting clamp on the aorta, and it's usually done after we finish the distals. As you can see here, we have excellent access again to the proximal because of the third space, so it's easier if there's any bleeding or anything, even coming coming off pump and the beating heart. You have excellent access to the aorta and access. And this is picture done post-op day 1 for the patient who had three grafts, and you can see the X-ray looks beautiful, no sternal wire. Usually the patients are very happy. Again, new frontier is that we go to totally endoscopic coronary artery bypass grafting. We need to invest more on probably an anastomotic device or stabilizer to be able to perform these procedure without any big incision. Thank you so much. I hope I didn't exceed the time. Open for questions.
Thank you very much, Dr. Fahd. Great presentation. We're going to move next to Dr. Momin. He will talk to us about robotic techniques for safe and effective cardiac surgery. And while we have his presentation prepared, if we can have Dr. Uthman joining us with the panel. And we will take questions from the floor about minimally invasive and robotic techniques. If you have any questions, we can take one or two questions. And I will start with the first question to Dr. Uthman and Dr. Fahd about the adoption of minimally invasive cardiac surgery, especially for coronaries. The adoption has been very slow globally, and even in the guidelines, minimally invasive, especially for coronaries, is still not getting a class 1 recommendation. So first, why do you think is that? And second, what can we do as a surgeon community to move the pace faster and improve the recommendations and the guidelines to try and make this a class 1 recommendation instead of 2A and some guidelines 2B recommendation? Dr. Fahd and then Dr. Uthman.
Well, I think that's a great question, Khalid. If you look at the history of minimal invasive cardiac surgery, we started at the beginning with the mitral surgery, and the adoption was also slow at the beginning in the early 2000 and 2006. For coronary, I think it's more difficult because, as you know, the outcome with coronary artery bypass grafting now is very good, and we're competing with PCI, right? So you really don't want anything to shake this outcome, and this is, I think, the wrong thought in the surgeon mind, that I don't want to change anything because I'm already doing good, and I'm being watched. I don't want to do anything that jeopardize my outcome. And I think what I've presented with the TC-RAD technique is the least change in technique for coronary artery bypass, because again, as I mentioned, the anastomosis is done exactly the same. You can use arterial graft, you can use radial, you can use vein, you do your proximal the same way, your distal the same way. And if you go systematic, there's always a way to be safe with this surgery, so you reach the good outcome. The uptake, I think, is growing very slowly in Europe and the Middle East, but I hope in the next few years we will see more outcome. And if you look in the literature, I think there are a series of 500, 600, 700 patients who have been published with similar techniques. Compared to the past, before this was popular, we used to see minimal invasive off pump, and this was very difficult, to be honest, to be adopted. So you see the uptake was very slow, but with this technique, I think it will change.
Go ahead.
Thank you. This is an excellent question. Two questions. Number one, guidelines. If you look at the guidelines 10 years ago, it was not even mentioned, the minimal invasive or the hybrid or anything. Now it is reaching to 2A and in the recommended in the Canadian guidelines. Number two, why it's not getting popular or something like this one, as Dr. Al-Koufi said, we need data. If you have data and you convince people and you have it a reproducible procedure that anyone could do that one, I think this is important, and this will push the boundaries to be more on that one. The third one, we need more research and involvement and for all surgeons, and having the heart team with the interventional cardiologist. That will make a huge, significant change.
Thank you. So we have two questions, Dr. Faisal, and then there. Dr. Faisal, go ahead.
So, because I don't want to take long from this time of the session, but this is a question that I want an answer from you, specifically from Dr. Mohammed. You run a cardiac center, so you are a policy maker. So if I am introduce a new procedure, whether it's a hybrid or the elegantly presented by Fahd, what will be the parameter that you will look for in order to mandate such a procedure, especially if you have long-term outcome to say the other procedure is benchmark for mortality, because now we need benchmark from STS for this specific procedure. And I just want to ask about the cost compared to the average cost, because the length of stay is the only thing. And again, I don't want to keep Dr. Mun'im, but this is something it's going to be important for our discussion about the adoption.
Thanks, Dr. Faisal, for this excellent question. But this is the key to adapt new procedures and innovation. I think all centers should persevere and push for innovation. So what we have done in Prince Sultan now, we had most of the cases, even valves, double valves with cabbage, is done by robotic or minimal invasive. And I pushed my team to do their best, and what we have done, we brought the expert from outside, and they joined the team for some time, and they trained and mentored, and then also we scrutinized the outcomes. So the outcomes should not jeopardized by doing minimal invasive. But this is how to push the limits and innovate. So every center, it's easy for us to do the simple procedure or the safest procedures, but it's always important to push the limits to do the best procedures for patients that will actually shorten the length of stay in the hospital, give them even better outcomes and with the conventional procedures.
Go ahead, please.
I am Ricardo Lima from Brazil. I would like to say just one small comment. First, I would like to congratulate the both colleagues for the brilliant presentation. And I would like to remember 40 years ago when I was a resident doing my training, my professor used to say, big surgeons have big incision. Now we changed the paradigm. Big surgeons, small incision. Thank you.
Thank you very much. Okay, so...
And if you don't mind, just to answer...
okay, Dr.
Just
Fahd,
2 minutes. I think for coronary, we can do many things to ensure, at least give you an idea that you have a successful, or reach a successful step, but not long term with those techniques, because you still have to wait for the long term. But we measure the flows on the grafts, right? We measure the flows in every patient, and post-operative, the 30 days outcome is, I think, gives you a hint if there is any complication that can happen, and this is what we've been trying to, and hopefully we'll publish it very soon. But we've been doing this, and this is what we've been. I think what will give you an idea, and for a policymaker or someone who will decide whether this goes or not, it can help.
Okay, Dr. Faleh, you want to make a comment before we move to the second presentation?
Thank you. Doctor, how many percentage of your patients that you did so far received only single graft?
Actually, I have the slide.
Approximately.
Single?
Yeah.
Single, well, very rare.
Very rare, it's okay.
Most of the patient, probably 60 to 70% of the patients are 3 grafts.
That's good.
Okay, so we're going to move to the second presentation now. Dr. Miming, please go ahead.
Yes, good morning again. And I think I'm a bit lucky that the previous presentation helped me a bit, because he talked about percutaneous procedures. And this is one of the main applications that I'm going to focus on. So this might save me some time. Yes, so as I was explaining, so surgical robotics, it's not only about accuracy. So robots is not helping us by just being more accurate only, but robotics is actually organizing things for the user or for the surgeon in this case to operate instead of being in the loop but out of control or have less control, with also a load of cognitive load on them, into having something that's more organized where the clinician is out of the loop but in control through tools. And these tools can be AI, can be haptic devices, robotics, and also VR and AR systems. And this is our aim. So actually, while talking to clinicians, normally say, okay, you're making robots that will replace us. But actually, that's not our aim. Our aim is to facilitate things to get the maximum output of the clinician because of their expertise. But what are the challenges in bringing robotics into clinical practice? Actually, there are many, as it was presented in the first presentation, that there are a lot of robotic systems that are getting into the market. But how much of them are successful? How of them could be used in several hospitals? They are not a lot. One of the things is the challenge of having haptic feedback. So while doing a procedure through a robotic system like the Da Vinci, actually, while you're operating teleoperatively, you do not have access to what you feel while doing the procedure. There is no feel there. You have something regarding the visualization, but you don't feel what's happening there, except only in the last version of the Da Vinci, so Da Vinci 5. This one includes force feedback. But you know how important it is to have force feedback while doing a procedure. And there were some adversities, some accidents that happens because the camera was not checking what's happening, and there was some excess of forces that was happening at some parts of the body. So this is a challenge that robotics system should have. Another thing is real-time visualization. So we might think that, okay, if you have a camera, then you have a real-time visualization. But some percutaneous procedures, you get, for example, CT or MRI images at certain moments, but not during the entire procedure. And this is also something that we need to consider while introducing robotic systems. And if we think about first time to talk about robotics, or what comes to your mind is actually, in factories and the fabrication of cars, you have robots, robotic arms like KUKA arms doing some stuff. But human body is different. We have a lot of things, dynamic things in our body that changes during doing some procedure, like respiration, you have heart motion. All of these things need to be considered while dealing with robotic systems. So we are not dealing with conventional robotics, we are doing it into some dynamic system like our bodies. The other thing is that while introducing robotic systems, we need to take into account the operation time, because you might think that the operation itself can get shorter, but the preparation, sterilization that happens beforehand, introducing a device, the registration actually between the imaging system and the robotic system, this all needs a lot of preparation, and also training the people who are working around the surgeon. So these are all challenges. Another thing is flexibility and adaptability of the situation. So let's assume something goes wrong with the hardware of the robot. What's going to happen? Is it safe to do switch easily into a manual mode or not? So there are several available systems in different fields. I tried to find some of the most famous in several fields, like for example, a Stryker for bone, and it includes robotics, includes AI for planning. Also for teleoperation like the Da Vinci, and also for tumor cancellation. It's also used a lot for eye surgery, because you would like to cancel the tumor in the operator's hand. And here I'm going to focus on one topic, which is the respiratory motion, which is specifically for the liver. So actually, during any procedure, if you'd like to insert a needle for percutaneous insertion, and you'd like to target a tumor to take it to take a biopsy for testing in the lab, or for ablation, you insert the needle and try to do cryoablation or any type of ablation, you need to have accurate insertion. But you get the image before the procedure, and then you try to follow a certain path based on the previous image to do the insertion. While in reality, the body is actually moving. And there is a lot of deformation that happens because of diaphragm motion that pushes the liver up and down, and it can reach even to 5 centimeters during respiration. This problem is well known in radiation therapy. So when you get a beam in order to target a tumor, for example, in the liver, this is a well-known problem, and they have ways to solve this problem. But for percutaneous needle insertion, this is not a well-known problem, and this is not actually commonly solved by robotics. It's solved by some practical things that I'm going to mention later. So this is, for example, what we learned from in radiation therapy, how they deal with this problem. Hopefully the video would run. Yes, so you see some markers are there on the chest of the patient, and they have a camera that tracks that, and they get 3D images of the part that's targeted part, and you try to localize the place where you would like to do radiation therapy. And after that, you synchronize the external motion of the body with the internal motion of the target. And this is where the mapping is taking place. So the respiratory phase and the internal motion phase. This is where training is taking place. So this is the maybe learning approach that they are applying. And at the end, you will find that the robotic system is actually controlling the beam to move the same way as the target. And this helps a lot in reducing exposing healthy tissue into hazardous radiation. As you can see here, you see that the target is moving and the robot is moving the same way as it. So this is for radiation therapy. But for needle insertion, what's the current solution is breath holding. So the patient take a breath, hold a breath, and they take an image. And then again, just before doing the insertion, take a breath, hold a breath, and do the insertion based on the old image, assuming that's going to be in the same position. But that's not always the case, because you cannot be sure that the patient hold his or her breath at the same moment, and at the same time that there is a percentage of patients, they cannot hold their breath for sufficient time. And can we use robotics and AI to solve this problem? And can we learn from what they are doing in radiation therapy in order to solve this issue? And this is what we try to investigate. So the approach that we have used is that we got some images with a specific sequence from, for example, MRI, and at the same time we were tracking the external motion of the patient while breathing. And then we created a model. And this model, we call it the correspondence model. And the external markers, I call it surrogate signals, because they are external signals that have a strong correlation with the internal motion. And after that, we can give the output of this model based on only the external motion to a robotic system that will take care that the motion is considered. And one of the surrogate signals that we used was actually an IMU sensor, you know, the one that you have in the phone that tells you the orientation. If you have an insert needle and you attach to it an IMU sensor, and then you will have a signal that shows some motion. And this includes the gyroscope, accelerometer, and magnetometer, and gives you the deflection angle, angular velocity, and the linear acceleration. And actually, some clinicians are using this first insertion, and they call it the reference needle, just to have the correlation between what you see outside and we have in the image. And we use this, and we put an IMU sensor, and this we did also this was done in Brigham and Women's Hospital, and it's an affiliate of Harvard Medical School. And we collected a lot of data regarding respiration from the MRI, and we did several tests. And we could get with the 1 millimeter accuracy, around 1.3 millimeter accuracy of prediction, real time with a frequency of 100 hertz, the target motion in the liver during respiration. And we tried to change a lot of parameters, like considering if we change the insertion angle between 40 and 90 degrees, the target depth, the velocity of motion. And we got several variations in this regard. Fine. And actually, after finishing this study, I got called by a company that developed a robotic system. It's called MPS, needle positioning system, which is CT-guided intervention in the Netherlands. And they said they had a device that's almost going to get certified. And when they were doing the animal testing, they found that the biggest issue that they have is respiratory motion. That they got, when they were in the lab, they have very good results, but when they get into the animal testing, they had a lot of issues with using this robotic system because of the respiratory motion. And then we come up with a simpler solution, because when you get closer to clinical practice, you would like to reduce the hardware, reduce anything that will make the procedure more complex. So we decided to go for something simple. Instead of using this complex model, we decided to go for a laser that actually gives information about the distance between the surface of the body and a certain position. And this was our surrogate signal. So we could link this external motion to the breathing cycle. And there was a light array that you will see soon that give you when you should hold your breath, so that it will be in the same position at the image that was collected before. So we are just trying to map the current position to the image that we collected before. And if we can do that, then we are sure that the robot can give the right insertion and the right angle while the patient is holding the breath for a very short time. And actually for this, in order to do more experiments, we cannot do this on patients or on animals, so we made a phantom, and if you see at this phantom, this actually mimics the respiratory motion of the liver. And the nice thing about it, that's actually only made of plastic stuff, 3D printed stuff, and even the actuation was by air pressure. which means that it's going to be suitable for any imaging modality. So you can put it in the MRI without issues. There are no electronics, no metals. And you can then simulate the respiratory motion. And here we use the camera as a surrogate signal, as you can see it, and there are markers outside, and you see this kind of motion that mimics the respiratory motion of the liver. And then we have the robotic arm controlling the needle insertion. And we need only 5 respiratory cycles that take only 20 seconds for this specific patient before we know the exact position inside. And we can create this model. And now I think it's just doing the tracking and prediction. You see that at any moment if you stop, the robot is going to get the right alignment between the target and the needle. And you see that's following the same motion of the target. And at the end, I'll also show you how, when you do the exact insertion, how things would work. So now it's ready. The patient decided to hold the breath at any moment. And my prediction is real time, so I can know the exact position. And then we can do the insertion. And at the end, you see here in this model, two spheres. One is green and one is purple. And the reason of that is that one is the actual one, and the other one is the predicted one. And the error between them is less than 1 millimeter, and actually the accuracy of insertion is less than 1 millimeter. So this was one step. We did it in the lab. And then the next step, we brought this entire system to be under CT. And we brought the similar phantom, and we could even do teleoperation this way. Because, you know, one of the issues of bringing robotics into clinical practice is the insertion part, so the part where there is intervention. This should be done by the user. This should be done by clinician. And that's why the teleoperation is very important, because I could have let the robot directly do the insertion when it stops. It's not a problem from the technical point of view, it's not a problem at all. But from the practical point of view, to approve this device, I need to make the insertion decided directly by the clinician. And if you look at the right side, this is the haptic device that also gives the user information about the depth. So what I mean is that when you do insertion and you're getting closer to the target, you're getting more resistance. So this device gives you more resistance. And at the moment the target is reached, you have a virtual wall. You cannot go any further. And this was a way to even reduce the number of images that are taking place. And one of the other signals that we used as a surrogate signal for motion compensation or to estimate the internal motion is actually the ECG. ECG is normally giving you the cardiac information, but if you look at the signal that we receive from the ECG, it also includes information about respiration. And why we thought about this is because we do not want to put more sensors, more hardware there. The ECG is already there. And if we process the data in a proper way, we can get respiratory information, because actually the diaphragm is changing the axis of the heart, and this affects the signal that you get from the ECG. And from there, we could also get very good results in testing deep breathing and normal breathing. And for the last minute of my talk, I'm going to talk about only one thing, which is we want to get further, reduce hardware further to make it closer to clinical practice. And we said, why do we need? If I do the prediction and get an X and Y, Z position, I can give it to a robot, but I cannot give it to a clinician. If I give them X and Y, Z position of the target, does not mean a lot. But how to do that? He said, can we use the same signal to even generate MRI images instead of just getting the position? And we know for the MRI, the equation is clear that if you would like to have high resolution images, you need to have it low frame rate and also the skin thickness, the slice thickness. So we said we can go for a surrogate signal, which is an ultrasound transducer. We found one we customized actually one that's MR compatible. We can put inside the MRI, and it includes only one electrode. So it does not give me the entire image, it gives me one line of the image. And I have this with a high frame rate. And at the same time, I'm collecting ultrasound MRI images. I can show you in a clearer way in this way. So here from the MRI, I'm collecting images with a low frame rate. And at the same time, I'm collecting ultrasound images, which represent only one line of the liver. So I get one line information from it. But I have this with a high frame rate. And if I create an AI model and I train this, I can even interpolate the images in between. And I can create images between these images. And if I extrapolate, so even after I take the patient outside of the MRI, I can still generate MRI images based on the model that I trained and having only the ultrasound transducer. And this also reduces a lot of the limitations of having tools inside the MRI machine. very quickly we had different types. In order to train the model, it took us time to have normal breathing, shallow breathing, deep breathing, even coughing. We modeled it while collecting data from patients. And just the last thing that I'll end with is that the image on the left is actually what you get from the MRI. So this is low frame rate, good resolution images. And the two images on the right are the simulated images, which includes synthetic images. And if you look carefully, you'll find that the images that are generated are smoother and have higher resolution than the initial image that we have. Fine. And for the sake of time, I will end up with one last thing, which is my conclusion and a take-home message. My main conclusion here is that the evolution of medical robotics is not linear or is not as we were expecting. So for example, the Da Vinci robot, when it started, the main funding that they got from it is from the Ministry of Defense in the US, because they would like to treat patients or soldiers while they are far away by surgeons. And actually, until now, that did not happen. But they made the biggest company for medical robotics. Another thing is that even the development of endoscopy, if you look at how the endoscopist or colonoscopist is holding the device, we as engineers, we don't think it's very logical. You know, if you look at the knob on the bottom center, you actually have some knobs and you're controlling it this way. And for me as an engineer, I found it why they're holding it this way. And I was trying to think, and I talked to someone who was very experienced in that. He said, I told him that if you have like a ball of a mouse and you can control it this way, you can control the bending in an easier way. He said that this is from history, because they used to look at the fiber through this. And what they changed is just, instead of looking it through the fibers, they're looking on the screen. But they did not want to change the way they get trained. So it's still difficult, but this is how the progress is going. So what I'm thinking of there, if you have some ideas of how to improve stuff, we need to go for it until we reach a moment that this will be endorsed. And the last thing is that maybe we say that one step is robotics and the next step is AI, but I think from the examples that I mentioned is that AI can help us to get robotics forward. Because we could not get the robot in the market because of respiratory motion, but we could solve respiratory motion by AI, and this allowed us to get robotics into clinical practice. And the last thing is that one surgeon told me that when sometimes we do something that sounds luxurious for clinicians. So he said that, okay, what if you give me extra vibration feedback, extra force feedback? He said, for me, it's like getting a car with sensors. So at the beginning, we have manual cars, and if we have them and we are driving well, it's fine. If somebody knows the way very clearly, they do not need Google Maps. But if you provide them with Google Maps, you can reduce the gap between experts and novices, and this will save time and costs for robotic development and for medical application. By that, I would like to thank you for your attention.
Thank you, Dr. Momin. So we are going to shift gears now, and we will talk about quality in cardiac surgery. I will present our experience with the STS database and the improvement journey that we had at Johns Hopkins Aramco. And then we will finish the session by a presentation by Dr. Ricardo. So I will start by saying that my passion for quality in cardiac surgery is really deeply personal. I had a pleasure of working with incredible teams here in Johns Hopkins Aramco, before that at BSCC in Riyadh, and at King Saud University, before that in the United States at Mayo Clinic and University of Minnesota, and before that in Toronto, Canada. And since I joined Johns Hopkins Aramco in mid-2021, we have embarked, me and my team, on a rigorous journey of quality improvement, where we had a meticulous tracking of our data, benchmarking ourselves against the best institutions in the world. And during this 3 to 4 years period, we have progressed from a 1-star center in cardiac surgery to a 3-star center, which is the highest rating provided by the STS for the participating centers. And that achievement was a source of immense pride for our team, for our institution. But at the same time, it raised really a critical question, and a fundamental question for me and for us as a group, as a cardiac surgeons. Despite having pockets of excellences everywhere, the fundamental question that I had is, how are we doing as a nation? What is the national performance of Saudi Arabia in cardiac surgery? We have some of the finest surgeons in the world, but we lack data. So the fundamental question is, let's say that the most common surgery that we do, major surgery, is coronary artery bypass grafting. So how are we doing at a national level in coronary artery bypass surgery? We heard about, the robotic techniques and the minimally invasive techniques. A lot of advancements are taking place in Saudi Arabia, but we still lack the basic question is, how are we doing at a national level? And before we talk about that, I will look into the international data. So the Society of Thoracic Surgeons is the largest database, not only in cardiac surgery, but in medicine. It is the most robust and rigorous database created in the medical field ever. And if we look at the crude operative mortality, we see a sustained decline since the inception of the STS database. In the left graph, you see the crude mortality rate, which is declined from about 3 to 4% 20 years ago to approximately 1.3% currently in the most recent data. And if you look at the risk-adjusted operative mortality, you see that there is also a downward trend. And in the most recent years, that risk-adjusted mortality from the STS database of isolated CABG is about 1.5 to 1.8%. Now, if you look in Europe, UK has one of the most robust databases. They follow every single cardiac surgery procedure that is done and recorded every year, and they even have a better outcomes. Similar thing, there is a trend of declining operative mortality with CABG. And if you look here, for the overall mortality of CABG, regardless of it's an urgent or elective procedure, the overall mortality is about 1.2% in the most recent data. And if you break that down by elective versus urgent, patients who come for elective CABG have a very low mortality rate. So 0.5% was the mortality rate for elective CABG in the United Kingdom. So the bar is very high. This is the benchmark. And you remember that we raised this question about all this new technology that we're introducing. We have to compete with this. We have to compete with an established surgery that has been done for more than 50 years with extraordinary outcome. Now, if we go to Australia and New Zealand, the Society of Australian and New Zealand Cardiothoracic Surgery also publish yearly a report of the outcomes in Australia, and you find even a better results. Now, in this graph, the top graph shows the operative mortality unadjusted, and the bottom graph showed the operative mortality adjusted for all the centers in Australia and New Zealand that participate. The y-axis is the operative mortality, and the x-axis is the volume of the center. And all these dots that you see are the participating centers. You see some of the centers are flagged in red, and these are the centers that had a mortality higher than expected. So they go outside the 95% confidence limit and they get flagged, and that information gets feedback to them to see what can be improved. And what you can also see in this graph is an important concept about the relationship between surgical volume and results. We know that there is some correlation between volume and results, but that not necessarily a cause-effect relationship. In other words, in this data from the Australian New Zealand Society, there were like more than 50% of the participating centers were actually low-volume centers, performing less than 100 cases a year, and more than 80% of these centers had an excellent performance. So you can still have an excellent performance despite a low volume. And having a high volume does not necessarily mean that you will have a good outcome. You can see the center number 45 here in the red in the top graph. That center performed more than 450 cases every year, and despite that, their unadjusted mortality was almost 2 times higher than the benchmark. And even after adjustment, they were like still on the fence in terms of mortality. So from the data, including more than 9,000 patients, the overall observed mortality in this data was only 1%, and the risk-adjusted mortality was even less than 1%. Now, so the fundamental question about what about Saudi Arabia? What is the national risk-adjusted mortality rate for isolated CABG in Saudi Arabia? And unfortunately, the honest answer is we don't know. So we don't have the data yet, so we can't compare ourselves, those of us who are participating in a STS, you can compare your results to the STS, but we don't really have a national benchmark yet. Now, the turning point for the creation of the STS was in the late 1980s, and that was due to a wide variability in the result between centers. That has raised a great concern among public, and there was a reputational crisis for cardiac surgery started in New York City because of this wide variability in outcome. And at some point, and until now actually, in New York, they report publicly the results of each center, and they even report the results by surgeons. So surgeons realized at that time that you have to have a measurement. If you don't measure your performance, somebody else will measure it for you. And sometimes this someone else may not understand the data that you are collecting. Now, the proven model of excellence that we have now for cardiac surgery quality is the STS database. It was founded in 1989. More than 97% now of centers in the United States are participant. Johns Hopkins Aramco, they joined this database since the inception of the program in 2017. And when I joined in 2021, that was really, it made my job much easy in terms of just having the data available. You just need to analyze it. And I had a previous experience at PSCC before they joined the STS, where we did a lot of work just to collect the data and to analyze the data in order to improve. So this was a big, I think, achievement for JHAH to join this database from the beginning. The scale of the database is huge. More than 7 million procedures has been recorded. And the mission is to improve quality through data. Now, the 4 pillars of quality cycle in the STS database is basically standardized data collection, rigorous risk adjustment with very robust and powerful statistical models, transparent reporting, and not only just reporting, but benchmarking. So they show you where do you stand compared to others. There is more than 1,000 centers participating in the STS database, and you see how you do compared to these centers. That's what helps you to improve. You benchmark yourself against others. And then you do your own local quality improvement. So the STS will not do the improvement for you. They will just show you the data, and then it's up to you to improve or not. Now, the results of implementing the STS for the United States at least was that the observed mortality has declined over time. And public reporting and benchmarking does definitely improve outcomes. And it's not only about mortality, but also morbidity. So if you do a surgery for a patient and he survived, but he sustained a debilitating stroke or renal failure requiring dialysis, that's a major morbidity. So the STS does not only look to the mortality, but look deep into morbidity. Now, at Johns Hopkins Aramco, we started this journey with the STS in mid-2021. And the reason was that if you are a participant in the STS, you receive regularly, every 3 months, you receive a report, an extensive report, it's like more than 250 pages, telling you about everything about your center. And then the most important figure in this report is this figure that I'm showing you here. So the figure here shows the performance of your center compared to the benchmark. So you have 4 domains, which is absence of mortality, absence of morbidity, use of internal mammary artery, and use of indicated medications. And you get a score as a participant center with a 95% confidence limit for each one of these domains. And based on these 4 domains, you get an overall score. And then you compare your score to the STS median, which is used as a benchmark, the 50th percentile. And the STS also show you what is the range of scores of all these centers. What is the minimum? What is the maximum? What is the 10th percentile, the 90th percentile? And then you look at your scores and see how's your performance. Now, the star rating is basically saying that if you have a 1 star, then your performance is significantly worse than expected. And what does that mean is that your estimate, the score that you got with a 95% confidence limit, is significantly worse than expected. If you have a 3 star, then it tells you that your performance is significantly better than expected, and statistically. And if your performance is as expected, you are meeting the benchmark, you get a 2 stars. Now, this star rating is a little bit tricky because it also depends also on the volume of the cases that you do. So if you have 2 centers, like Center A and Center B, and both of them, they have exactly the same score, same mortality, the same morbidity, but Center A does 300 cases, and Center B does 100 cases. Center A, which does the more volume, will end up having maybe 3 stars because their confidence limit will be smaller, and they will have a significant better performance compared to the Center A, who does a less volume, but good outcome, but less or wider confidence limit, and therefore you will not have a statistically significant difference. So it's important not just to look at the star rating, but look at the actual numbers. So when we looked at this in 2021, and we said, well, why we have a lower overall score? And if you look, you can see that the absence of mortality was okay. The performance is adequate. For mammary was okay, medications was good. So the problem was for absence of morbidity. So we targeted this domain, and the absence of morbidity domain has multiple components in it. So again, this figure just shows you the visual representation of the table that I showed you before. Again, you see that you have this dotted line, vertical dotted red line, that's the benchmark. And then you have your estimate as a center, which is the vertical black line with that 95% confidence limit, the dark blue, for each one of these domains. The 4 domains, mortality, morbidity, mammary, and medications, and then the overall score. And you can see that the overall score is significantly worse than expected. So you want to be towards the left of that benchmark, the red dotted line. Here we are towards the right. In other words, we are statistically worse than expected. And that overall score was driven mainly by morbidity. It's not by mortality or mammary or medications. It was mainly driven by morbidity. So these are the 2 problems here. So the overall score is basically driven down by suboptimal performance in the absence of morbidity, domain. So the morbidity itself, the 5 major morbidity that the STS Society track are those morbidities. So deep stenoid infection, postoperative renal insufficiency, surgical re-exploration, stroke, and prolonged intubation. And again, when we looked to this morbidity domain, we found that this was mainly driven by suboptimal performance in surgical re-exploration, so that we had a higher rate of take-back for surgery, and we had a higher rate of prolonged ventilation. So that was the target that we aimed at improvement. So we focused on surgical re-exploration and prolonged intubation. We created a team and we initiated a quality improvement project, and then we tracked our outcomes over the next year. So by 2022, which is like 1 year after the start of this quality improvement project, we had a trend of lower reoperation rate. So we can see here that we consistently lowered that down for the first year. We also tracked the prolonged ventilation, and that we had also a significant downward trend of lowering the prolonged ventilation. And if we look at the morbidity mortality rate as well, so again, for the first year, we tracked that very closely, and you can see a downward trend since the start of our QI project. So within 1 year, by just targeting the two problems that we had, which is the two major morbidities, we were able to reduce the overall morbidity by 80% in 12 months. So by year 2023, we had an overall morbidity and mortality for isolated CABG of 4%, and that's where like mostly morbidities. And the benchmark in the STS is 10%. So if you look at your data, isolated CABG data, and you look at the 5 major morbidities and mortality, you should always try to bring it below 10%. So the lower, the better. The benchmark, the 50th percentile in the STS is 10%. And of course, most of those are morbidities, the 5 major morbidity that we talked about. Now, we continued to follow this for the second year, which is from 2022 to 2023. And you can see that the trend line here, so the red line is the benchmark, is the STS, rate risk-adjusted reoperation, which goes about 2.5%. That is the benchmark. And you can see that we had like a lot of up and down in those years from the inception of the program. So, and then once we started our quality improvement project in 2021, we had a trend of lowering this major morbidity, because it is associated with increased blood transfusion, increased prolonged ventilation, and some studies showed even higher mortality for patients who had a reoperation. Similarly, the prolonged ventilation was a major problem, was really a major problem that needed an improvement, and we worked with our ICU team that those patients don't need to be on the ventilator for 24 hours. So we established a protocol for fast track. So the patients who get isolated CABG, they should be extubated within 6 hours, unless there is really a reason to keep them on the ventilator. And we tracked our data also for prolonged ventilation, and you can see that also there is a trend since 2021 of low prolonged ventilation. Now, you can see here that the risk-adjusted mortality for the year after that, which is 2023, also was reduced. By year 2023, we had only 2% of combined morbidity mortality for isolated CABG. So that just told us that these quality initiatives that we did and the tracking of our data and this quality improvement cycle is really working. This again showed the trend of the risk-adjusted mortality since the beginning of 2021, and we have kept the trend below the benchmark. One important aspect that really we had a major gap in is the post-operative hospital stay. So in the STS database, the short hospital stay post-CABG is defined as staying less than 6 days. And the benchmark is about 45 to 50%. So at least 50% of your patients, post-isolated CABG, they should be leaving the hospital in less than 6 days. And you can see here that there was a major room for improvement. During all these years, the short hospital stay was hovering around 10%. So by reducing morbidity, we also worked on improving the short hospital stay. And again, we were able to bring the short hospital stay and beat the benchmark. And now most of our patients, after isolated CABG, they leave hospital within 4 or 5 days. Now this shows you the longitudinal results. This is a graph that you can generate from the STS. It showed you your overall performance. And you can see that the operative mortality, we had a very low mortality since 2021. In fact, we had 0 mortality for the last 4 years for isolated CABG. Now for risk-adjusted morbidity mortality, similarly, so now we are, meeting the benchmark. And after 2-3 years, because these STS star rating compile for you a 3-year data. So if you do well for only 1 year, nothing will change. You have to do well for a long time, for at least 3 years. And we have reached in the most recent report back to a 2-star rating overall. And you can see in medications that we had a 3-star rating. But again, I will tell you, when you look at this, you may say, oh, I wish I had a 3-star rating, but you should look at the actual score itself. So you can see that we had an overall score of 98%. And if you look at the benchmark of the STS highlighted in yellow, you see that the 50th percentile is 97%. The 90th percentile is 98%. So we were very close to the 90th percentile. In other words, we were better than the benchmark. And you can see that the morbidity now is very good. Absence of morbidity is excellent. Absence of mortality is excellent. Use of memory and medication, etc. And this is just a graphic representation of the same table. So you see that here we are towards the left of the benchmark, which is the red dotted line. And if you look at the overall score, we were almost close to get a 3-star in the isolated CABG. So maybe if we increase our volume a little bit and we got a narrower confidence limit, we could probably get a 3-star rating in isolated CABG. Very recently, and you can see here also the trend of the star rating. So we have maintained a 2-star rating over the last 4 years since 2021. And very recently, this is a recent score that is generated by the STS. And this does not include only isolated CABG, but includes all procedure that you do in your center, which is really very good because your sample size gets bigger. And if you are doing a good performance, that will show up in the star rating. So we were very happy and very excited to reach a 3-star rating for our overall cardiac surgery service. And we were the first in the region to achieve this 3-star rating. And this was really very exciting for us. You just told us that using data for improvement can help quality very, very big time. Now, so the path forward, we really need a vision for our country. I think we have to adopt some sort of registry. And maybe we have also with us today Dr. Mohammed Al-Aklabi, who is the Executive Director at PSCC and for the cardiac centers in Saudi Arabia. And I think he will help us to, try to make a national strategy for establishing a registry for cardiac surgery. This will drive the quality improvement. It will foster local research. It will enhance our global standing. And this definitely support the Vision 2030. So let's build our future together. We can adopt and adapt the STS database. We don't need to reinvent the wheel. The wheel has been already invented. We just need to use it. We need to secure a mandate and support, invest in infrastructure. Data is the bedrock of quality. The STS database is a proven blueprint. The time for Saudi registry is now. No measurement, no accountability, no improvement. Thank you very much. So we will make the questions towards the end of the presentation. Now, Dr. Ricardo from Brazil will present for us strategies for revascularization.
Hello
Good afternoon, everybody. I would like to thank the scientific committee for the opportunity to invite me to participate in such an important meeting. I have been having very pleasant moment, and especially want to highlight the hospitality of the Arab people. I also would like to express my happiness to being together with my great friend, Dr. Fahd, and being able to live with his culture for a few days. Thank you, my friend. In my presentation, I will make a retrospective of myocardial revascularization surgery, and I hope it will be interesting for everyone, since the top of the discussion in this meeting have been artificial intelligence and medicine, robotics, and small incision. Next, please. Okay, sorry. I have no conflict of interest, and I would like to show you the evolution of myocardial revascularization surgery from the saphenous vein to the total arterial graft. The experimental work started in 1910 by Carrel, followed by Weinberg in 1960, using the mammary arteries implanted inside the left ventricle. The vein graft done by Fahd in 1967, following the mixed use of the veins and the results by the Cleveland Clinic in 1996, arterial grafts in 1999, using a bilateral mammary artery at the Cleveland Clinic. And also during this time, there was a lot of contribution, like the Buffalo contribution in Bennett, Buffalo from Brazil and Buffalo from Argentina, working together. They had introduced the extracorporeal pump of extracorporeal circulation. In 1993, we introduced the pericardial suture, and also comes the no-touch aorta by another colleagues in Brazil. This is the historical milestone done by Fahd when he introduced in 1967 the saphenous vein with extracorporeal circulation. This was really a milestone because they changed the history of the treatment of the myocardial ischemia. After 4 years, they started to show the first paper, hyperplasia of the thrombosis of the saphenous veins under arterial pressure condition very soon. And this took about 18 years for the Domingos Souza. He's a Brazilian guy who worked in Sweden in 1989. He showed a no-touch technique for the vein harvesting. They show us that they take the vein, no touch the vein, and keep all the pediculum around the vein. That's avoid some kinks and obstruction in the future. The mixed use of the mammary in the vein started in 1996, but it took also a long time because the first mammary harvesting in use was by George Green in 1963. And in 1986, Floyd Loop showed the patency and the survival in 10 years, the Lima versus saphenous vein for 2 vessels and 3 vessels, and it's a great difference. And why is the mammary artery so special, and what protects it from atherosclerosis? No change are observed in the edema of the vessels.
of the Lima over the years support a long-term hypothesis. That's the reason. And that's what's not happening in the vein. So 3 years later, Bruce Little from Cleveland Clinic showed the use of the bilateral internal mammary is better than use the single mammary artery. And the beta grafts was associated with high survival and lower need for repeat vascularization compared to the single mammary use. And this observed from our study, over 7,000 patients, the beta was associated with significant reduction of the long-term mortality relative to single mammary. And the benefit was increased in the study with a high proportion of males. Bilateral and Lima for diabetic patients also is better in both groups. The other question was important to answer was the site of the second graft. And we observed the survival of the bilateral mammary use is not affected by the site of the second graft. You can see the mammary in situ and the top figure and the right and the mammary in the right coronary artery, but you can see the right coronary artery to the circumflex, and you can see the left mammary to LAD and the radial arteria like a composite graft. It doesn't make any difference for the results. In the radial artery was presented by Alain Carpentier in 1971, but fortunately the early spinal occlusion shows that the surgery cannot be used very often, and it was excluded for the surgical arsenal. But ACA in 1992 showed that the Carpentier has introduced the technique, but the harvesting technique was wrong, because he just showed that if you do not touch the graft, and if you use a pharmacological validation instead of the mechanical dilatation, and the graft will work well, and we have a result of 100% of the early postoperatory period. So, when compare radial artery and saphenous vein graft, the radial artery shows better result than a saphenous vein. So, to take home message, you can say the radial artery should be used preferentially over the saphenous vein for the second most important vessel with a significant stenosis after left anterior descending artery. Benefits of the radial artery versus saphenous vein is a superior quality, reduction in cardiac events, and superior survival. Total arterial surgical revascularization is superior to a single thorax artery use. So you should try to use the revascularization, the most of the arteries possible, and also is the same. You cannot use the same sinking of the hemodynamic using one stent just for one artery, the cupid artery. So Puskas and Taggart did that recommendation that the left and right mammary artery have the same impotence for the LAD. The use of a secondary artery graft is recommended. Skeletonide right mammary artery is recommended to become a little bit longer. Smoke cessation, glycemic control, use the right mammary even for lesion with severe stenosis, no problem. And patient age is not a limiting factor for arterial graft. In 1981, Enio Buffalo from Brazil and Benetti from Argentina, as I said, working together, they reintroduced the off-pump coronary bypass graft in the OPCAB. But they use only for the anterior vessels
And in 1993, we introduced the deep pericardial suture that's allowed to do the complete revascularization and off-pump surgery. And this guy, Lobo Filho from Brazil, the Northeast Brazil, also using this technique, they introduced a no-touch aorta with OPCAB. So this avoid any kind of cerebral events. And the other big contribution is the contribution, as I mentioned before, by Domingos Souza, use a no-touch vein. I think this composite ideas makes the myocardial vascularization is a very big and very nice thing, continuous very nice thing, opportunity to treat the patients. Off-pump surgery now, after more than 15 years, Pushka showed that the off-pump multiple arterial graft with minimal aortic manipulation is for everyone. I think so is for everyone, but in fact, it is not need only the surgical technique, but did the surgeon have a good mind to do this kind of surgery, because it's a kind of surgery you cannot run out, you just have to do pace by pace. So our arterial clampless of CABI may offer combining benefits of minimizing preoperative stroke risk and maximizing long-term graft patterns. That's real true. So some groups, especially in the developing countries, and have a hybrid coronary revascularization robotic, but the result is still very in the beginning. The synthesis show us that the presence of angina at 1, 6, 12, 36, and 6 months was higher in the group, the PCI group. So, CABG VGA-ATC, you can say that the CABG improves survival, ATC is uncertain. Decision for CABG should be based on the complex of the disease of arterial coronary, emphasize the individualization of the patient decision. This is very important and have been discussing all this morning here in this session. Consider coronary anatomy, comorbidities, surgical risk, and I do approve the heart team is essential for complex disease, but I do understand that's no easy to do work with a heart team. The treatment strategy, the optimal treatment strategy is still unclear. Heart teaming plus patient-centered care is an important task to do. And to left main coronary artery, CABG is indicated for patients with left main, although it can be treated medically, depends the kind of the lesion. And the ATC can be considered an excellent option for improving survival compared to the medical treatment in patients with mild to moderate and complex CAD and the left main CAD, and who are suitable for both surgical and ATC treatment. So I would like to thank you for that great opportunity. This is the Heart Institute in Recife, the place where I work is a university hospital with 252 beds, and the next year we're going to up for 380 beds, almost 400 beds, only for cardiac. Thank you very much.
Thank you, Dr. Ricardo. So I know everybody is hungry and we have to go to lunch now, but we will take 2 or 3 minutes for questions and discussions. I will start with the panelist, Dr. Mohammed Al-Akrabi.
Thank Khalid on his outstanding outcomes, and I think you reach these outcomes after looking your data and benchmarking. And it comes over years, and that's just the point. And each hospital, they have to actually look at their data and benchmark them. And sometimes I'll give you a small example. we were running STS for 15 years in Edmonton and Alberta, and we're looking at our outcomes. And when I joined MBC in Vancouver, so we were running both places, we looked at arterial switch and units after arterial switch, and mortality is very low on both. But we noticed in Vancouver, they go home at day 4. In Edmonton, they go home at day 7. So if we actually did not have the benchmarking, we would never know. When we looked deep in Edmonton, they were feeding the babies NG the first day after surgery. They have NG in the OR, the baby will be NG fed for 3-4 days, and they'll start feeding afterwards. So that's why the 3 days extra is to introduce the oral feeds for the baby for going home. In Vancouver, immediately after surgery, next day baby will be fed orally. So tells you when you look at the data, this helps you to improve your quality in every aspect, and I think this should be mandated. The other thing I will mention also, for our intervention colleague this morning mentioned how to actually introduce the procedure to a patient, either CABG or PCI. And I think that's a key, because if you tell them the surgery will be open from here to here, I'm sure even us will just choose PCI. I think it's a key, if we know that's actually the best option for the patient is CABG, is how to present it, especially with the new minimally invasive surgery that I've done with excellent outcomes. And then we're looking for the long term for patients. Thank you, Khalid.
Thank you very much. Any other questions?
Yes.
Or comments? Okay, Dr. Faleh.
Thank you, Dr. Khalid. My question is to you, actually. You showed a very good result, and there is big shift from 21 to 22, from 28 mortality to 2% mortality. So there must be major change, presuming that volume of the patients increased in your center. So there must be change in OR or ICU or maybe patient selection or maybe both.
So let me clarify that it's not mortality, it's a combined mortality morbidity.
Combined, okay.
So the mortality was not the issue. I think the issue was morbidity. We had a higher take back for bleeding and a higher prolonged ventilation. For example, I will tell you an example of the prolonged ventilation. So there was no really drive for the ICU team to extubate the patient. They will just keep the patient intubated overnight and say, okay, we extubate him in the morning. Why we rush the patient? So, and the counter argument for that is that why would you keep him intubated? If the patient is not bleeding, is hemodynamically stable, why do you keep him sedated and intubated, just waiting until next morning? So there was a culture issue. Yes, there are some parts that are technical parts for us as surgeons. So if you do a surgery and you have a higher rate of bleeding and the patient is bleeding in the ICU, well, guess what? They will not extubate the patient because he's bleeding. He's bleeding, he may go back for a take back to surgery, you will get more blood transfusion, you will get in more complications. So it's like one complication begets the other. But it starts with, as you mentioned, it's like a comprehensive approach. It starts with patient preparation, so it's pre-op, start with excellent intraoperative procedure and preemptive measures post-operative. So don't wait for the patient in the first 2-3 hours when he arrived to the ICU and his ACT is very high and nobody checked it and he was like bleeding and he was not given protamine. So instead of waiting for the patient to bleed, we'd say, okay, well, when the patient arrived to the ICU, the first thing that you do, you have to check his ACT. If it's high, you give him protamine. So these preemptive measures prevent complications that can happen, and you could potentially prevent them. Now, the things that you do inside the OR, nobody can fix it for you. You have to do a good operation. If you don't do a good operation, the ICU cannot help you in that. So,
in the ICU then?
Yeah, yeah, both.
So, Khalid, I agree with you. It's always hard to change culture. But I think I'm just going to give you an example of what we have done in Prince Sultan. The first case we have done in an adult, I told them to extubate in the operating room. Because I know if you go to ICU, he's going to stay at least till tomorrow. So the ICU was shocked because they're used to have a patient intubated. Now they are actually, the patient is extubated, they have to deal with something else. But what happened next day morning, the patient was in the ward. So now more than 60 patients, 60% of the patient extubated in the operating room. And I think we had to struggle with anesthesia, but we made it a mandate. that all patient has at least, if they could, not even the complex cases. But that actually made even our length of stay 50% less. So I think extubation and the operation, we have to push the anesthesia to do it.
Yeah, and we have actually done that in the last 2-3 months. We started this idea of extubation in the OR. And as you said, it depends really on the cardiac anesthetist who's with you. So we were, in the last 2 cases with Dr. Safar, we extubated the patients in the OR. But it needs anesthesia cooperation. So it has to be done in a certain way. You may have to wait in the OR for maybe extra 30 minutes or so. But it really did a major difference. So that this patient, by next day, he will be walking around. And his his hospital stay will be really affected in a positive way. So
I have a question.
Yeah, Dr. Fahd.
Now you elegantly presented how data can help you in measuring the outcome of your work, basically. Is there a way where we can measure the outcome of treatment of coronary artery disease in general, so whether it's medical therapy, surgery, or PCI, like for a center?
Well, I think you mean how to assess the quality of care of a center in cardiology and cardiac surgery, is that the question? Yeah. I think the wheel is, as I said, it's already invented. So we have for cardiology the NCDR, and I think that's probably the best database, most comprehensive database that you can use to see how you are doing. For us, I think in cardiac surgery, we have the STS, the most robust and rigorous database. You don't need necessarily to join the STS itself. You could probably just adopt the definitions of the STS and start using it in your center, even if you are not a participant in the STS, but use it and compare yourself to the STS and see how are you doing. But the beautiful thing about joining an STS is that you'll collect this data prospectively. So you have a data coordinator who's dedicated to that work. What she does is that she enters the data for those patients prospectively for each patient before they leave even the hospital. For the retrospective collection, especially if you don't have electronic record, it's really hard. And you don't know, there's no standardized definition. How do you define stroke? You may say, okay, well, my patient did not have a debilitating stroke. It was just, well, no, you have to define it stroke as in the STS. There is a very certain criteria that has to be met to say stroke, even if you don't have a debilitating stroke or a disabling stroke. Any stroke is counted. How do you define renal failure? How do you define deep cellular infections, etc.? If you measure it and you track it and you see where you stand compared to others, your peers, it will drive you to do better. Without measurement, trust me, it will not change. You may even not notice. Like, for example, the length of stay. You may, I know certain places when I was in Canada, they have the normal length of stay for them is 9-10 days for isolated capital. Other places, they're 5 days. I know the patients sometimes they want to stay, but it's not a hotel. So you have to give the patient, prepare him before surgery that, look, this surgery, you're going to leave day 4 or day 5. If you are very slow, day 5. If you are good, you're going to go day 4. Once they are psychologically prepared and they are doing well, they will accept to go home at day 4 or day 5. Last question, Dr. Uthman, or a comment.
Yeah, sure. It's a question or picking your brain on that one. Moving now in privatization. Would that help or no?
Well, I think with insurance, like in the United States, for example, insurance prefer centers that have data collection.
I think so.
So I'm hoping, but I think, as Dr. Al-Aklabi mentioned, I think the government has to mandate this. The registry, I think it should come from the Ministry of Health and the National Heart Center. The government, like in UK, for example, it's mandated by the government. In fact, we have examples from our local region. In Abu Dhabi, for example, it is mandated that you participate in a database. You cannot open a cardiac surgery program without being part of a database or a registry that reports your outcomes every 3 months. In Dubai, it's open, you can do it. So I think in Saudi, we are a big country. I think it will start with a collaboration between Ministry of Health, Ministry of Defense, Ministry of National Guard, because our healthcare is not only under the Ministry of Health. We have different domains, so they have to collaborate together and agree that we should adopt this registry for cardiac surgery. Okay, so thank you very much. We're gonna go for lunch. The lunch will be in building 58, right? Okay, 54, thank you.
Hello, everyone, and welcome back. I hope everyone had a refreshing and pleasant lunch. We will now be moving on with our next session of the program, or our next section. I would like to welcome Dr. Faisal and Dr. Fahd Diaby to the stage to present the awards to our abstract winners.
Thank you. I would like to take this opportunity to thank all the candidates who submitted their work. I would like to thank Dr. Faleh, Dr. Hayat, and the reviewer of the abstract. We received a total of 55 poster and abstract. 30 has been chosen in the screen outside, and 3 of them were chosen to be the winner for I think multiple reasons, but the ranking was the same in my own view, was a fair ranking for most of the abstract we review for conference. But you will see we try as much as we can to put a glimpse of the abstract. I encourage you also to look at the abstract in the screen for those 3 winners. So for the first abstract, and there is no first winner and second winner and third winner. We think the 3 abstract deserve the mention of the 3 best submitted abstract. So I will have Dr. Faleh present the first one.
Congratulations, the first winner is Anna Cardon. She's from Netherlands, 20 University. She had abstracts about ECG-driven recurrent neural network for liver respiratory motions estimations. And congratulations and welcome to the stage. Second winner is Mahiba Sayyid or Saeed. Please come to the stage. Her abstract was about developing a multi-agent AI system for real-time heart attack detections, cooperative architects for emergency care unit. Congratulations, Mahiba. Next abstract is for Muhammad Ramiz in his
work in application of artificial intelligence in cardio-oncology patients to detect therapy-induced cardiotoxicity.
I just want to appreciate and deeply thanks Dr. Haya and her team that they assist the applicants from Johns Hopkins Hospital in clinical side, and also my colleague and good friends Dr. Ahmed Al-Dalag from KFUPM and his team that they assisted actually, and they evaluated the submissions related to the bioengineering. So this work is their work and they helped us a lot, and thank you very much.
We will now proceed with the next session, focusing on vascular medicine. Please help me welcome Dr. Mustafa Fleet, an interventional radiologist at Johns Hopkins Aramco Healthcare. He'll be our moderator for this session. Please help me also welcome the panelists on this session. Professor Yinghui Lum, he's an associate professor of surgery, a vascular surgeon at Johns Hopkins Medicine, Baltimore. Joining him is Dr. Shagran bin Khamis, section head vascular interventional radiology at King Faisal Specialist Hospital, and Dr. Tariq Barakat, a consultant vascular surgeon at Johns Hopkins Aramco Healthcare.
Thank you. Assalamu alaikum, good afternoon. First of all, I'd like to thank the organizer for including this vascular session in the HeartFusion program. Obviously, they are connected and fused. This session will be divided into peripheral vascular disease management, then aortic aneurysms and aortic dissection. So there will be several talks on these main topics. The first talk will be by Professor Lum from Johns Hopkins Medicine, and he will talk on the recognition and management of peripheral arterial disease. Dr. Lum, please.
All right. I'd like to first thank the organizing committee for this great opportunity to come and visit and to speak. The hospitality here has been incredible. Thanks for the hosting, the gala dinner, and all those things to make us feel so welcome. So thank you. I'm glad we're already about an hour late, so what's another 1 or 2 more hours, right? I've got a lot of slides today. Well, the first talk is going to be on the recognition and management of peripheral arterial disease. Unfortunately, I do not have any disclosures to make. The objectives today, we'll talk about what PED is, some symptoms, risk factors, and mortality outcomes. And then we'll talk about management strategies and briefly go through some general themes, and then what we can do about it, in terms of screening or testing. So peripheral arterial disease is just one of the continuum of cerebrovascular disease, coronary artery disease, and the spread of atherosclerotic disease throughout the rest of the body. Peripheral arterial disease actually doubles the risk of having an MI, stroke, and cardiovascular death. So if you have one of the diseases, as shown in the REACH study, about, there's this huge overlap between all three, and about 14% will have all three types. And we'll go through some of the mortality curves about what happens when you have this. Most people don't die from PAD, right? You have PAD, you may get some, gangrene and stuff like that, but you don't, unless the leg gets infected, what you really die from is from strokes or MIs and things like that. So the importance of diagnosing PAD is that there are 1 or 2 small things that you can do that is in addition to what you're already doing for someone with coronary artery disease or carotid artery disease. So symptoms, most people are asymptomatic, so you can have all the blockages in the legs, but most people will have no symptoms whatsoever. And then you have claudication, which I like to think of as angina. 10 to 30% of all people have some form of claudication. Typically, you want to ask them where exactly the pain is in the calf, how far can you walk, and things like that. And then the next step, what I like to think is like unstable angina, would be rest pain. The pain is so bad that even when you're at rest, you have pain in your legs at night. Typically, people are saying that they dangle their legs off the side of the bed at night. And then after that, you have ulcerations and tissue loss, which is thankfully only 1 or 2%. And this falls under critical limb or chronic limb threatening ischemia, CLTI. Symptoms that are not typical of PAD that we get referrals for when we see patients in clinic. Leg swelling, that's not PAD. Feet burning, that's not PAD. Now you can get some neuropathy with diabetes and things that have associated PAD, but these symptoms are not PAD. And of course, we get a lot of patients, my orthopedic colleagues, who have hip and knee pain, they have arthritis. And shin pain, shin splints. Risk factors are the same for coronary artery disease as well as carotid artery disease. Smoking, diabetes, hypertension, hypercholesterolemia, chronic kidney disease, and of course, history of CAD. Now, interestingly, smoking, if you are a smoker, you are twice as likely to develop PAD than you are to develop coronary artery disease. And this is what happens. The phenotype or symptoms of what you have in PAD impacts your survival. So on the upper curve, if you only have claudication, your survival curve is actually a lot better than, pretty close to the national average, the average patient. Without any comorbidities. But if you have critical limb ischemia, your mortality rate is significantly worse. I tell all my patients in clinic who have critical limb ischemia, there's a 50% chance in 5 years that something else bad will happen. Not from the PAD. I could fix the PAD, we could do a bypass or do a stent and save your leg, but something else bad may happen in the next 5 years. Now, what happens if you have PAD with coronary artery disease or with a history of stroke? Your mortality is at the lowest here. In this study of about over 6,000 patients 40 years or older, if you have all three disease, your curve is at the bottom of that line there, 25.5% chance that you'll make it around 12 years. Now, if you've only got the top curve is 87%, and then if you've only got one of the other two, so PAD and coronary artery disease or PAD and stroke, you're kind of in the 40 to 50% range. So implications for this, it just helps with counseling. It's not that you're going to change things that much, and there's one or two small minor things, but it helps with patient expectations and counseling. I wanted to see what was the landscape here in the kingdom, and I found 3 studies. The first one is in 2007 in Riyadh. They found about 11.7% PAD prevalence in patients above 45 years old. 93% were asymptomatic. Probably a little bit underreported, but that's what was the data out there. In the diabetic clinic, 23% PAD prevalence, which I thought also was a little bit low considering it was a diabetic clinic. But in general, 67% of high-risk Saudis had never even heard of PAD. So that's definitely a recognition issue. Now, when someone has PAD, there are 2 main goals and objectives that I look at as a vascular surgeon. One is preserve life, try to improve the outcomes in terms of mortality. And like I said, you don't die from PAD, you die from cardiovascular events like MI or stroke. And the second is to improve limb outcomes, save the limb. Try to give them better quality of life with the ability to walk if you're going to intervene for claudication, which we are very conservative to do. But if you did do it, it's got to be really disabling claudication so that you can actually make an impact on the quality of life. And of course, if someone has got critical limb ischemia, you try to fix the limb ischemia and prevent amputation. In terms of updates on therapy, the general themes for both of them, and the ones in red are probably the newer medication classes that have come into play in the last 5 to 10 years. Rivaroxaban and aspirin combination We'll go through some slides after that. And really the PCSK9, like evolocumab, that really is quite a significant change, especially if you have coronary artery disease as well. I'd like to look at numbers in terms of number needed to treat, and I believe the number needed to treat with evolocumab is something like 16 or 20 or something like that. So quite a rather effective medication in terms of preserving life and limb. This is a COMPASS study that talks about rivaroxaban and aspirin. Again, it helps a little bit, by giving 2.5 milligrams of rivaroxaban with aspirin, you are decreasing the incidence of either adverse cardiac events or adverse limb events by a little bit. Number needed to treat for that is about 50 to 80, and that's at 2 years. Considering, aspirin is something we give like water to everybody, the number needed to treat for aspirin is somewhere between like 150 and 180. So 50 to 80 is not horrible, but if you narrow it down, especially when you're thinking about costs and things like that, it's most effective if you give it to patients who've got established PAD diagnosis, and even more so in patients with PAD that have had some sort of revascularization. In this case, the number needed to treat is a little bit lower at 40, and that's at 2.5 years. So what can we do about this? Well, the US PTF Preventive Task Force says nothing really much, no screening because there's not enough evidence, although they talk about some high risk factors and things like that. The American Heart Association, actually the SVS, Society for Vascular Surgery, actually gives some guidelines about screening. And they actually recommend screening in maybe patients who are symptomatic, those aged more than 65, patients above 50 with diabetes, smoking, coronary artery disease, or chronic kidney disease. Or if you're less than 50 with one risk factor, or any known coronary artery disease or carotid artery disease for risk stratification. Again, I said, mostly not that you're going to treat or do anything else, but more for diagnosis and counseling. Obviously, not recommended for anyone that's asymptomatic or low risk. What else can we do? Physical exam is probably the number one. Check for the patients for pulses. The pedal pulse is quite easy to check. And then after that, you can do an ABI. And depending on that, if you're really going to intervene, then you might do other imaging. But typically, we kind of just stop at that unless you're going to do something else more. Now, it's not that we're going to treat these patients with a procedure, right? An abnormal study does not mean you need to do aggressive surgical or procedural treatment, because we know that at least in the, and I can speak more for the lower extremity, for the major adverse limb events, MALE, once you put the stent in for claudication or things like that, you're at a risk of intimal hyperplasia, restenosis, and then when the stent blocks up, you can become even worse than where you were to begin with. So the risk of then losing a limb once you've had a prior intervention goes up significantly. If you have no symptoms or you're just a claudicant, the chance of limb loss in 1 year is less than 4%. So you may have an 80% stenosis, a common femoral artery, but if you have no symptoms or maybe just mild claudication, you do not need a procedure, even though it may be 80% stenose. For the medical students and residents in the room, how do you measure the ABI? You take a blood pressure cuff between the ankle and the arm. The ratio should be 1, right? The blood pressure in the arm and the leg should be the same. It's a little bit higher in the legs just because of hydrostatic pressure and the blood vessels are a little bit more stiffer, so you need a little bit more pressure to compress the arteries in the leg, but typically it's about 1. And then when to refer to a vascular specialist? Well, if it's greater than 1.4, maybe because someone is diabetic, you cannot really compress those vessels. The ratio can be a little bit falsely elevated. In that case, refer to a vascular specialist to counsel them and stuff that might not be unreasonable. Or if the ABIs are really low, 0.5 to 0.8 or something like that, you can refer them to a vascular specialist as well. Obviously, if they have a lot of lifestyle disabling claudication, that's another reason. Or if they have signs of critical limb ischemia, rest pain, and also tissue loss, that's another indication to refer as well. All right, so the take-home messages from this is PAD is common, coexists with coronary artery disease. I think there's a role for multidisciplinary evaluation to help detect, counsel, and try to optimize cardiovascular care for these patients. The phenotype of peripheral arterial disease matters, whether they are asymptomatic or claudicants or they have CLTI. First line evaluation is physical exam, followed by maybe an ABI. And if you do other things, or if you do a screening program, the goal again is to save life and limbs, not to do more procedures. And then the invasive procedures are just limited for patients with CLTI or lifestyle disabling claudication that have failed otherwise conservative therapy. Thank you.
The second talk for Professor Lum is the acute limb ischemia, so we'll carry on, please. Thank you.
All right, our next talk, moving along, is on acute limb ischemia. We'll talk about what is it, what causes it. We'll talk about the different stages. I know there are a couple of internal medicine residents in the room. Diagnosing this is quite important. Then we can talk about how we can manage this and some complications that can result as a result of limb ischemia during the acute phase. All right, to relate that to the cardiology world, I like to think of acute limb ischemia as the STEMI of the leg, right? You have this, or to our folks from KPUM, it's like you have a pipe and all of a sudden you're turning off the pipe and there's no flow down the rest to the leg. Mortality rates can range from 15 to 25%. Amputation rates about 15 to 30%. The data out there is a little bit varied, depends on your practice, but about 1 in 4, 1 in 5 cases of some sort of cardiac origin, whether it's from thrombus from atrial fibrillation, left ventricular thrombus as a result of low EF, MI, prostate valve thrombus, endocarditis, and paradoxical thrombosis. I saw many cases of paradoxical thrombus during COVID when people were having massive PEs and little pieces of clot were going over from a right to left shunt. Other causes, embolic sources from other parts of the aortic arterial tree, from the aorta to the iliacs to the femoral, from blue toe syndrome and things like that. Thrombotic occlusions from existing plaque. Trauma happens a lot in Baltimore, a lot of penetrating trauma that can result in limb ischemia, or classically the patient that falls and dislocates the knee and gets a popliteal occlusion from that. Popliteal aneurysms can thrombose. Arterial dissections in any part can cause flow limitations in the true lumen. Iatrogenic sources, probably one of the biggest things that we see in the tertiary referral center from ECMO or any kind of procedures from TAVRs and things like that, or PCIs. People with prior existing grafts, stents, that now become occluded, those cause acute limb ischemia. Systemic hypotension in patients with multiple vasopressors. And of course, compartment syndrome in the leg from DVT, and then you restrict flow in the arterial system as well. These are the definitions and the time windows. So basically, it's a sudden decrease in limb perfusion, typically less than 14 days. The 6 Ps, again and again and again, I tell my residents all the time, the 6 Ps are the things you need to know. Pain, pallor, poikilothermia, which is a change in temperature, pulselessness, and then the late stages, paresthesias and paralysis. This table shows the chart in terms of the Rutherford classification for limb ischemia. Green is, bad, but not horrible, and then red at the bottom is really, really bad. So class 1, you don't really have any sensory or motor weakness. You can probably still even get a Doppler signal in the foot. So a Doppler signal is something you hear, a pulse is something you feel. In these cases, observation, sometimes anticoagulation alone is good enough. I've seen patients resolve their thrombus from just anticoagulation alone. The limb is viable, not immediately threatened, but if they're having a lot of symptoms, probably something you can treat over the next couple of days. 2A, marginally threatened. Now you're starting to have some sensory loss, but you still do not have any motor deficits. Patients can sometimes still walk or hobble around a little bit. In this case, urgent revascularization. What's urgent? Anywhere between 12 and probably 24 hours would be the standard of care. 2B is when you start getting really significant trouble. You get the motor weakness. And that's that's emergent revascularization, which is something you take to the operating room tonight, or don't wait till tomorrow morning, otherwise the lawyers will probably come and get you. And 3 is when everything is kind of too far gone, there's some rigor mortis, the leg's stiff, they have no function whatsoever. That's the time you probably want to just proceed with an amputation. earlier in my career, I probably was a little bit overzealous in trying to save one or two of these, and then you get into some of the complications that we'll talk about later. Again, I wanted to see what's going on in Saudi Arabia. I found 2 papers about limb ischemia. I think there's some degree of publication bias. You know, you probably report the good results. No one's going to report the legs that they had to amputate. So the 2 studies. One basically confirmed the high suspicion of diabetes and PED over here in the Eastern Province. In this group of patients that had acute limb ischemia, greater than 60% were diabetic, and more than 40% had symptoms more than 12 hours. In my last slide, I think I forgot to mention 6 hours is kind of key, especially when you're at 2B ischemia. You really want to revascularize the leg within 6 hours. Otherwise, you can get a lot of irreversible damage to the leg. This second study is further up, I think the northern part of Saudi Arabia, over a 3-year period. Surprisingly, I think 27 patients is a little bit low in numbers, mostly trauma. I think the lead author was an orthopedic surgeon, and some had arterial thrombosis. You see the class, Rutherford class of how they split them up. 85% were class 1, which is rather high, meaning that, you know, perhaps they were presented early somehow to this to these hospitals. They were treated with a combination of surgical embolectomy and catheter-directed thrombolysis. And their limb salvage rate, I think, is pretty high, 92%. So immediately, what do? You start IV heparin, give them a bolus, and then start the infusion, provide some analgesia, oxygen, and IV fluids. Do not delay for imaging. Sometimes you can take the patient to the operating room. I was in an expert witness case recently, reviewing a case, and there was a surgeon that decided to transfer the patient just because they didn't have a C-arm in the operating room, and that was not the right answer. And of course, contact of vascular surgery or interventional radiology. Your options for revascularization, I think it varies. There are many trials in the past that looked at endo versus open surgery. The problem with all those studies is that they really vary in the patient population. There's so many reasons why someone has acute limb ischemia. So no surprisingly, when you look at the Cochrane review, there's no difference between endo versus open approach. I think the options should really be tailored to the etiology of the limb ischemia, taking into account some patient factors like age, comorbidities, and things like that. How long they've been having ischemia, and what kind of resources are available in your hospital institution to be able to treat that. So in the past, people would say, oh, if you need emergent 2B ischemia, you need to revascularize the leg as soon as possible. So that would mean surgical embolectomy, take the clot out. But that's not so true anymore. Endovascular in the past would mean thrombolysis, where you would leave a percutaneous catheter inside the body for 12 to 24 hours, recheck it the next day, and maybe even leave it for another 24 hours after that. So the concept was that that would be too long to improve the flow in the leg. But now you have much better devices. You have a combination of different aspiration and mechanical devices that can suck out or clear out the clot on the same day, really, sometimes. So the adage of reserving endovascular options only for class 1 ischemia is probably not true anymore. You can probably do it even for 2B ischemia. As a surgeon, when we do embolectomies for this, the incisions are not too horrible. They usually start in the groin, the femoral region, to try to cut down. When you pass the catheter down, it goes all the way down the leg over here. Typically, it'll go down probably the perineal artery, which is the most straight, which leaves it, makes it a little bit difficult to clear the clot in the anterior tibial and the posterior tibial. I have my compression socks. Just so you know, you can buy these on Amazon with the arteries of the leg going down your leg. So I tell the sock which one's left and right by looking at the anatomy on the socks when I put them on. But sometimes if you cannot clear the tibials out, then you have to chase them one by one. And then the next stage would be to make another incision below the knee, typically just underneath over here. And that exposes you to all the tibial vessels, and you pass the catheters down one by one. And then if that doesn't work, then you really cut down at the ankle for the posterior tibial or on the dorsum of the foot for the dorsalis pedis. And then the last option is amputation, especially for class 3 ischemia. It's okay to do both. If you do a surgical embolectomy and then you don't think you're getting good clearance, it's okay to do endo. And then you can do wire-guided embolectomy and pull the catheters out that way instead of cutting down. If you thrombolize someone for one day and the next day is not getting better, it's okay to switch over to open surgical embolectomy. So having all these options is quite useful. And of course, don't forget, you may need to do a fasciotomy as well. I know there's a talk later on the endovascular methods, but this was just a case I did about 3 weeks ago, so I thought to show that. So this is the thrombus right there in the popliteal artery. It kind of goes away, whereas it remains on the right. Just a small, simple embolus from atrial fibrillation. You can see some tibials coming back there. And what we did was we actually used one of the aspiration devices. And this is the angiogram that shows the popliteal artery being patent at the top. Oops. Popliteal artery being patent at the top with the 2 tibial vessels. And then on the left, it's just the rotor going up and down. And then it looks a little bit better there, followed by a balloon angioplasty. And then the final angiogram. So you're done in one day without having the need to do repeat thrombolyses. Complications, you can get rhabdomyolysis and renal failure. A couple of years ago, again, in my early days, I tried to revascularize the leg that I probably shouldn't have done that, and the patient developed severe rhabdo. And then a couple of years after that, I didn't learn my lesson. I tried to revascularize again, but this time I thought, I'm smarter than this. This time I'm going to put the patient on dialysis right away and try to clear that. Did not work. So definitely 3B, sometimes amputation to save your life is probably better than a valiant effort to try to save a leg. Compartment syndrome, that requires a fasciotomy. What this picture shows, you make 2 longitudinal incisions on the medial and lateral aspects of the leg. You can also get a lot of arrhythmias from reperfusion injury as a result of the ischemia. And of course, even though you save the leg today, same thing can happen again tomorrow or next week when the patient gets discharged and you get limb loss. Which brings us to this last slide. Acutely, your risk of limb loss from acute limb ischemia is higher. And that's evident in the first year mark of the dotted lines being higher. But after that, chances are the patient is going to be on anticoagulation and things like that. The risk of limb loss is actually higher for the CLTI group because those are the ones with the chronic limb, probably more severe component of peripheral arterial disease. And that's when CLTI really becomes the major factor going forward. And your risk of limb loss is actually higher with CLTI after the first year. In conclusion, acute limb ischemia means a vascular emergency, immediate vascular surgery or IR consultation, start IV heparin, and goal is try to salvage the leg within the first 6 hours if you can. Thank you.
Thank you, Professor Lam. So we'll leave the questions till the end of the session. Next, I'll introduce my colleague, Dr. Tariq Barakat. He's a consultant vascular surgeon, joined Johns Hopkins Aramco Healthcare about 2 years ago. Before that, he was a consultant vascular surgeon in the UK, and he was trained in vascular and endovascular both in the UK and in Toronto. So Dr. Barakat is going to talk about the surgical role of vascular surgery in peripheral arterial disease. Thank you.
Thank you very much. Thank you very much. Sorry, there might be a bit of overlap between the talks. Thank you very much, Professor Lam. You have put a very nice foundation to my talk. And I do apologize for my fellow speakers if I intrude a bit to their talks. So I'm going to talk about the role of vascular surgery in peripheral artery disease. And in fact, the peripheral arterial disease is getting more and more. It was about 5.6%, but it has increased now to 7.4%, especially in high-income countries. It's usually underappreciated compared to coronary artery disease and cerebrovascular disease. And the importance is that 11% of them can develop and progress to critical limb ischemia. which is the worst part of the worst of ischemias. So presentation, I'll run into that quickly. Is asymptomatic, or it could be atypical symptoms, claudication, critical limb ischemia in the form of rest pain, ulceration, gangrene, and acute limb ischemia. These are claudication. There is intermittent claudication, which we know that pain which you get in the muscle group when they are in action and relieved by rest, or you can have neurogenic claudication, and also you can have venous claudication. Risk factors, as was mentioned previously, smoking, diabetes, and especially diabetes in Saudi Arabia is a big problem. 25% of the population above 30 years old is diabetic, and another 25% are pre-diabetic. So it's a huge problem in Saudi Arabia and actually in the Middle East in general. Hypertension, dyslipidemia, atherosclerosis, and old age. Imaging, we have our ABIs and toe brachial index as well, duplex scans, which are non-invasive, and then you can proceed to a CT angiogram or MR angiogram. And the best, which is the gold standard, which we use for diagnostic and therapeutic reasons, is a catheter angiogram. So what are the challenges when you are revascularizing these patients? These patients usually have got a lot of comorbidities. They previously had a heart attack or a stroke. They might be on dialysis, or they have renal impairment. If you are revascularizing diabetics, it usually affects small blood vessels, which makes their revascularization much more difficult. The risk of infection is high. These patients, their immunity sometimes is lower. And neuropathy and deformity, especially in diabetic patients, which predispose them to ulceration. So the management, conservative management usually, with smoking cessation, lipid management, blood pressure control, diabetes, antiplatelet therapy. When we come to claudication, most of the treatment of claudication is conservative. We only treat claudication surgically if it's really affecting the patient's quality of life quite significantly. And if the patient has got very short distance claudication, for example, like a postman, which is affecting his work, then you will think of intervening by either endovascular or surgical. And then you have treatment of critical limb ischemia, which you try your best to revascularize the patient, otherwise they will lose the limb. So endovascular management, we use a catheter angiogram to do angioplasties, stenting, thrombolysis, or thrombectomy, using a balloon or putting a stent to increase the diameter of the artery and allow more blood flow distally. So when we come to surgical management, what we do as vascular surgeons, we can do endarterectomy, in which we open the artery and we core the inside of the artery and close it with a patch, what we call patchplasty. We can do a bypass using a prosthetic material or a vein, which is usually the best, or we can use a composite graft, in which it's a combination of vein and prosthetic material. And when we do a bypass, it can be an anatomical bypass or extra anatomical. That means you take the graft not in the anatomical way, the route where your normal artery goes. And then when you fail, then unfortunately you go for an amputation. So important rules when you want to revascularize someone. You want to make sure that you've got a good inflow, and you've got a good conduit, your vein or your graft, and you have a good outflow because this blood needs to go somewhere. If you have got a blockage after you do the bypass, then the blood will not be able to flow and will become stagnant, and your revascularization will fail. And in general, a short bypass is better than a long bypass, usually. So here in endarterectomy, we open the artery, we take the inside of the artery, and we close it with the patch. This patch can be a vein patch. It could be a prosthetic patch like Dacron or PTFE, okay? We use a vein patch, especially if you are worried about infection. Or you can use a prosthetic graft here, like a Dacron graft, which is, in part of it is reinforced by rings so that it does not collapse. Or you can use a PTFE, which stands for polytetrafluoroethylene, what we call plastic. There is also Omniflow, which is a biosynthetic graft. And nowadays, people can use cryopreserved cadaveric arterial allograft. And these are usually used, they're quite expensive. And they take it from young patients who unfortunately died, for example, in a road traffic accident. And they treat it so that it can be used. And usually it gets used in infections. Other maneuvers which we use is to do a vein cuff, and that's all to try to improve the patency of your prosthetic graft. So between the prosthetic graft and your artery, where you are going to do your anastomosis, you stitch a vein graft, and that's all to try to reduce the turbulence and reduce the new intimal hyperplasia so that your graft survives as long as possible. Here, for example, if we go from higher up down, this is an aortobifemoral bypass where if you have an aortoiliac occlusion, you take a graft from higher up in the aorta and you tunnel it in the retroperitoneum and bring it to the femoral artery. This is like an anatomical bypass because the graft is it's going in the same route as the arteries. Then if you go lower, you have the femoropopliteal bypass, and usually we do it if you fail to revascularize the patient by endovascular means, or if the occlusion in your superficial femoral artery is long occlusion. So you do a fem pop, what we call a fem pop above knee, using a prosthetic graft or a vein graft. You can also go distally, below the knee, to the distal popliteal, or also you can go to the tibial vessels from the femoral. Extra anatomical bypasses, here we have, for example, like a fem-fem crossover. If you have an iliac lesion, for example, which you couldn't recanalize endovascularly, so if a patient, for example, is not fit to have an aortofemoral bypass, and you want an operation which is not a big operation because of their fitness, you can do a fem-fem crossover bypass, so you don't have to open his abdomen. This is an extra anatomical bypass. Also another bypass which is extra anatomical is for people who have got aortoiliac lesions, is to do an axillofemoral or axillobifemoral bypass. And it's a long bypass. You take it from the subclavian artery and bring it down to the femoral arteries. Just going back, there are also other bypasses, ultradistal bypasses we call them. If you want to go to the foot, for example, look, dorsalis pedis on the plantar vessels. Amputations, when you unfortunately fail and to revascularize the patient, they might end up with limb loss. And here, there are different types of amputation. You can have foot amputations, toe, transmetatarsal amputation, or a major amputation like a below knee amputation, or above knee amputation, even hip disarticulation. Here, there is a below knee amputation. We always try to go as distal as possible because the energy expenditure is less. If you do an above knee amputation, the energy expenditure is more than 50% compared to if you have your knee joint. So always we try to go as distal as possible. This is foot amputation, like big toe amputation and transmetatarsal amputations. So what's the prognosis, especially in critical limb ischemias? The 30-day mortality ranges from 70 to 22%. Your 1-year mortality can reach 40%, 50% in 3 years. Patients with critical limb ischemia, 80% of them die within 5 years of a lower limb amputation. So, actually, in fact, critical limb ischemia is worse than cancer. If you have an amputation, the chance of having the amputation on the other leg is 25 to 50%. And especially in diabetics, the chance of them having an amputation 10 to 15 times than the normal population. So, I think we have to consider peripheral artery disease as a global systemic disease. We need to treat it quite aggressively, especially in people with critical limb ischemia. It needs multidisciplinary team management from all sectors, and awareness of peripheral arterial disease and change in lifestyle. Thank you.
Thank you, Dr. Barakat. We'll leave the questions. Next talk is Dr. Shagran Mirkhamis. He is a consultant vascular intervention radiologist at King Faisal Specialist Hospital, Riyadh. Dr. Mirkhamis trained in vascular intervention in Toronto, and he worked in the King Saud University for several years before joining King Faisal. Thank you very much.
Thank you very much. Assalamu alaikum. It's truly an honor to be here. Thank you, Dr. Fahd, for the kind invitation, and thank you for the whole organizing committee. I haven't been really in the BAM for such a long, long time. So I'm going to be switching gears to more endovascular management, and the speakers before me, Professor Lam, Dr. Barakat, really have probably covered pretty much everything. So for the sake of time, I'm going to focus more on aortoiliac interventions. It's a bit closer to the heart, since we're in the HeartFusion, I guess. So, these are my disclosures. These are the outline of today's talks. So we all know the different task classifications. For every level of the body, there's something called the task classification of the type of occlusion or the type of stenosis or type of disease, which have specific recommendations for the type of treatment that should be done, either endovascular or surgical. Nowadays, pretty much everything is, or most things are more towards endovascular methods rather than surgery. The biggest debate is usually on the task D lesions, because they're the more complex lesions, they're the more occlusions, the ones that have aneurysms at the same time. These are the ones that have the more arguments between going to surgery or endo. But again, nowadays, with centers that have more experience, more skill, more equipment, more combined therapy between endo as well as surgery, are doing more surgery. So, the treatment options have already been covered very nicely, so I'm going to jump through it. We have endarterectomy, bypass, different types of bypass. I'm going to just go towards the endovascular part. So one of the things that I usually focus on when I'm training or teaching or even learning myself to do something new is not just how to do the procedure. I actually focus more on what are the complications of the procedure or the success rates of the procedure. That will help me be safer and help me know how to handle or how to deal with my issues with the patients, as well as counseling when I'm talking to the patient. So the complications are luckily low in terms of percentage, less than open surgery for aortoiliac interventions. However, surgery does still have better patency rates. These numbers are a little bit old, like about maybe 4 or 5 years ago. The patency for endo goes up to 90%, It's very variable, again, because it depends on which centers are doing it and what are the expertise in that hospital. But bypass has more morbidity. The most important concept is, as Dr. Barakat mentioned, is you have to have very good inflow as well as very good outflow. So patients that have poor SFA runoff or have poor below-knee runoff could also potentially decrease your patency if you're doing endovascular especially. We know that common iliac artery does much better job in staying open than the external iliac artery if you do endovascular, so we have to keep that in mind. But with the newer technologies and the newer devices we're using, we're getting better results, thankfully. The good thing, I think, about aortoiliac disease is you're very unlikely to ruin future bypass, except if you go crazy and go all the way down to the common femoral and all that stuff. But if you do a lot of infrainguinal interventions, such as SFA, distal, or popliteal, that's a bit tricky, because if you ruin that area, you're going to the higher chance of ruining the chance the patients to have a bypass or other alternative treatment methods. Okay. And of course, there are always hybrid procedures. We have to also think about approach. We have multiple different access sites we can use from the upper limb, either the radial or the brachial artery. You can also go through the common femoral artery, the upper SFA, or even sometimes the popliteal or mid SFA if it's occluded. It usually depends on the type of disease we're facing. So you can think about it in different ways, and you can use a lot of different combinations. For example, if you have like a Leriche syndrome, which is we call aortoiliac occlusion, involving just up to the common iliac artery, then most of the time you need bilateral common femoral, and you might need the upper extremity at the same time. You might not. If you have just stenosis diffuse, involving a little bit of the aorta, most of the time here it's simple. You can just do bilateral common femoral. Very rarely that you need upper extremity, but if the disease goes all the way down near the common femoral, you might access the upper SFA if the size is good enough, just to give you room for your sheath and your stent or whatever you're going to use. Or this might need to go to surgery directly, since it's a very diffuse disease, and especially if the vessels are small. If you have this type of morphology, it might be enough to have one access. You can cross, treat, and as you go back to the other access, you can treat from one side. So one access, of course, has less complication rates and it's going to cost, of course, less money because you need less sheaths and less wires. And so on. Depending on where you're dealing with, you can choose how your access might go. You just have to think about all these things at the same time. So what are my general tips and tricks? Some of it's from the literature, some of it's from experience. I think the first thing you need to remember is you need to remember what the plaque how the plaque behaves. So we know that the plaques in arteries, I'm not sure if it's similar to the coronary arteries, but the morphology of the proximal plaque and the hardness and the softness is different than the distal plaque. And depending on the shape, we know that it's going to be easier to cross from an antegrade approach or a retrograde approach. So for aortoiliac occlusions, it's very common that the upper cap is stiff. So if you're going to start from the top, you need a bit stiffer equipment and to cross from the top to get into that area of occlusion or thrombus. Then once you're in the area of occlusion or thrombus, usually a bit softer, you need something not that stiff so that you don't go to the subintimal plane if you can. And so more directionality to guide everything that you're going to do. If you reach to the bottom, or if you're going to go from the bottom, the distal cap is usually, most of the time, it's soft, unless the patient is very, very heavily calcified. So I don't like to use stiff equipment from the bottom, just because otherwise you're more likely to go subintimal. I try to stay intraluminal as much as I can. So try to think about all these things. General tips and tricks for aortoiliac interventions, or that can apply as well to any kind of endovascular, or even sometimes any kind of medical therapy, I guess, or treatment. In the end, first you have to be persistent. You can't give up easily, but you have to know what you're doing. I think it's always good to be liberal with your upper extremity access, just to save time, save radiation. I usually give myself a certain amount of time to cross from the bottom. If I cross, I'm happy, I'm done. If I don't, I go prep the arm, or the arm is prepped from the beginning if I know the chances of me using the arm are very high. I prefer using the appropriate size sheath from the beginning. So if I measured the vessels very well from a CT scan, and I know I'm going to use a stent that needs a 7 French sheath. So after I do my access, I prefer putting my 7 French sheath from the beginning. Some people prefer putting the smaller sheath, then after they cross, then they try to change it, just in case they can't cross. If there is dealing with an occlusion, And most of the time we use balloon-mounted stents. So these balloon-mounted stents can theoretically detach from the balloon as you're crossing the occlusion. And we usually don't like to do a lot of pre-dilatation in iliacs. So if you need to do, you can do a small pre-dilatation so that the stent doesn't get stuck. Or you can just put a long sheath across the occlusion, put the stent in, and then pull back your sheath. It makes your life much easier and you less risk for causing problems. I prefer starting with an 018 wire or more of a CTO if it's very calcified. And if I fail and I try a lot of things, my go-to wire is an 035 Advantage wire from Terumo. One of the key factors I think to do is don't give a lot of sedation, especially in the aortoiliac, so you can gauge the pain and stuff when you're doing your procedure, because the risk, if the patient rupture as he's sleeping, you might not really know it until his blood pressure starts to drop. Make sure you do a lot of views, and I'll show an example of that. You need to size very, very well. I know in the coronaries, they're very picky in sizing, which is great because the vessel is small, like half a milli different, or even 2 milli different, or half. Makes, like, it could be 10-20% difference in size. Same can apply for iliacs, same can apply for below-knees. So I usually measure from CT or ultrasound myself. I don't depend on angio ever because you're missing the wall a lot of the times, and you can use IVUS, but it's more expensive. Be ready, of course, for ruptures. I guess be ready for all complications. So if I don't have the equipment I need to deal with a rupture, I will definitely not even do the procedure at all. And if you cross very easily any kind of occlusion, always think in mind, because there's any acute component in that, so you might need to do some thrombectomy methods before doing your intervention, otherwise you're just going to shower everywhere. Have a re-entry device. This is something I'll show an example for. It's when you can't cross and it's a mess. You're going to fail because you don't have, if you have this device, it will save you a lot, and it's easier than telling the patient, sorry, I failed and I don't have a re-entry device. And of course, for any kind of surgical management, we always have to know when to quit. So these are my pearls collected from different people, and part of it is just from some of experience. So, complications, why? I have to review it now because people need to make sure that they know what is the complication of this procedure, what do they have to have ready. So one complication you can have a dissection, so you have to have on your shelf different types of stents to help you. You can of course have rupture, so it's the same concept. You have to have some stents, but you have to have balloons to be able to inflate the balloon until you manage what you're going to do. Even more importantly than that, you have to work in a place that has backup to do surgery, either yourself as a surgeon, or if you're an endovascular specialist that you don't do surgery, you have to have a place that's going to help you out if you need, because otherwise the patients will suffer. There are very rare incidences where you can actually cause bleeding from rupturing lumbar arteries when you're crossing an aortic occlusion. So it's always a good idea to have coils or somebody ready available to do embolization if you need. Thrombosis, you need to have mechanical thrombectomy, surgical thrombectomy. If you have distal embolization, stent migration is tricky. The best way is not to let it happen. So as I said before, do a little bit of pre-dilatation, put a long sheath across, and hopefully it will be useful. Okay, and then access site bleeding happens everywhere. So let's go for some cases. I'll cover a few depending on the time. So some of the videos might not work, unfortunately, but I don't think they're critical. Here's a typical, straightforward case of common iliac occlusion. It's very close to the aortic bifurcation, so you can argue, do I need to do kissing stents, what we call? You have the 2 stents all the way up like that, or is it enough to put one? That comes with experience and with time. So I tried to cross from the bottom. It didn't work. I kept going subintimal, and I don't like to go subintimal as much as I can, or if I go, I have to use a re-entry device. After that, go to the next step. So go from the left side. I use a reverse curve catheter. This is one of the techniques to use with a bit of a stiff tip, and then you just try to poke with any kind of wire that has a bit of a heavy, like say moderate to heavier tip load. You just want to penetrate the cap. Once you're penetrating the cap, you can, on the third video, you can see the wire now is going inside the other sheath. Then on the last video, on this video, you can see that we're flipping the wire, and then I always inject contrast just to make sure that I'm actually in, which of course is clear, but just to show it. So this is just different steps of doing from a retrograde way. Then the rest is easy. You choose your stent, you choose everything, it looks good, the vessel sizes are nice, okay? The video, okay, didn't work, sorry. Second case, this is one of the older cases. Nowadays, when these patients come with relatively smaller vessels, Especially if they're very healthy, then they were more likely to go for surgery. But again, most patients we have are very heavy smokers. They have a lot of other comorbidities. So this is not a straightforward case to do, not because of the crossing. The crossing most of the time is easy, but the problem is the vessels are small, the complication rates, the patency rates are a bit lower. But anyways, we crossed, we put the stent. Looks good, bilateral. These were uncovered stents that we were using at the time, especially for stenosis. I don't think it's a big difference. For occlusions, we definitely put covered stents from the beginning. The patient comes just 1 month after. His pain is back on the right side. The stent is occluded. This is the angiogram. You can see on the right side, everything is occluded. It's retrograde filling very, very slowly. So there's something probably tricky happening up at the top here. So I said, fine. The case was done previously, a month before, by another colleague. I came back. And I said, okay, it should be easy. I'll just cross and come from the bottom. Came from the bottom, tried. It was like a rock within a month. I couldn't cross. I couldn't do anything. Came from the top also, like the other technique we just showed, trying to go up and push. I couldn't. Then I said, no, maybe there's something. Maybe I'm missing something. So we went back to the previous image. And if you look at the previous image, you see the wire. Actually, part of the wire crossed from the side, so subintimally. And we probably placed the stent at one point in the subintimal plane. So that's why it just got blocked. So at this point, I said, you know what, I'm giving up. I'm just going to go with my re-entry device. This is the re-entry device, which is an outback. This is the L shape, which tells you where your needle is going to puncture. There's a needle that will puncture back into the vessel, and you just put a wire and it goes up. And then we extended the stent a bit higher while placing a balloon on the other side just to protect the contralateral limb. Okay? Of course, the same patient, sorry, you have to be ready for your complications. So, where's the video? There's a giant clot that developed during the intervention. So we have to take it out. Here you can go surgery, you can open it. Thankfully, we have thrombectomy devices like Penumbra and Rotarex, and this is what it looked like before, and this is what it looked like after, thankfully, with no showering. So for the sake of time, I'll jump this case. This is just showing a rupture, and we placed the covered stent. Smaller vessels, again, older patient that we did a long time ago, and nowadays, most of these smaller vessel patients we're trying to avoid. So, I'll jump this just for the sake of time. This is an aortic occlusion using bilateral re-entry devices to be able to cross the Leriche syndrome, and then we placed here what we call a CRAB procedure, which is the basically putting extended cover stents all the way across, and this is the picture of that. So, conclusions. I know my time is done. It's my last slide. So, for aortic interventions, we still do endovascular first. Preferably covered stents for common iliac, self-expanding stents for external iliacs. We try to preserve as many internal iliac arteries as possible. Patient selection is key. You have to work in a good group where you decide which patients need what to have better patency and better counseling. We need to always be ready to manage our complications in whatever kind of setting we're doing. And open surgery right now in our institution, we keep it for extensive diseases, but with good risk patients, which is uncommon, or small vessels, or failed endovascular interventions. Thank you very much, and sorry to take extra time.
Thank you very much, Dr. Khamis. I think we can have a couple of questions before we move to the aortic part of the session. Please, yeah.
No? Well, Rafael Astudio is my name. I'm a cardiac surgeon working in Uppsala, Sweden. And this is just a comment to my vascular surgeons, colleagues there. You mentioned graft infections, and that is a terrible issue, isn't it? What I have done in my experience regarding thoracic graft infections, You know what it means. That means a reoperation, of course, extracorporeal circulation, and sometimes deep hypothermic circulatory arrest. And then when you open and you see that the aortic graft is embedded in the pus, then you just think, what am I going to do? Well, what I have done, and it has worked out well in my hands, is that I have manufactured a new neo-aorta graft with bovine glutaraldehyde treated pericardium. And how do I do that? It's very easy. I done this. I mean, fortunately, it's not so many cases. Probably I've done 3 or 4 in my life, but I've done this in some other cases as well, like in type A aortic dissection. But those places were not infected. When they have an infection, it's just to explant the infected graft, measure with the sizers the diameter of the aorta, and then with the help of a HeartFusion dilator, and then I put 1 or 2 sheets of the pericardial, the bovine, and then around the HeartFusion dilator, and then I use the vascular graft that we are using for lung surgery, and then you have a neo-aorta graft of biological tissue in just 1.5 minutes. I just wanted to say that works quite well, and our vascular colleagues in Uppsala, they have used that in some cases in the vascular surgery as well. Thank you
very much.
Just, intriguing actually lecture, especially the one with the retrograde recanalization. So my question to you as a TAVI operator, we are seeing a penetration of intravascular ultrasound to optimize the femoral artery to do a TAVI. But there is a certain subset of patients where they have total occlusion, and we are creating a transcaval approach. And as you know, when we go to those meetings with the interventional cardiologists, we didn't see vascular surgeon, we didn't see most of our surgical colleagues in specific that sense. So would it be, what is better for the patient? If there is an option for recanalization and delivering a TAVI through a stented pathway, iliac, towards the aorta, or going through a transcaval approach from a vascular surgery perspective?
Go ahead.
That's a great question. I think you might have met Dr. Rani Hassan, who is a friend of mine, and he likes to do a lot of the transcaval stuff. I think it depends on the patient's indication. If they have asymptomatic from the peripheral arterial disease standpoint, I think doing a transcable is a lot easier. You don't have to subject them to any kind of complex endovascular or open surgical procedure. So in that setting, if they're asymptomatic from the peripheral arterial disease standpoint, I say transcable. Or in some circumstances, they're doing the transcarotid and things like that too. But I think if they've got symptoms, and everyone is pushing the limits. So for example, I've got colleagues in transplant surgery that want to push the limits in reconstructing the iliac arteries so that they can sew the transplant in. So they say, hey, can you reconstruct the artery first? And then you come to timing. You cannot use a deceased donor for the transplant, so you have to do an elective case to recreate the aortoiliac anatomy, and then you have to have an elective donor, a living donor, that's willing to donate the kidney in such severe cases. So people with severe PAD and chronic kidney disease, their survival is already going to be low. And then now you have to find a donor willing to donate a kidney for just a few years. So lots of complex things. I think it depends on what the symptoms are and how much you really want to push the limits.
I have a question for Dr. Yang and Dr. Ben Khamis and also Dr. Tariq regarding the timing of amputation in patients who developed acute limb ischemia, which is like established dead limb in a patient who was on ECMO. And that was like as a result of ECMO cannulation that you got a limb ischemia and now the limb is not viable. And we always worry about weaning those patients of ECMO of reperfusion injury. And we have seen a case like this before. Actually, several times we have seen this. So, and we always have this, conflict with the vascular surgeons about the timing. Should we do the amputation at the same time of weaning the patient of ECMO? Or maybe should we do the amputation before weaning the ECMO? Or should we even isolate the limb before weaning the ECMO to avoid that antegrade flow into a dead limb? I would like to hear your feedback.
Great question. I think one of the things which is important is the stability of the patient. The anesthetist here plays a great role. If they think that the patient really is not fit at this moment to go to OR to remove the limb, I think you just have to wait. But I think the sooner the better, really, to do the amputation. Because you have a dead limb, you have someone whose heart is not great, you have the risk of all these unhealthy metabolites to go back to their heart, which are harmful. So I think the sooner the better, if you can.
Our cardiac surgery colleagues like to use ECMO as well. So for a while, we were the ones doing the distal perfusion catheters, and then now our cardiac surgery colleagues can do the distal arterial perfusion catheters at the time of the insertion, and that's decreased the limb loss or limb complication rates. And then on top of that, monitoring ahead of time with the NIRS on the leg, that's also helped increase early detection of limb ischemia to try to prevent the problems. Now, I think when someone has got ECMO and the limb is ischemic and dead despite whatever you've done, if they're coming off ECMO anyway, I think in your case, like what you're talking about, if they're going to be decannulated, then I think doing it at the time of the ECMO decannulations makes sense. The amputation doesn't have to be the formal amputation. You can just do it quick. Just do a guillotine, take a leg off, takes 5 minutes, maybe 10 at most. And that would be done at the same time as the decannulation. So you save one trip to the operating room, because it's not the number of trips to the operating room. I mean, I think the number of trips to the operating room with all this stuff is problematic. You transfer the patient, something gets dislodged. All those things are probably bigger factors. So I'm more in favor of doing a simultaneous procedure at the time of decannulation if that's the indication. And quick procedure first, just take the leg off. You can always leave the leg open. For the knee, instead of doing above the knee, I like to do knee disarticulations. That's very quick. And if it's just the distal foot, I like to do ankle disarticulations just because it's so much quicker. I don't have to wait for the staff to get me the saw or the giggly saw or any power saw. I can just use scissors and just cut any of these amputations.
I have a question. I have two questions first. The first question, Dr. Long, you said this coronary artery disease is a risk factor for coronary artery disease. My question, when patient comes to you with a PAD, and he's asymptomatic from his heart, do we need to check his coronary or not? Does it cost effective?
Are you talking about cardiac CTs?
Yes, or angiogram. I mean, do we should worry about it or even look for it or not? Because he said most of it's going to die from his coronary, not from PAD.
Yeah, I think it depends on the PAD. If the PAD is symptomatic, and if I was going to do any kind of intervention, then I would ask them what their symptoms are from their coronary standpoint. I think there's good data to suggest, like the Capri study, that preemptive cardiac evaluation prior to peripheral arterial disease didn't really change the outcome. So I think if as someone that's symptomatic from PAD, I'm going to do something, I'll see what their coronary situation is in terms of symptoms. If they're asymptomatic, I might just do an echo and nothing else.
Dr. To the panelists really, the main question is still now not answered, is what's best for CLI, endovascular or open? If you look, the best CLI is still, they said surgery is better. You look at the other trial, said no, endovascular first is better. So I just want what perspective of the panelists about what the best treatment for patient with CLI, endo or open?
Well, I mean, I think the easy way to say is that both are good, But it really depends on the expertise in that place. If that place are experts in endo, they're going to have very good endo. And if they're experts in open and they try to do endo, they're not going to have good results. So I think that's one of the most important issues that happen with the best CLI in these kind of studies, because it happened in places where they have expert this kind of thing. Of course, you're going to have good results. So that's how I would put it.
I think the Basel trial probably answered that. So it depends on the other comorbidities. If the patient is expected like not going to live for many years, then endovascular will be to try first. If somebody younger and not other like bad comorbidities, then surgery lasts longer.
I think if you look at the Basel trial, the first one in patients who have got a life expectancy of 2 years or more, bypass was better. But when they did the Basel 2, they thought that endovascular treatment first probably is better. And if that fails, then you can go to a bypass. So I think overall, if the lesions in your arterial tree can be managed by endovascular means, these patients usually are frail, they have a lot of comorbidities, better to try it first. And then if it all fails and they are fit to have a bypass, then go for a bypass then. We know that even Basel III, when they compared even all the types of drug-eluting stents, bare metal stents, and also drug-eluting balloons, they found no significant difference in clinical effectiveness between them.
Right.
One question, Jutta Arends, University of Twente in the Netherlands. I know you're a surgeon, so you're looking at surgical solutions for your patients, but I was wondering if you combine your efforts with hyperbaric oxygenation therapy, because that has proven to decrease the need for amputation in these cases.
What's the lump you
At least in the US, hyperbaric treatments are sometimes not covered by insurance, just because the results, I think, yes, there's some studies that show it works, but there are also studies that show that it doesn't make a difference. I think the real question is how extensive of a revascularization you do. If it's just something like toe gangrene, I think sometimes you do not need all inline flow all the way to the toe, although there's a classic teaching. I think in some of those cases, sometimes just doing a proximal inflow thing and giving them some time, it might be enough to heal the wound, so you don't go crazy by doing a distal bypass up front. So I think it really depends on the patient's situation. If you've really done everything else possible, there's nothing else. There's also lymph flow, right, and all this other stuff you can do for below the knee and small vessel disease. So yes, I do hyperbaric on some patients, but not routinely on all patients, because the data is not great for all patients.
Can I say, Dr. Tariq, just to continue my questions. My question was for the patient who fit for both. I know a patient not fit for surgery, of course, going to endovascular. But my question, patient who fit for both, which one should go? The first thing. Second things, if you look at the Basel II trial, showed if you do bypass after failed endovascular, even Basel II, the outcome is worse than if you do primary bypass. So it's very important, I think, from the beginning, when you see a patient, you decide, is this best for endo or best for open? And if you agree.
I agree. I think if you have, for example, one vessel runoff, for example, and you have a complex endovascular solution, I think if the patient is fit, it might be better to do a bypass, especially because the last thing which you want is with a complex endovascular procedure, then you embolize into that single runoff and it's lost, and then you are doomed. So I think probably better in that case, for example, that's just an example, is to go for a bypass.
Thank you. You mentioned in your thank you for the presentations. Saudi populations carry high prevalence of the diabetes, And you mentioned already 40% about diabetic foot. So from Baltimore now, there is any model for predictions, preventions in early stage, especially for SORI community, which work better?
For diabetic patients?
Yes.
I think, the podiatric and SVS came out with some guidelines, I think 2019 or something like that, about annual foot exams. So I think the multidisciplinary clinics, and Dr. Masloom is actually in Baltimore now trying to replicate these things. Having a multidisciplinary clinic where the one patient in that one visit sees the endocrinologist for the diabetes, sees the vascular surgeon, and the podiatrist. That way you're not having the patient have to come back multiple times and loss of follow-up or coordination of care. In the one clinic, in the same room, they get to see 3 of the doctors. You do the annual visits. And I think that model has shown to be quite successful in terms of trying to reduce the chance of recurrent diabetic foot ulcers. Because as you know, once you have lost one toe, the chance of recurrent amputations is high. So you really have to have good secondary prevention on top of primary prevention as well.
Right, well, thank you very much. So we'll move to the next session, which is the aortic session. And it's my pleasure to introduce Dr. Samer Kusayr, who is a vascular endovascular consultant at Rashid Hospital in Dubai. Previously, he was working as consultant vascular surgeon at King Faisal Hospital, Specialist Hospital, Riyadh. Dr. Samer, thank you.
Thank you. Thank you, everyone, and good afternoon. First of all, I'd like to thank the organizer committee for the invitations. I'm going to speak, I really pick up this subject because aortic arch is still a gray area. We know ascending aorta all go to the cardiac surgery, descending go to the vascular, but the arch used to be for the cardiac surgery only, but now slowly we are shifting to vascular surgeon. So I'm going to speak about debranching repair of the aortic arch aneurysm technique and result. Of course, we divide the arch into 4 zones. Zone 0, which involving the ascending aorta and intimate artery. Zone 1, involving the left origin of the left carotid artery. Zone 2, involve the origin of left subclavian artery. And zone 3, distal to the left subclavian artery. And according how much we go in the arch is different technique to deal with that. So let's talk about zone 2. If you have to go and put like stent graft and covering left subclavian artery, usually it is required in about 10 to 50% of the cases. And we know the left subclavian artery is very important for upper extremity perfusion, especially left vertebral artery, if it's a dominant one, is very important for posterior circulation and very important for spinal cord perfusion, especially if you cover the thoracic aorta down to the celiac artery. Also, we have to know that limma is very important, especially for the cardiac surgeon if he decide to do a CABG. But in general, covering the left subclavian artery is very well tolerable in about 90% of the cases. So what options we have? If you have to cover left subclavian artery, you can do a chimney, you can do a periscope, or you can do in situ fenestration, which is very common now, or you can do the new branch TVAR from Gore, or you can do carotid subclavian bypass. Some people, they do it for all patients when they cover left subclavian artery, but I like to be very selective when I do that, especially if patient has a limma, has patent limma to LAD, or he has upper extremity dialysis access, or he has the dominant left vertebral artery, or the left vertebral artery coming off the arch. And strongly, we have to consider doing the bypass if patient has extensive aortic coverage to decrease the incidence of paraplegia, and if patient has a prior AAA repair or occluded internal iliac artery. If we have to go, what the SVS guideline tells about left subclavian artery coverage, they said if you are doing an elective TVAR and you have to cover left subclavian artery, then revascularization of left subclavian artery really is suggested. But if you're going to cover left subclavian artery and going to compromise blood flow for the left upper extremity, then it's recommended to do a bypass or revascularization endovascular. And if you have an emergency, then covering subclavian artery should be individualized. It depends on the urgency of the case and the need to do a revascularization of the left subclavian artery. What if I have to go more now proximal to the covering the zone 1, which is covering left common carotid artery? We have 2 options, endovascular option by doing a chimney, or we can do carotid bypass. But the really challenge if we have to go all the way down to zone 0 and we have to cover the all aortic arch vessels.
Of course, surgery is still the standard for these cases, but the problem with the surgery, it's technically demanding, required cardiopulmonary bypass, deep hypothermia, circulatory arrest, cerebral perfusion, and prolonged recovery. So as we said, in cardiopulmonary bypass, you have to reperfuse the brain, either integrate or retrograde, and the most important, you have to do a deep hypothermia so you can buy more time to work on the arch without perfusing the brain. And we know that in normal temperature, you have only 4 minutes to work on the brain, to stop the blood flow to the brain. The more you go deep in the hypothermia, you can have more time. So if you go to 11 centigrade, you can have up to 60 minutes to work without perfusing the brain. But the problem with the hypothermia is very bad because it has an steroid effect because it affects the wall of the cell, which can cause water leaking out of the cells. It has a lot of systemic effect, like cognition. It can affect your cognition function. It can cause a shock, can cause a renal failure, can cause rhabdomyolysis, neuropathy, or gangrene. Also, it has a lot of tissue effect because it damages the intima of the vessels, which can lead to the lactic acidosis or vascular insufficiency. Also, it has open repair of the aortic arch. It has a significant morbidity. You have neurological impairment can go up to 20%. Acute renal failure can go up to 7%. MI, reoperation, bleeding, sepsis, and mortality can go up to 18%. This is the reason why we start thinking about something replace the aortic arch surgery, especially in high-risk patients. Of course, patients are good fit for surgery. Still, surgery is a standard. So we came first with what's called hybrid arch repair. We have two kinds of hybrid repair. We can have total hybrid arch repair, or we can have a combination of chimney and extraventricular bypass. So let's talk first about total hybrid repair. The way we start first, we can create a Y graft. By one limb will be large, about 10 to 20 millimeter. A second limb is 6 to 8 millimeter. Or you can use a orthobiFEM bypass graft and put it in reverse position. After that, we do stenotomy. We open the pericardium. We dissect the ascending aorta. We mobilize the left element vein, and we pull it up. And after that, we put a side clamp. You have to put on the side of the ascending aorta as low as possible. Then we bring our orthobiFEM bypass, and we're suturing using 3O or 4O proline. After that, we start first with the innominate artery. We transect it. We suture the stump with a 4O proline. Then we bypass the limb under the innominate vein, and we do end-to-end anastomosis. After that, we go to the left common carotid artery. The same, we close the stump and end anastomosis. And the last thing, subclavian artery. But subclavian artery sometimes is very far. We cannot see it with sternotomy. Then we can leave it, and then we can do carotid subclavian bypass through the neck incision. This is one of our cases where you have arch aneurysm, and patient was very high risk for open repair. And this is, you can see our graft, the orthobiFEM, put in reverse position. We did the first limb going to the innominate artery, and second limb went to the left common carotid artery, and then we did carotid subclavian bypass through the neck incision. This is then you do a T-bar after that, covering all the aneurysm, and this is during the procedure, you can see complete exclusion of the arch aneurysm with a patent debranching graft. And this is post-op CT angiogram with a good result. Sometimes the artery could be very high or very difficult to reach there. Then you can do what's called sutureless anastomosis. The way we do that, you bring the graft. We're going to do anastomosis to the left common carotid artery. We put a sheath on the side of the graft, and we put the wire through the graft to the inside the artery, and then we deploy a Viaband from inside the artery to inside the graft, creating end-to-end anastomosis without any suturing. And this is very common technique. We use it when you have a difficult anastomosis, end-to-end anastomosis between two arteries. The second option is to do, if patient cannot even tolerate sternotomy, then the other option to do is to put a stent in the innominate artery and do, through neck incision, just do carotid bypass and carotid subclavian bypass. So this one you can do total debranching without opening even the chest. So how good is this technique? This is a very nice paper came from UK. They did meta-analysis of 195 patients. They underwent total debranching of the aortic arch. Morbidity was 21%, mortality 9%, stroke rate 7%, and endoleak about 9%. So still this device and this technique has a significant morbidity and mortality. And they conclude that hybrid repair of complex aortic arch disease is alternative treatment option with acceptable short-term result. What about the chimney? This is a nice paper, came from Greece, from Dr. Constantino. He reviewed about 124 patients, 136 chimney. Primary success was about 99%, perioperative mortality about 5%, stroke rate was 4%, overall endoleak was about 18%, and we follow up this patient for 1 year, all the chimney grafts were still open. So what he concludes that endovascular aortic arch repair using a chimney associated with a lower mortality rate if we compare it with a total debranching or open repair of aortic arch pathology. I'll give you some tips and tricks to get this very good result with any of this technique. The first thing, you have to choose the right patient. You need to avoid the shaggy aorta or heavy calcified or floating thrombus in the aortic arch. The second thing, you need to occlude all the arch artery before doing a bypass to prevent any embolization to the brain during the procedure. The third thing, you need to avoid zone 1 because the distance between really left common carotid artery and the innovative artery is very short, only 1 centimeters. So if you have to land in zone 1, it's better to go to zone 0, get better sealing, and then do complete debranching. The second thing, the ascending aorta should be less than 38 millimeter because the largest TEVAR we have in the market is 46. So if the ascending aorta more than 38 millimeter, you cannot do total debranching unless if you replace the ascending aorta with the graft first, then you can do debranching after that. You need a lot of adjuvant during the procedure. You may need a EEG, rapid pacing, and TEE. Avoid the graft kinking. So you have to put the graft in a way that when you close the sternum will not compress the graft. So you have to be very careful when you design your graft the position to prevent it any kink. You have to avoid dissection of the ascending aorta when you clamp it by avoiding any adventectomy. Use a fine needle 4O, large bite, and Teflon plug it to prevent any dissection in the ascending aorta. And finally, you need to individualize or tailoring your surgery depend on the anatomy of the patient and how many bypass you have to do it. So last thing, give you some parallel and pitfall. Again, debranching should be placed. The most important to put debranching as low as possible in the ascending aorta because you need enough space of the aorta to accommodate the TEVAR when you deploy it. This is your landing zone. And if the ascending aorta, as we said, more than 34, then you have to replace the ascending aorta first. If patient has mechanical valve, is a problem because when you deploy the TEVAR after you do debranching, the bullet of the TEVAR has to go through the valve. So if patient has mechanical valve, you cannot pass the device to deploy the TEVAR. In this situation, it's better to put a conduit in the debranching graft and deploy it in antegrade fashion, not through the femoral artery. When you put your clamp in the ascending aorta, try, because as we said, you have to put as low as possible. You have to be very careful not to injure it to the right coronary artery. And you need to lower pressure less than 90. And finally, if the subclavian, you cannot reach it through the sternotomy, just close it and do carotid subclavian bypass. And again, the graft, when you put it, the most important, don't put it on the anterior aspect of the ascending aorta. You have to put it on the right side of the ascending aorta, because if you put it on anterior to ascending aorta, when you close the sternum, this will be compressed. Thank you very much for your attention.
Thank you, Dr. Qusayr. I think if we can have Dr. Qusayr next talk. So the one not immediately after, the one after that. Update on total endovascular repair of aortic arch aneurysm. No, the next one, the next talk.
This will be a continuity to the same subject, but now, again, as we saw, the debranching procedure has significant morbidity and mortality, and chimney is not the best option. Now, most, people shifting mainly to the complete endovascular repair of the aortic arch, aneurysm and pathology. So I'm going to give you how much update on the complete endovascular repair of the aortic arch and where we stand today. So we talk about this zone. I don't have to go through it. As we said, if you cover left subclavian artery, the option is very easy. Is do chimney, periscope, in site of fistration, or branch TEVAR. If you go to the left common carotid artery, you just do chimney. But again, the most difficult challenge is zone 0. This is a problem where all total endovascular devices coming out to the market now. So aortic arch aneurysm and dissection are the most challenging for the endorenal grafting. And evolution of endovascular therapy has expanded our option. It gives us a new tools, a new concept to deal with that. But the problem is not as simple procedures, and the problem, it creates uncertainty for the future. So we don't know how this device really will work on the long term. The reason why we're still always saying that all this procedure should be only patient for high risk, cannot fit for surgery. So we have 5 devices available in the market now. We have one from Tetrouma, which is the relay plus double branch device. We have the single branch from Gore. Medtronic, they have a Zenith Arch branch device. And we have from JHAH, we have a Nexus stent graft system. And from the BTMC, we have Innovi stent graft. I'm going to go through each one. First one is from Tetrouma, the relay branch thoracic stent graft. It's a custom made, it's double branch. It has 2 inner branch, and it has a window at the upper part of the aortic of the stent graft. So what happened? You deployed it, then you go from the left common and right common carotid artery, and you deploy 2 stent. The only problem is that before you do that, because it doesn't have any window for the left subclavian artery, so you have to do left carotid subclavian bypass before you deploy this device. So this is a device you do first left carotid subclavian bypass, and you deployed it. Then you go from right and left common carotid artery, and you put your cover stent inside the inner stent inside this device. How good is this one? It comes from the Italian registry called a TRIUMPH registry from Italy. They use this device in 24 patients. The in-hospital mortality was about 16%. Cerebral event was 25% with a 3 major stroke. Retrograde dissection about 8%, and no type 1 or type 2 endoleak. So what they conclude that endovascular aortic arch repair using the double inner branch stent graft is feasible and result in acceptable result in high-risk patient. The second one is from Gore, which is a single vessel branch, and you can go the single vessel, you can put in the left subclavian or left common carotid or in innominate artery. But the more you go distal, then you have to do anatomical bypass to the carotid or carotid subclavian bypass. How good is this device? This is a multi-center prospective non-randomized short cohort study, 31 patients, and they found the success. The side 30 days outcome, side branch patency was 100%, freedom from type 1 and 3 endoleak was 97%, and this or paraplegia was 0%. The third one is from Cook, which is the Zenith Arch branch graft. It's a patient-specific option. It has come with a 2 or 3 inner branches, depending how many arteries you're going to debranch it. Both brachiocephalic and left common carotid artery usually connected in a retrograde fashion, and usually use self-expandable stent like Fluency or Viabahn to bridge the stent for the inner branch inside the TFAR. How good is this one? Dr. Stefan Holon, he has the most experience with the Cook device, and he did 38 patients. Technical success was 84%, 3 days mortality about 13%, stroke at 11%. So he concludes the study confirms the feasibility and safety of the endovascular pair of arch aneurysm using Zenith branch graft. Number 4, we have a Nexus aortic arch. This is the only one off the shelf. This is a good thing about this device. This is from JHAH. It has 2 pieces. The first one has a branch which goes to the innominate artery, and the second piece goes to the ascending aorta. So 2-piece component to make it easier and to be off the shelf can be used. And of course, after that, you have to do carotid, and carotid subclavian bypass. How good is this device? This is a paper where they review 28 patients. They use a Nexus device. 30-day success rate was 96%, freedom from procedure-related mortality 93%, no stroke, paraplegia, MI, or aortic regurgitation. So they conclude the Nexus aortic arch stent graft demonstrate a high success rate with excellent 1-year safety and performance. The number 5, Innovi stent graft from BTMC. This is only different from the other one. This is a branch already connected to the stent graft. So what happened? It has a pre-wiring. So you have to go from left common carotid artery and right common carotid artery and snare the wire and pull the side branch inside the branch artery. So it can come with 1, 2, or 3 branches. The most experience came from Japan. They did it on 89 patients. 30 days mortality was 4.5%. Technical success 100%. Period procedure stroke 16%. Freedom from aneurysm-related deaths about 93% at 5 years follow-up. So what they conclude, this device is good when you use it only for one branch, but the more you do 2 or 3 branches, you have higher mortality and morbidity with this kind of device. I think the promising one, this one I saw, this is in China. It's coming out very soon from LifeTech. It calls a concave. The beauty about this device is the upper part of the stent graft has a window. It has 3 inner stent, go antegrade and 1 retrograde. And it is very easy to deploy. You just deploy it and then you go from the left and right common carotid artery, and then you put your cover stent, and then you go from subclavian and you do periscope. Again, this is not available yet in the market, but it's coming very soon, and I think it will be very promising because it's very easy to deploy it with a good result. What about fenestrated custom made? What about custom made fenestrated from Cook? This is a nice paper. This is a single center retrospective study, 44 aortic arch repair with fenestrated stent graft. Technical success was a very good 95%, 30 days mortality 9%, a major stroke only 7%. What about in situ fenestration? Usually we do it for left subclavian artery. It's very common now these days. It's very easy. You can do it with a laser or you can do it with the needles. And how good is this one? This is a paper from Norfolk in the United States. They did 22 patients undergo laser fenestration of left subclavian artery. There was no fenestration morbidity. The hospital mortality was only 4%, primary patency 100%, and no fenestration related type 1 or type 3 endoleak. So they conclude that in situ fenestration, laser fenestration is feasible and effective option for left subclavian artery with high technical success, low fenestration morbidity, and excellent midterm patency. The last thing I want to mention that after you do all this procedure, sometimes you get type 1 endoleak, so we have some tools to deal with that, like endo anchors. Like this one, our patient, after we did total debranching with a TIVA, you can see type 1 endoleak. So you go there and you put endo anchors, and this will seal your endoleaks. So this is something you can think about it if you develop a type 1 endoleak during the procedure. So conclusion, rapid improvement in endograft technology over the last 10 years has expanded the indication for endoluminal grafting. We have a lot of options. We have fenestrated, branch graft, hybrid repair, chimney technique, and all various available, but only for high-risk patients. So which one we should choose, it depends on your experience, availability, and urgency. But the long-term result for all this device is still unknown. And the most important, if patient is fit, we still think that open repair should be the first and best option for aortic arch pathology. Thank you very much.
Thank you, Dr. Qusayl. Now next I'd like to invite Professor Raffaele Studello from Uppsala University, Sweden. Professor Studello is a cardiothoracic surgeon. He did his vascular surgical training in Karolinska, and he's going to talk about the residual false lumen after acute type A dissection. Thank you very much.
Thank you. First of all, I should like to thanks to the organizing committee for inviting me here and giving me the opportunity of exchange our experience with this novel surgical method. And a special thanks to my friend Dr. Fahd, who invited me to this meeting as well. Well, Dr. Evangelista and his group, I have been following him for decades, and he is one of the many groups that has highlighted how important it is not to have a patent false lumen after type A aortic dissection. This is another paper showing that a patent false lumen in the long term is not a good business, especially for a young population. I want you to take a look at this slide because this is very important. I mean, the entry tears location in type A aortic dissection is located in 50% in the ascending aorta, in 33% in the arch, and 15% in the descending aorta. Remember this. What we are doing, usually in the middle of the night, because these patients are arriving to the emergency room with pain, and sometimes they get the antiplatelet treatment, and that makes our surgery time considerably longer. This is what we are doing, and this is correct. We are saving the life of our patients. This critical disease has 1% mortality for every hour that goes untreated, and the mortality rate, even with surgery, is 15–16%, and the stroke incidence is the same. It's below 20% sometimes. But what happens when we just implant a supracoronary graft and we send the patient home? Well, we are leaving this patient untreated because the patient still has his tear entry in the arch and sometimes even in the descending aorta. And what does it mean? Well, a remaining false lumen demands a reintervention rate, or has an intervention rate in the long term, of 25 up to 50%. In some papers, it has been reported up to 60%. And that means that to have a patent false lumen is not a good idea. The remaining false lumen and the flow that is circulating in it, it's very complex. But what I can say is that depending on, reading some computerized studies shows that there is still a flow with a very high flow, very high blood flow velocity, and even pressure in the false lumen. And this has been studied with Darcy's law. This is hydraulics issues included in medicine, because the flow in the false lumen is very, very complex. One of the reasons, because we still have a patent false lumen, might be this DANE. DANE is is the acronym for distal anastomotic new entry. And you see, when a patient arrives with a type A aortic dissection, the inflammatory response is extremely high. Can you imagine working with these tissues that are very inflamed? It is just like trying to suture a soft cheese. They're so fragile that it's not holding our sutures. And in this picture, you can see the head of the patient to the left, the new entry marked with a star. The new entry is usually, in this surgeon's view, situated between 10 o'clock and 12 o'clock in the ascending aorta. And these are some of the papers with the computerized models showing that the blood flow in the false lumen varies a lot depending on the diameter or the length of the entry, the tear entry, if it's located in the ascending aorta or in the descending aorta, and even the size of it. Different flow patterns have been seen in cases like this. I should say that it's extremely complex, and that means that the patent false lumen after type A aortic dissection is very complex. This is another paper showing that if the correlation between the diameter of the false lumen compared to the true lumen, for the ones that are not surgeons, this is the small one here is the true lumen, and the big one is the false lumen, because in an aortic dissection, the false lumen always takes over and is closing all exit of many different branches that our vascular surgeons colleagues have to help us with. If the if the diameter of the false lumen is larger than the true lumen, then this will have a much worse prognosis. Let's talk now about the novel surgical approach. I have been working with this many years. I am in the last years of my career, and I have always said that to implant a vascular graft in the ascending aorta is good, but it's not enough. And it's me who has been doing the reoperations of these patients afterwards. And that is a lot of work. I should say that it's 5-6 years ago at the Uppsala University, I had the privilege, together with our vascular colleagues, to get a nomination as the Aortic Center of Excellence. And that was the result of our very close work. I mean, it was a privilege, actually. The goal of this novel approach is to prevent further dilation of the aortic arch and descending aorta, as well as to try to seal the tear entry and depressurize the false lumen. This is done by placing a blocking device membrane that is still under development into the false lumen of the aortic arch. The insertion of the membrane into the false lumen in the aortic arch is done like this. It's very easy. Let's see if I can start with the video. The head of the patient to the left. And what we are doing is just putting inside, as long as we can, a pericardial membrane, a glutaraldehyde pericardial membrane, like that. The assistant is helping me to assess the false lumen. This has to be secure, and what we are using is a 4O Petroleum, and using a pericardial strip as well. As you can see, that is folded several times. 4 to 6 of these sutures are used, and we are from the true lumen. We are going through all aortic layers, including the pericardial membrane, taking the needle out and then placing another platelets in the outside, just like a sandwich technique, nothing else. 4 to 6 of these sutures, of course, you have to be very careful not to include the exit of the vessels going to the head. And this is how it looked like. You see, this is the graft in the ascending aorta, and there we have the intima layer, and we have the membrane, pericardial membrane in the false lumen, and the adventitia outside. And here we have additionally a pericardial strip in order to reinforce the suture line. But let's take a look at the CT images. To the left, we can see the aortic dissection membrane in the arch and how it looked like 6 months later. Now, if we take a look at the descending aorta, there it is. To the right, we have the 6 months later. We see that the dissecting membrane has disappeared. And this is another case. As you can see, the descending aorta has healed so well that it seems like this patient has never been sick. This is another patient. You see the arch, and this was the CT control was done 5 days after, and you can see that there is no contrast in the false lumen. And even more, the same patient 5 weeks later, we can see that the thrombus in the false lumen has started to reabsorb. This is a patient as 5 weeks later as well. We can see that the dissecting membrane in the descending aorta has disappeared, and we have just the thrombus and the false lumen. This is another patient. And this patient, this is a particular patient. This CT control was made 5 hours later after arrival to the ICU. And we can see, I mean, this is something that is new. We are ourselves still learning of it. And this is the way it looks like 5 hours later. You see that the true lumen has gained again his true lumen. And in the false lumen, we have a thrombosis that is already formed there. And this is the same patient in the arch. You see how it looks like before and just 5 hours later, the patient arriving to the intensive care unit. And what does it mean? It means that the thrombosis in the false lumen is probably the first stage in order to get healing of all aortic layers. That's why. It's not more difficult than that. And this is the same patient in the sagittal view. The descending aorta has gained again his true lumen. Otherwise, this should or could, if we shouldn't have used the technique with the membrane in the arch, it might be that the preoperative CT scan might look exactly the same afterwards. And you see here, this is a typical example of the true lumen, the tiny, tiny, tiny part here. And then 5 hours later, it has already gained its diameter. But let's talk about results now. 144 patients have been included in the study. 51 treated with this device, blocking membrane. And I have to confess that at the beginning I was disappointed because we couldn't see any difference regarding the 30-day mortality, the stroke incidence, the reintervention rate, or even the thrombose false lumen. Even though, and I have to say this very clear, even though this didn't reach the level of statistical significance, there was a numerical trend towards a better result than in the control group. And this is another very important issue. You see, a patient with a type A aortic dissection, the problem has always been the aortic root that is dilating, and then you get a aortic valve insufficiency, or even the arch or descending aorta. But in this study, the aortic root diameter did not differ 6 months later. It was not a statistical significance, and this is due to the fact that in both groups, in the membrane group and in the control group, all these patients were repaired in the aortic root. This is very important. Patients were repairing the aortic group in both groups, and the aortic root diameter was the same 6 months later. But now comes the most important thing, the aortic arch diameter. We could see that the blue line is the control group, and the orange line is the membrane group. We can see that there was a statistical significance in both groups, because the aortic diameter in the membrane group was decreasing, and that was not happening in the control group, and that was a statistical significant. What does it mean? Well, it could mean that in the long term, this might have a good prognosis or good effect. And what about the proximal descending aorta diameter? Here we could see a tremendous change. We could see that still the blue line is the control group, and the orange one is the membrane group. We could see that this was a statistical significant as well. That means that the patients in the control group, they are dilating, and that is not happening in the membrane group. If we summarize this, the aortic root was the same in both groups, and it might be that it was because of in both groups the aortic root was repaired in some way. Sometimes we made different techniques there, but it was repair. But in the aortic arch and proximal descending aorta, there was a difference. Take-home lessons. Well, what should I say? We still have a lot to learn. Surgery for type A aortic dissection still carries a high morbidity and mortality rates. It's a terrible disease. Surgery for type A aortic dissection has important limitations in follow-up, particularly regarding the aortic root and arch in terms of surveillance and the need for reinterventions. We all know that these patients are, when we are operating these patients are, until some years ago, these patients were customers for us because we were controlling them every year with a CT, and we were just taking a look at the CT. It's not dilating. We wait 1 more year and see if it starts to dilate or not, and then we could derive the patients to our vascular colleagues, and in order to probably use a TEVAR. And despite recent advances in acute type A aortic dissection surgery, the field still remains open to new approaches and challenges. I know that the endovascular total arch is going very fast forward. That was one of the reasons because of creating this aortic center of excellence in Uppsala, that is the only one in North Scandinavia, in North Europe. It was because we could agree that we can, share patients. This patient is not good for surgery, or this patient is not good for the other treatment. Then what do you think? I think that we should try this with a total endovascular repair. And well, it's 1.5 years ago since I quit in Uppsala, but I think they almost completed 50 patients treated like that with the customized Cook. And I don't know the exactly results, but I know that the stroke incidence was a little bit complicating factor in this, but they're going ahead. And that is the future. The tiny surgeries, as Dr. Lima said this morning, before big incisions for big surgeons, now it's small incisions to big surgeons. I think that was my last slide. Thank you very much for your attention.
Thank you, Professor. I think we'll leave the question at the end. So next I'll invite Dr. Samer again, please, to talk about how to prevent stroke during TAVI procedures.
Good afternoon again. We know that stroke is a major comorbidity after TAVI. So this is really, I'm going to take how is anything we can do differently to just to decrease the incidence of stroke during TAVI. The incidence luckily is not very high, it's about 2 to 3%, and the majority of the stroke happen first for 24 to 48 hours. But if you look at the silent cerebral embolic event during TAVI, it's very high, it's about 80-90%. But it doesn't have a clinical outcome because they are very silent. They go to the part of the brain you cannot see it, But a lot of studies show this silent embolic, it increases risk of future stroke, can cause dementia in the long run, depression, cognitive impairment, and early death. This is a very nice paper. They measure the TCD, which transcranial Doppler, detected the hits to the brain by using MRI during TEVAR procedure, and they found the most embolization happened during contrast injection and stent deployment. They look also at neurocognition test to see if this microembolization cause any effect, and they found that the more you have embolization, this will show a significant decrease in the neurocognitive test, especially if patient older patient more than 70 years old. So they conclude that the older age patients showed a significant postoperative decline in this test, but even younger patient has significant postoperative decline in manual dexterity, and the use of their dominant hand at the follow-up from these all microembolizations. So really we do a lot of harm, but we don't know about that. So what about the physiology? If the stroke happens within the procedure period, like less than 30 days, the pathology most probably is embolic, caused by dislodging the debris from the calcified valve tissue or aortic valve atheroma, thrombus, or air bubbles during catheter manipulation, balloon valvoplasty, or valve deployment. If it's happened after 30 days, the most probably is related to the patient underlying health conditions or atherosclerotic burden, like it has atrial fibrillations, history of previous stroke, TIA, or chronic kidney disease. So what are the risk factors? We have a patient risk factors, like he has a history of TIA or stroke, which is the highest strong risk factor predictor of stroke during TAVI. Older age, chronic kidney disease, atrial fibrillation, high calcium burden in the aortic valve or left ventricular outflow tract, or peripheral arterial disease. Also, we have a procedure-related factors like longer procedure. If it takes too long to do a TAVI, a lot of manipulation in the arch, you have higher chance of stroke. Use of alternative access, like if you go transaxillary versus you go transfemoral. Pre and post deployment balloon valvoplasty, because it can send a lot of showering to the brain, and intraoperative hypotension. So what the preventive strategy we have? The most important is to pick up your right patient for TAVI procedure and procedure planning. Try to identify the high-risk patient, especially who has a massive calcification. Try to avoid this kind of patients. Avoid shaggy aorta. Try to give statin because it helps to stabilize plaque and smoke cessation. The second thing, procedure technique, try to minimize the catheter manipulation in the aortic arch and calcified valve area. And the most important, also try to minimize the patient to keep the ACT between 250 to 350. And finally is to use what's called cerebral embolic protection. Even though this cerebral protection device showed it reduced the silent brain lesion in MRI, but larger clinical trials have not demonstrated a significant reduction in the overall clinical stroke rate with routine use. The reason why they are indicated only in high-risk patients. We have many cerebral protection devices in the market. We have 8. Everyone has different indication and characteristic, and not to go through all of them. The most one we use really is Sentinel cerebral embolic protection. It's very simple. We go through the right radial artery. You go cannulated. You go over to the arch, and you pin the catheter. Then you cannulate the left common carotid artery. You deploy the first filter, then you deploy the second filter. And it's very easy, and it's the only FDA approval, and to protect the brain during TAVI procedure or TVAR. It protects the brain. If you see the green area, this is a part of the brain will be completely protected by using Sentinel. The yellow area will be partially protected, but still some areas not protected, because remember, we're not protecting the left vertebral artery. So patients still get embolized through the left vertebral artery to posterior circulation. So the red area is not protected, but it's only about 2%. So 98% of the brain will be protected by using this device. This is one of the procedures. You can see it here. You can see the 2 filter, and you can see all this debris catch up by the filter. The second one is the Edward umbrella embolic detector. It is a CE market, 6 French, and goes through the radial axis. We have also the Keystone Heart TriGuard, but all this not very common as Sentinel filters. So what happens if patient get a stroke during or after TAVI? Most of the patients really managed conservatively, but timely neurointervention can improve the functional outcome, especially in moderate or severe stroke. Mechanical thrombectomy is the standard care for acute ischemia involving the large vessel occlusion. But if you look at the ASTRO-TAVI registry, which is really a huge registry, about 1,600 patients, they found even though the mechanical thrombectomy can improve the function outcome of the patient in 3 months, but did not decrease the 1-year mortality. What about thrombolysis? May be considered, but it has high risk of bleeding, especially if the patient has just had a TAVI. And second thing, it may not work because the emboli could be a non-thrombus like a calcium emboli. So really, we should use it very carefully after a multidisciplinary assessment. This is the ASTRO-TAVI registry, and you can see here After 3 months, there's a significant improvement in the function of the patient, but the mortality did not change by using this, or if you do mechanical thrombectomy or you don't do it. So really the main benefit from improving the functionality of the patient at 3 months, according to the ASTRO-TAVI registry. What kind of anticoagulant we need to give after TAVI to prevent a stroke? This is an Atlantis study. They compares apixaban versus antiplatelets. They have about 1,500 patients, and they found that at 1 year follow-up, apixaban did not demonstrate superiority over antiplatelet therapy in reducing thromboembolic event after TAVI. So it's not recommended to use any anticoagulant unless patient has like atrial fibrillation or mechanical valve, but otherwise antiplatelets alone is enough. The second question, should we use single or double antiplatelets agent? This is answered by popular TAVI trials. They compare both for post-TAVI, and they found that if you use double antiplatelet agent, this will increase your bleeding, but stroke prevention will be the same between both. So they recommended that single antiplatelet therapy confers a superior safety profile over double antiplatelets without compromising ischemic protection, and patients who do not require double antiplatelets for any reason, like recent coronary or has a stent, then should be treated with aspirin or with a single antiplatelets as the first-line therapy in patients undergoing TAVI. Prognosis, if patient gets a stroke after surgery, it is increased his 30 days mortality about 6% higher rate of major or life treatment, threatened bleeding or longer hospital stay. The reason why recognition of stroke and treated is very important, the best way to use BFAS tools. Conclusions, stroke remain a significant complication after TAVI with a substantial impact on the patient prognosis and family outcome. Routine use of cerebral embolic protection device during TAVI has not demonstrated a reduction in the overall stroke rate and is not universally recommended. Most patients are managed conservatively if they get a stroke, but tiny neurointervention by using mechanical thrombectomy can improve functional outcome, especially in moderate or severe stroke, but will not change 1 year mortality. After TAVI, the recommended treatment remain aspirin for patients with a low thrombotic risk, since dual antiplatelets, rivaroxaban, apixaban failed to reduce the risk of ischemic stroke and increase the risk of bleeding. And finally, long-term stroke prevention should focus on the aggressive management of risk factor, individualized anti-embolic thrombotic therapy, and close cooperation between the cardiology and the neurology team. Thank you very much.
Thank you, Dr. Qusayr. I think we'll have a slight change in the, so we'll have Dr. Ben Khamis show us some interesting cases from vascular surgery and endovascular surgery, and then the final talk will be Professor Lam after this.
Okay, good evening, or I guess still afternoon, so I'm back. Thank you, Professor Lam, for allowing me to go ahead. I'm just going to have to go to the airport in a few minutes. So I'm just going to show a few cases. I'm not a surgeon, so I'm not going to show vascular surgery cases, but they're endovascular interventions. So it's, I guess, overlapping between all the several different specialties. So let's start off first with, let's say, middle-aged male, diabetes, hypertension, has this complete gangrene of his fifth toe, but not infected, it's dry, there's a bit of rest pain. Patient is already on dual antiplatelets plus apixaban. His pulses are good in the groin, but there are no pulses in the popliteal or in the, there are no pulses in the foot. The most important thing here is he's had other interventions, other hospitals, and they failed to recanalize his vessels. So whenever I get a patient like that, I already try to think, I'd like to see what they tried and what they did before to try to see how I can improve the success in the second procedure. So on the ultrasound, he has stenosis in his popliteal artery, very distal, and his below-knee vessels are all very bad. So I don't depend on the ultrasound here. Now, this is the kind of cases that I really like to see the angio to really see the below-knee vessels well before I really decide. But I know it's not going to be straightforward. So this is the angiogram of the below-knee. All the top was fine. You can see there's a stenosis of the distal popliteal that we saw on the ultrasound. And then you can see the tibial perineal trunk is very diseased or nearly occluded. The anterior tibial, only the proximal half is open, the rest is occluded. The posterior tibial artery is completely gone. So here, say, now I assume I understand why they couldn't, or what they failed in. They failed crossing the anterior tibial down to the arch. I'm not sure really if they tried before the TP trunk or not. And this is the below knee runoff, or the below ankle runoff. So it's pretty bad. His below ankle vessels are small. Maybe it's just because of poor inflow, or maybe the injection was because so far up from the top. But it looks like he has some degree of microvascular disease in the foot. So here we decided to use a support sheath, which is called an Oscar sheath. We use it in long occlusions or heavily calcified occlusions to help penetration. And we decided to do orbital atherectomy followed by angioplasty with regular balloons and drug-coated balloons, just because it's a second intervention for this patient. Usually we don't go DCB right away. It's still not proven 100% to do a good job in below knee vessels. We were able to cross, looks nice. You can see the stenosis of the anterior tibial. It's patent. The TB trunk looks very nice. Maybe a small dissection in the TP trunk, but it's not that bad. And he had a small wound, like a focal gangrene, and we said maybe this is going to be enough. We don't have to go crazy in the below knee, below ankle, and try to open the posterior tibial. You can see distally now, you start seeing some of the vessels at the bottom here, and the TB trunk looks, dorsalis pedis artery looks nice. So we expected him to do well. Unfortunately, he came back 1 month after with non-palpable pulses and no Doppler signal on clinical exam. So he went back and did another angiogram, and everything collapsed again, just within 1 month. His risk factors are not very well controlled, but that's just part of it. But his anterior tibial actually now looks much worse already within a month. The TP trunk is not bad. So we said, okay, here, what's the choice? Is he fit for bypass or not? No, we decided he wasn't fit for bypass for lots of different reasons. So we said we have to do something different. So that was the time when there's a new product being launched in the region, which is the bioabsorbable scaffold. So we decided in this patient, this is our first patient to use our bioabsorbable scaffold. So we used IVUS, so you have to size the vessel very, very well to decide what the vessel is. Especially you're dealing in this area, the vessel size can change from the perineal to TP trunk to distal popliteal. And so we saw that the distal vessel was, doesn't show very well, it's 3.8, and the upper vessel was 4. So we have to size the vessel, the stent very well. The procedure steps for this is you have to do aggressive pre-dilatation with high pressure balloons. So the bottom we did 3.75, and then the whole vessel we did 3.75 vessel preparation, and the top was just, we did a 4, and then we used it's called Esprit stent, which is a scaffold. You actually don't see the stent at all on X-ray, you only see the markers, that's it, you don't see anything else. And then you have to post-dilate it again with the high pressure balloon, the bottom 3.75 and the top at 4. So here, basically, this was our last hope for this patient, that his gangrene doesn't get worse, and without compromising his below ankle vessels. So sometimes when the vessels are very bad in the below ankle, we try to recanalize them, but you increase the risk of making the foot worse. So we don't do that until the end. This is the IVUS after the stent. You can see these markers here are the stent. The vessel lumen looks very well perfused. And this is what it looks like on the angiogram initially. So since it was our first patient to do this case, we decided to bring the patient back in a month just to do a diagnostic angiogram to make sure that everything is okay. And the very nice thing about this is, just for the sake of time, I'm just going to go directly to the pictures. You can see the vessel remained patent, thankfully. And the thing that I really liked is you can see now the flow in the foot. Just because the vessel stayed open probably for a longer period of time, you can start seeing the smaller vessels in the foot starting to open up and to get better perfused. And this is almost a year ago, and he's still patent, and that gangrene actually just self-amputated, and he did very well. So this is the first case I'd like to show, just to show the new different techniques and different steps of decision-making, as well as using new technology that hopefully will help if we use it a bit more in selected patients. So from the leg, go back up to the aorta. So we have a patient that has a type 4 thoracoabdominal aneurysm. We have, I would say, with, of course, the help of Dr. Samer previously before he left us, we have like a busy aortic program between us, vascular surgery, as well as cardiac surgery. So this patient has a type 4 aneurysm. He has a lot of comorbidities. He has already previous surgery before for a certain segment. So here, again, we go to the patients, we decide always, is it conservative? Definitely not for this patient. Is it either a fenestrated graft or a surgical repair? So here we decided to do a custom-made graft. This is just go through quickly the steps of the procedure. We place the graft, still partially deployed, partially. And then now we just then we expand the rest of the graft and make sure the alignment is as accurate as possible. Then we start selecting the branches or the fenestrations. So this is the branch here. This is for the SMA. And then the SMA stent is placed. Then we select the celiac branch. And you place the celiac and the SMA stents. And you do the same thing for the right. The left renal is already done, then the right renal. And you have, these are fenestrations, so that you have to extend a little bit the stent into the native aorta. This is the initial angiogram on table. You can see it looks like there's still a little bit of a type 1A endoleak at the top. And so we just reballooned it, hoping it was going to do well. And yes, thankfully, the endoleak disappeared. But we thought that this was the only endoleak, so we just, I guess, at this point, we stopped. We send the patient back to the ward. And in these complex cases, sometimes we like to do a CT scan 1 day post-procedure to make sure we have a baseline and to make sure we discharge the patient safely. So on the CT scan, on the next day, you can see there's still significant filling of the sac. And we know from the angiogram that it's not a type 1 endoleak. So we go through now our thought process of what could be. We have a lot, there are types of endoleaks that happen in custom-made fenestrated or branched grafts are a little bit more complicated. So out of these, we thought, okay, it's either going to be a side branch attachment, so the distal part of the stent is not landed well in the branch, or it's something with the fabric, which is very, very rare to happen with these new devices, or last but not least, it could be an attachment at the actual branch opening of the graft. So we said, okay, the first thing to do is make sure the attachments are well sealed. Let's go do a ballooning of all the different attachments. So these are different pictures of us doing ballooning. These are not the most appropriate balloons to use. We don't have specific, usually have these very compliant soft balloons to be able to flare the attachments, but we just used regular balloons and we ballooned everything, all the 4 different attachments. But then we did an angiogram and we can still see filling here. So definitely it's something going on around where the renal stents are. So one of the things that can happen is either the stent is not extended enough into the aorta, or you didn't flare the stent enough to actually seal the opening, or sometimes if there's any misalignment between the opening and the stent that you placed because of, let's say, tortuosity or twisting of the graft, you have like a space between our gutter that will actually fill. So here what we're going to do, we thought most likely now it's not a fabric tear, or it still could be a fabric tear, which is very, very rare, or it could be an attachment site of the more proximal here, because this still looks very nice, well sealed. What we decided is here, let's extend the left stent more, and let's see what it looks like. We extended the stent, but no, there's still, you can still see filling here. And we sat and listen, let's take a break. Let's go back. Let's look at the images again. Let's try to decide what we're doing. We actually asked for some help from one of our colleagues in France to help us look at the images and try to decide where everything is coming from. So we said, you know what? Maybe there's a small, or there's too much space here between the stent and this marker here. So there's a bit of a space here. So with 3D imaging and stuff, we thought that, okay, maybe this is the problem. And you can see now we have a small catheter here that actually can jump and jumps into this space here. So that actually there's a malalignment, or there's a gap between the renal stent and the fenestration. And you can see us injecting contrast here, and we're outside there. So now, what are we going to do? These are the different things we thought of. So one, either we're going to try embolization, like doing, like for example, closing an ASD or closing a PFO, these kind of small connections we want to try to use. Or are we going to do a direct sac puncture, which of course is not safe for these kind of patients, try to balloon more, extend the stent more. We already did that twice and we thought it's not going to work. Of course, surgical explant in this kind of patient is probably just going to kill him, so that was off the table. So we decided to do an embolization of this plug, or let's say just a closure of the plug, so closure of this gap. So with the catheter back in here, you can see a wire went inside it. So just like a through and through access from the artery to the vein or through any kind of defect, we placed a plug, which is an Amplatzer 4 plug. It's the smallest plug we have. We thought of using a plug that's for the PDA or for the PFOs, but we couldn't find the right size. And this is after the deployment of the plug. We injected contrast. See, there's no more filling of the sac. And this is the angiogram post-procedure. The conventional angiogram is not running, but you can see the CT scan. Finally, after about a month and a half of the patient figuring out, you can see that there's no further filling of the sac. And that was maybe a year and a half ago. And so far, thankfully, he's doing very well. So thank you very much.
Thank you. So I'll invite Professor Lam again for the final talk on carotid disease, when to refer for carotid endarterectomy or stenting.
All right, thank you for your attention. So for this talk, these are my disclosures. I think we are coming to a topic that's full of controversies. Number one, I'm a surgeon, so Hippocrates is known to have said, when medicine fails, the scalpel succeeds. And then if as an interventionalist, you're going to have different views between a vascular surgeon versus a neurosurgeon versus a cardiologist that does carotid procedures or a neurointerventionalist, and versus a non-vascular, non-proceduralist like a neurologist in vascular medicine may have very different views on how they interpret the data. And I will say that I think in general, I consider myself a very conservative surgeon, operating only when you absolutely have to. So we'll see, and you can come to your own conclusions and tell me if I'm too much of a quick trigger to the scalpel. So these are the objectives. We're going to talk about carotid disease. We'll talk about different options, including CEA, carotid endarterectomy, carotid stenting, which is through the traditional transfemoral approach, or the transcarotid approach, TCAR. And then we'll talk about what exactly symptomatic disease means. Talk about, we'll throw in some mathematical formulas for measurements of the degree of stenosis. And then we'll talk about some major trials and discuss the pros and cons of each of these approaches. Again, this is the last trifecta of the systemic vascular disease, including the carotid cerebral vasculature. Fifth leading cause of death, causes a lot of disability if you get a stroke, and costs a lot of money annually. So this is it. In the interest of time, this is the answer. This is when you refer. Symptomatic, moderate or high grade, 50 to 70 or more than 70%. That's when that's the current indication to proceed with the procedure. The caveat to that is that patients must have a Rankin score, a stroke score of 3 or less. You don't do procedures like that if they have a major disabling stroke. The timing of the stroke, timing of the intervention for revascularization is also important. Ideally, you want to try to do it within 2 weeks if it's a minor stroke or TIA, because the risk of recurrent events, embolic events, neurologic events is greatest in the first 2 weeks and generally starts to fade out after 6 months. And then the other side is asymptomatic. You're asymptomatic, when to refer, probably high grade, and I would tell you that I do not think all high grade stenoses need to be intervened on. A lot of neurologists also ascribe to this principle, and I think it should only be reserved for patients who have progression or have some high-risk features.
All right, so the overview of the options of treatment, you have best medical therapy, all the stuff we've talked about, statins, aspirin, Plavix doesn't really add that much, but you can, and then all the LDL control stuff. But those evolocumab and the PCSK9 inhibitors have not really been studied much in this case yet. Stenting, you have the traditional transfemoral stents, and you now have the transcarotid stents. Kind of funny to tell someone, I'm going to operate in your carotid to put the stent through your carotid to fix your carotid. Why don't you just do the incision the first time or try to find a different approach? But the TCAR has been quite a major change in the game, and I'll explain why later. But essentially, you insert the sheath in the proximal common carotid, and as you're deploying all your devices, you clamp the common carotid, and you then have reversal of flow because blood pressure in the IC and the EC is going to preferentially come out through the sheath into a device, and that's inserted back into the femoral vein. And we'll talk about why that's important. But first, we'll talk about just what the symptoms of carotid stenosis can be. So it's defined as a focal, sudden, transient neurological or could be permanent neurological disability that can be ascribed to your ipsilateral carotid. And the definition in all the trials has got to be within 6 months. For TIA specifically, you have amaurosis as well, which is transient monocular blindness. People always describe like a curtain coming down the eye as the vision loss. And then all the symptoms of stroke, contralateral motor weakness, sensory loss, aphasia, dysarthria, hemiparesis, and stuff like that. Now, things that are not symptomatic carotid disease would be vague symptoms, dizziness, lightheadedness. Yesterday we talked about syncope, global confusion, memory loss, vertigo, ataxia. All these things are generally not supposed to be true symptomatic carotid disease. And how do we measure stenosis? So typically, the first step is to do ultrasound. And then you kind of categorize them in broad categories. 0% where you have none. And then 1 to 49% is all lumped into one group under ultrasound criteria. And 50 to 69, which is moderate, and then 70 to 99, and then 100%. That's based on measuring the speed of blood flow. I explained to my patients just like the nozzle of a garden hose. When you narrow the nozzle, the speed speeds up, and then you measure the ratio of how high the speed is to where it's normal, and you get the ratio. And based on those ratios, you kind of classify them in the different categories of less than 50, 50, 69, and more than 70. Then for the mathematical formulas, this is how you measure stenosis on CAT scan. The most commonly used one is the NASIT criteria, where you measure the area of stenosis there based on what the artery is supposed to be normal, just distal to that, and that ratio of it is the degree of stenosis. All right, these are all the major trials that everyone talks about in carotid disease. We're going to talk about symptomatic stenosis now, the NASIT and the ECST. These are done in patients who at least had a 2-year life expectancy. So the absolute risk reduction is 26% down to 9%, 26% being for medical therapy, and if you do a CEA, the 9%. So the absolute risk reduction is 17%. The number needed to treat, 6. So I tell my patients, every 6 patients I operate, I'm going to prevent 1 stroke. Some patients may say, oh, that means 5 out of 6 operations you do are unnecessary. I tell them it's like playing Russian roulette, right? So you have 1 bullet, you do not know what that bullet is, but the results could be catastrophic. Now, for 50 to 70%, that number needed to treat becomes 15 to 20. So doing a lot of unnecessary operations to prevent 1 stroke. Again, the consequence is catastrophic. You're willing to take a 1 in 15 or 1 in 20 chance. ECST, similar numbers for high-grade stenosis, more than 70% is 3 to 5. Number needed to treat, and then for CEA at 50, more than 50% stenosis in the moderate criteria is about 15, it's about the same area. Now, asymptomatic, if you do not have any symptoms, I guess the analogy would be like a proximal LAD lesion, right? Asymptomatic, but something potentially disastrous. What is the number needed to treat? For more than, in this case, was 60%, but high-grade stenosis in category. you need to have a 5-year survival before you can see any benefit, and that number needed to treat is 17. Similarly, ACST1, the first trial, the number needed to treat is also about 16 or 17. Now, these trials are done in the 80s, 90s, way a long time ago, and actually moved to this. And that's when best medical therapy wasn't really available, right? You had the aspirin, but maybe we're not doing statins and things like that. Now that people are doing more best medical therapy, there's a paper published in 2020 over here that actually showed that, hey, maybe now with best medical therapy, the number needed to treat is 40 to 50 for asymptomatic carotid stenosis. So for that reason, really, a lot of people wonder, hey, should you even be doing carotid endarterectomies if the number needed to treat is 40 to 50? So there are a couple of studies that show, hey, maybe some things that you should worry about. So this paper looked at about 1,000 patients, followed them for 8 years, came up with about a 12% risk of progression of stenosis, and that came up to about 35% at 3 years. But out of that risk of progression of stenosis, even though it's like 12% per year, the stroke risk was only about 1 to 3% a year. Right? So for asymptomatic carotid stenosis, your risk of stroke, I tell my patients, if we do nothing, 1 to 3% per year. And speaking of ChatGPT and AI and stuff, I actually used ChatGPT to recreate this little graph here. The colors didn't come up well on this background, but that steepest curve here shows that 3% at 1 year for the most high-risk features and progression of stenosis in terms of risk of stroke. And then the other colors are the other features if you didn't have progressive stenosis, or if the plaque type is echogenic versus echolucent. So there are some features like echolucent plaque which may imply a more unstable plaque that's more likely to rupture and cause stroke. Irregular ulcerated surfaces are also more likely to cause to rupture and cause stroke. And then higher degree of baseline stenosis. And then these are some of the other things that are quite obvious that may lead to a higher risk of stroke. So if you were going to intervene, what are your options? Well, a bunch of studies here. Since there are not many vascular surgeons here, I won't bore you, but all these studies have a bunch of, they're very heterogeneous, a lot of variety in the terms of indication, in terms of the percentage of asymptomatic versus symptomatic patients, whether they were standard risk versus high-risk patients, the type of embolic protection device that was used, and also different terms of outcomes. Some people talk about stroke and death. Some people talk about stroke, death, and MI as a group. So if you look, the summary is this. If you look at all the composite outcomes, stroke, death, MI, they're probably about the same. But when you think about when I'm doing a procedure for a stroke and the complication is stroke, that's probably, I think, stroke and death is probably what you want to look at. MI, I think I'd probably take a small MI or even a big MI as opposed to a big stroke. And they've done quality of life studies for that. But in general, from all these studies, carotid stenting, at least transfemoral in all these cases, had a slightly higher chance of stroke, sometimes, but not always statistically significant. But what was beneficial was that for high-risk patients, transfemoral stenting at least was probably what you should be doing. Now, this is the study then in 2022 when stents became open for almost all patients, including standard risks in the US. This one looked at a bunch of patients, and basically over here, death or any fatal or disabling stroke, not statistically significant. Now, if you just look at any stroke, not just disabling stroke like the last slide, tends to show that CA is probably a little bit better, but that was not statistically significant. So after this study, it kind of opened up the road for all stents to be equivalent to carotid endarterectomy. We heard earlier about the TAVI and stroke risk and things like that, and that's because the aortic arch is really the source of stroke. As you come in from the femoral region, you have to go up across the arch. This was a study done similar to what was mentioned earlier about diffusion weight MRI finding changes in the brain. CEA and TCAR are pretty low, right? Because you're puncturing here, you're avoiding an arch, so it's pretty low, 70%. But when doing transfemoral stents, the amount of pickups on the deficient weight MRIs is pretty high. And that probably explains why the source of stroke is a little bit higher. And this is what happens when you pick out, this is a TCAR patient, and then there's a little filter, because as I showed you, the blood flow goes backwards. So as you're intervening up there, any kind of embolic stuff goes backwards into the filter before it goes to the femoral vein. And you usually see quite a lot of stuff there sometimes. So TCAR avoids the arch, and that's been quite the big game changer at this point. In fact, TCAR now has got rates or stroke and death rates that in some registries less than CEA. But for the most part now, TCAR is considered to be almost equivalent to CEA in all the studies. Now, TCAR, however, has got some anatomic restrictions. You have to about 5 centimeters between the where you access the neck to where the bifurcation is. Otherwise, you're going to be putting the wire up and down across the lesion and negate the benefits of having a TCAR. The size of the common carotid has to be a certain size. It's going to be free from disease. And you have a lot of circumferential calcium. The stent, you're worried it cannot fully expand. Although now, the people are pushing limits. Now you have intravascular lithotripsy, which is the same stuff we use from kidney stones, where you use ultrasound to disrupt all that calcium. And people are using more TCAR even when you have circumferential calcium. Now, transfemoral stents, you got different approaches. You can come through the radial portion, at least on the right side, you can avoid the arch. And there are also newer protective designs that minimize the number of instruments you pass up and down. And now there's one new design that incorporates the filter with a balloon with the stent. So I expect all the results to really get better. And earlier on, I mentioned the stroke and death risk from procedures. For CEA, the standard of care was to have less than 3% for asymptomatic disease, and the standard of care for symptomatic disease to be less than 6% for stroke and death. Now, for these procedures, even especially in centers that do CEA and TCAR, the risk of stroke and death is less than 2%. So, in general, I think there are certain circumstances when there are clear advantages of a CEA or clear advantages for TCAR. I like to think of a case whether it's going to be an easy CEA or is it going to be an easy TCAR, and then help recommend one over the other for my patients. This actually is a picture of the plaque removed from a patient with radiation, just because he has such extensive disease, and due to the significant length, we would have to use like several stents to overlap, and I didn't like the idea. And I didn't have a good spot to access the common carotid artery as well for the TCAR. So I ended up doing a CEA in even what we would have considered a high-risk patient. So for the conclusion slide, I think these are the patients that should get referred to a vascular surgeon for consideration for repair. If you're symptomatic, you have at least a 2-year survival rate. You're going to try to do something within 14 days. 50 to 70% or more than 70% are probably reasonable to do. If you're asymptomatic, you have to have at least a 5-year survival. And in that situation, only high grade, more than 70% with high-risk features. I don't think you should be doing, and just because someone comes in the clinic for the first time with 70% stenosis, I don't think a person should be undergoing a procedure right away. I think it's got to be shared decision making. A lot of patients sometimes have different comorbidities. I think you have to use the right tool for the right job at the right time. And it really depends. And it's good to be in a place where you have expertise to do both. In general, I would say TCAR is probably better than transfemoral carotid stents. And then for TCAR and CEA, I think there's now dealer's choice at this time. Even within my department, I've got some colleagues that would just favor TCAR. I think for me, I still tend to favor CEA a little bit more, but I think they're probably equal based on the data. And longer term data is needed, but I don't think it'll ever come. I don't think you probably won't get the study for medical management versus PCI and the different types of PCI versus CABG. Right? This is where we are now with this landscape for carotid disease. That kind of complicated trial probably will not come. But ideally, if you have best medical management versus CA versus TCAR versus transfemoral carotid stent, that's probably the best thing to do. But I don't think that'll be coming anytime soon. The next study to come up is the CREST-2 trial. CREST-2 actually is only transfemoral, doesn't even include TCAR, but there's the next awaited study that's probably going to come out in the carotid world. All right, thank you.
Thank you, Professor Lam. So, if any questions before we conclude the session?
I know everyone is tired now, but technical questions. Dr. Samir or Samir, sorry, thank you. Regarding the hypothermia for aortic repair, I saw that you are trying to deattach the brain vessels and selective perfusions, like integrate. So we are used to this for congenital heart. We keep the roof of the aortic arch, then you can actually do integrate perfusions easily. You will have free time to do whatever you want to do. And then again, you anastomose also the islands that connecting the whole vessels in the draft. Much easier, much safer, much less problematic for the brain, risk. That's number one. Number two, if you allow me to ask also, Rafael, your technique is very simple, but I understand it that, you anastomose and you're trying to do the proximal entry of the aneurysm using the pericardium, and you secure that, you seal it. Then you leave the distal free, right? But what about if there is other entry aneurysm?
Yeah. If I understood your question right, when the diagram I put it for debranching the arch, this was without hypothermia. This is without even storing the heart. So the heart is functioning. We just do a partial clamp on the ascending aorta, and then we cut all the branches and we debranch them. So it's not a deep hypothermia only if you want to do a total, open repair. Doing an island or independent, of course, as you said, island is much easier. Unless the patient has connective tissue disease, then we like to do, separate, vessel, because you may leave any island that can cause, aneurysm in the futures. So I don't know if I answer your question right. You talk about, because there's no hypothermia with a debranching. It's only in the open, yeah.
Yeah, I understand your answer, but what I saw, what you presented there, you're deattaching the brain vessels, like carotid, both of them, and then you integrate, perfuse them.
Correct.
Then you need again to deattach and do anastomosis.
Correct.
So this still you can do it while you're side clamp, islands, do integrate perfusions easily. But of course, you have to have, integrate perfusions.
Okay, I got your question now.
Yeah, and then you can do the anastomosis, then you can release your clamp. Much easier. We do it in pediatric, we do it also in aneurysm patients. If there is also proximal aneurysm for aortic root, you can still use the aortic root, and usually we do it if the patient is margin line for diameter. Because those patients, if they are hypertensive, the risk they will come again with the aneurysmal area. So since you are there already, it's better to do it. It takes only 7 minutes, 10 minutes more.
To perfuse the brain during the branching?
During the branching.
Yeah, but in general, clamping the common carotid artery, because the only thing...
Issue, and that is the, even though anastomosis shouldn't take so long time, I mean, that you have a normal thermic patient, that anastomosis should take at least 10 minutes, no longer, and everything has to be perfect, prepared for that. That is the key for a good result. And otherwise, I know it works. I've done that myself. Well, what I show you, Dr. Fahd, is that the tear entry in the arch, many times I cannot see them, because especially the tear entries in the distal part of the arch, I cannot see it. If the aorta diameter is not so dilated, you cannot see that. The tear entry in the descending aorta, I cannot see them at all. Those patients, if something happens, then we are referring them to our vascular colleagues just to place a TEVAR. That takes 45 minutes. But that is something that it's beyond our capacity. But in the ARCH, in most of the cases, I am positively sure I can fix it.
Can I ask a question to Rafael? Many times, as you said, when you get acute type A dissection, every hour delay increases your mortality. Sometimes I get patients come with type A dissection, but with valve ischemia or lower extremity ischemia. So what should do first? Now he's stuck because any delay is mortality. So how you approach these kind of patients?
I like your question because that is a discussion question all the time. Personally, if the patient arrives with abdominal pain, with a type A aortic dissection and abdominal pain, if it's discrete, and I mean very discrete, then probably we can start here with the central. But if the patient has more than discrete symptoms, you have to fix this out first. Otherwise, 6, 8, 10 hours later, the bowels will be necrotic, and then you will not have any patient. That is my point of view. I know that some of the cardiac surgeons probably will not agree with me because no, if we fix up the central part, then it will fix up. No, it's not like that. I have actually lost at least a couple of patients in my life just because of that. Another thing that you mentioned, and this is just a comment, the shaggy aorta. That is one of the reasons because I really, I don't feel so good thinking about that because I had a patient with a shaggy aorta. And since that was many years ago, I was still quite young. And I was reading a lot and I could see that some groups, they do operate, some others, they do not, and probably was 50-50. But and then that patient had a very big aneurysm, and I said, no, that is going to rupture. I have to go forward and operate. But that was the worst decisions in my life because a shaggy aorta, I can say that to the younger surgeons, do not touch them because it's impossible to work with them. It's, even if you clean up everything, the risk for multiply emboli is extremely high. Do not touch patients with shaggy aorta.
They usually say, don't wake up the dragon.
Yeah, something like that. You say that in English.
Right, well, thank you very much for all the speakers. And now we, the final session, which is the cardiac innovation biotechnology. Thank you very much.
Okay, so for this third and final session of the day, I'd like to introduce Dr. Mariam Shargi, who is a postdoctoral fellow at MIT, and joining her our panelists, Dr. Manisha Nair and Professor Yuta Arens as our panelists for this session.
Hello, everyone. Thank you for staying to the final session today. We're going to have an innovative session talking about biotechnology and cardiovascular innovations, starting with the Assistant Professor Dr. Fahd Nizami from Harvard Medical School and MIT. Please join me in welcoming him to the stage.
Hi, everyone. Thank you very much for hanging out here. I was telling a joke that whoever stayed this long, I will secure a position at Harvard for a postdoc for them. I don't know if there is any innovation left in your veins, but we will try to discuss how we see engineering work in the hospital, how innovative it can become, how hand in hand and our research can be when it comes to doing research at the forefront of practice. I've thought a lot how I want to present it, but seeing Muzammar presenting like 30 slides, I made it 40, so I think we are good. There was an article about my lab at Brigham. It was very exciting. I sent it to my mom. The problem was they still call us aliens. So it seems they still don't accept. I think like here is a little bit ahead of the game and accepting engineers and MDs together, or even engineer MDs. There they don't still believe that we belong where the practice is happening. The vision I have for research, for future of research, is digital medicine. So what we are doing is we are typically receiving the patient, and that patient is coming with some indications and manifestations, and that can include what you heard a lot today: coronary heart disease, aortopathy, and so on and so forth. But the way I see the future medicine to happen is we are going to digitize those patients. So we are going to make replicas of those patients in our computers, and that's where Muzammar works. And we make image processing, we make their replicas. Then there I come, where we do computational modeling, data analysis, and try to get functional information. So we have anatomical information, functional information, and demographic information. And all together, we can have a better diagnostic and prognostic tools for the therapy. We call it personalized medicine or individualized medicine. Let's not mix it with precision medicine with its genotypes and stuff like that. No, we are talking about personalizing the surgery and medicine. And for that, you need a lot of skills, all combined. And hopefully, if you can manage to do that, you will have much less adverse outcomes and better medical devices. I'm going to run from here on. So if you don't understand it, just enjoy the animations. I just try to show you different applications of how we can do these things. This is my lab. So we do a lot of image processing. I don't know if we do it as well, as good as Professor Behzad does, but we do a lot of intravascular image segmentation, digital twinning for different type of cases, or we leverage AI and statistical shape analysis for some outcome prediction. We also study, I'm sorry, I needed to go back. We also study pathogenesis. So we study how bicuspid aortic valves, for instance, can introduce some sort of a aortic aneurysm or dissection, and, or congenital disease like coarctation, how we can treat them, how we can grade their severity. Is there a metric? Can we come with a metric which is not only anatomy informed, but also having some function in it? And we do all sorts of medical devices, and that's because that's where the money is for research. So we do all sorts of stents, LVADs, valves, TAVI, so on and so forth. Let's start. I have tried to have three categories, so bear with me. This is the engineering work and mathematical models, okay? This is a typical engineering work we do as mechanical engineers. We do 3D printing of replicas of the case, and then we can study benchtop experiments and understand the turbulence of the flow better, or the behavior of the device. So that's a typical work we used to be doing. Or we take some setups where we can have a fracture or fatigue studies for the stents. Another approach could be what we call it particle image velocimetry, where we can visualize the flow and can understand. People believe what they see. This is something I'm super proud of. So these are called long parameter models, 0D models, electrical analogy of a cardiovascular system. So you have the resistance compliance and voltage changes as a pressure change. And then you can study how the whole cardiovascular system responds if you have some sort of a change as an LVAD, as a surgery, and so on and so forth. We have used this to extract PV loops in real time from this ex vivo heart perfusion setup that we have built at MGH. And that allows us to what we call mend the broken heart. So we can improve the quality of the transplant hearts. The results are really, really promising. And you can see that the measurements from the echo and sensors are very much on top of our models. Now I have this wonderful student from ATH, Till, that he is actually extending that cardiovascular 0D model to the entirety of pulmonary and cardiovascular. So we have the whole system, and now I can apply LVADs, and now I can apply ECMOs and try to study both the oxygenation and the blood flow. And that's the whole connection here, which looks very complicated, interventional parameters or selection problem with the drug that are being used with the medical device. This is a more complicated simulation for the valvular disease. Dr. Khoufi is an expert in TAVI, so you need to learn why any specific type of a bicuspid disease, congenital bicuspid disease, might lead to aneurysm formation or aortic stenosis, and why some of them will be left alone because there is not much of a manifestation. You need to do a fluid simulation because then you can see here the turbulence modeling, the jet, and what is happening at the site of the valve. Later on, if you do that, then you can model implantation of device. We all know that, do we need a valvoplasty? I don't know. But I can model it and tell you if this case with the level of the calcium burden might actually require valvoplasty before or after to reduce the paravalvular leakage risk, or is there be any risk of permanent pacemakers because I am pushing the calcification too much into the LVOT? I'm just giving you examples. This is a brain aneurysm. I got the chair in Brain Aneurysm Foundation for this project. So we have made an automated platform when you can get the imaging and just build the entire domain of what we call it digital twins. Why am I doing it? And I apologize if I'm going fast. I really want to respect your time. Everybody is tired, and Utah is flying. So we have done what we call it wall shear stress informatics. So we treat the wall mechanics with proteomics tools. So what we do actually is we extract the wall shear mechanics or wall mechanics and project it on the wall. That way I can actually cut open the aneurysm and predict the risk of rupture for the aneurysm. Or even better than that, we can implant devices. So this is a web device for who is working in neurosurgery. This is a special type of device to fill the aneurysm to reduce the risk of rupture. And this is what we call it a flow diverter. I apologize that some of the colors are not very clear. I can see it very beautifully here. I think chairs are enjoying the videos here because that's not really clear here. And this is ECMO simulation. We know we have a north-south syndrome problem with the ECMO. So the mixing is happening at different locations, and titration of the flow can decide where that mixing is happening. There might be some renal issues with that. So we can titrate the flow numerically, and rather than having a doctor deciding whether to go with 2-3 liter per minute, we can actually make it personalized for the patient. I have built a controller for that. Now, actually, I don't even need a doctor. I have a setup that I can control the titration of the flow. These are impellas, if you have heard about, from Abiomed. So we have modeled the impellas. We still don't know what is the right RPM for different patients. Numerical simulation can help you with that. You can study thrombus formation in the pumps. These are the pump heads of cardio help and stuff, if you have heard about it again. And this is the topic that I love the most. I'm a person of coronaries. So upper body cannulation sometimes results in ischemia. And it is very much depending on the titration of the flow. We need technologies. So you can have, for instance, the lumen constant, and you can change the calcium, or you can keep the calcium constant and change the bifurcation, and so on and so forth. Then you can build tens of thousands of synthetic cases and study the pathology better, or you can implant the device and develop a better device. This is a company from now on disclosures. So we are building an AI tool for CABG. So what we are doing is we are digitizing the case, and we are calculating the stenosis, the most severe stenosis. Then with numerical simulation, we can find where is the best landing position, what is the competitive flow, how we can build the graft, and we actually allow the surgeon to make the graft by hand on the computer, connect it, look at the flow, not like it, disconnect, connect, till you have the best plan, and you go to the OR and you do the job in 15 minutes and leave. So we call this graft mind, a fantastic work of these three wonderful postdocs. This is TAVI. So we call it cardiovision. The idea is we are getting the CT images preoperatively, and then we characterize the anatomy very properly with all the information, far better than what we do with the radiology report. And based on that, we can decide what is the best device, how much is the coronary height, and so on and so forth. We also implant the device, and not only that, we can actually correlate it with the outcomes of 2,000 patients we have in the repository to see if this patient might have risk of PPM, PVL, and so on and so forth. This is a tool we have developed for therapy planning pre-procedurally. This is diagnosis. This idea is simple. Doing the chart reading takes a lot of time. So what we have done is, this is a RAG that reads the OCR, that reads the reports, handwriting, images from the EPIC, and collects all the data required for you. So you can chat with the software. You say, how many patients did have a stroke in this cohort? And it will just list the cohort number for you. So if you want to extract 10,000 patients, it will take you a day rather than 9 months to do the outcome research. So this is serving the outcome research. We have two more, bear with me. This is huge. We call it cardiac GPT. And the name, it says it itself. So we have a very long line of research, but now we are focused on the surgery. So we have 3 different GPTs. One helping the anesthesia to decide the best decision intraoperatively. One to help the surgeons. So it actually collects the data while doing the surgery, predicts what can go wrong or what are the next steps, gives the options. It is not talking to the doctors. It is there for the doctor if they need help, or it's like a check mark points for the doctors. This is trained by the Harvard professors and can be used to train the residents, or actually can be used in the ORs of other hospitals. And we also have a similar tool for the ECMO. We call it OxAI, which does actually the same thing. So this is again another. These are all like Steele's companies in my lab. This is JHAH. I will go fast. This is a
product is actually a cardiac monitoring solution that is designed for patients with atrial fibrillation. We heard a lot about atrial fibrillation. It's an epidemic. I very quickly look at the prevalence of AFib in Saudi Arabia. Unfortunately, it seems that the country is exactly like the rest of the world, and this is a very, very prominent disease. Unfortunately, today, there's no cure for AF. There's a large spectrum of treatment that exists, but once you have AF, there's no actually way of really getting rid of it for the rest of your life. So for the good management of patients, you need monitoring solutions that help these patients to know about their cardiac status, and especially with those patients that have subclinical AF. Today we have different classes of device that can be fine. The one I call the clinical equipments, they are heavy, they are cumbersome, they are in general very limited in time. Couple of days, couple of weeks maximum. And then we have a brand new category of devices that are really blurring the frontier between medical device and consumer devices with the Apple Watch and all the wearable and watch ECGs type of devices, and one which is extremely popular now in the United States, which is a LifeCore device where you put your finger on a piece of equipment, record an ECG, and can have a diagnosis of AF. Unfortunately, those devices are actually either cumbersome for people who have the kind of long-term diseases, and a LifeCore device work for really symptomatic patients. And we've seen many times people buy this device, they are super excited about it, they use it for a couple of weeks, and then they forget about it, and they need to have symptoms to really have the incentive to check basically their ECG. So we need today tools that permits to improve the management of these patients, and we need tools that do not put constraints on the patients. Those are chronic disease patients. It means they have to take their medication. They have a lot of constraints in their life. Can we actually design a monitoring technologies that do not actually put any constraint on the patients? We need a new solution enabling long-term cardiac monitoring, and here, when I say long-term, I'm saying lifelong monitoring, not a couple of weeks or couple of days. Lifelong monitoring that is low compliance, doesn't bother the patients, that is reliable, obviously, and that is easy to deploy. You want to avoid to distribute devices and things. So we came up with a solution that uses video-based technologies, okay? And we call this solution video plethysmography. It's also called remote photoplethysmography. And really what we're going to do is use a phenomenon which is actually how the ambient light is refracted and reflected from the skin, and specifically the skin of the face, by the modulation of amount of blood that is in the cardiovascular system. What does it mean exactly? It means that hemoglobin actually captures the green components of the lights. It means that when there is a change in volume of blood underneath the skin of the face, you have a modulation of how the light is reflected from your skin. What am I talking about? I'm talking about blushing phenomenon. When you are stressed, many people blushes. It's basically an increased amount of blood pressure and blood content. This blushing phenomenon exists at the beat-to-beat level. Each time your heart beats, there is actually a slight changes of the color of the skin that is invisible to our naked eye, but our technology is able to detect these changes in the color of skin. This is an example, and this is actually a proof of concept that we've developed with Verily Google at University of Rochester, where we put actually cameras above the bed of a patient. And as you can see here, the patient is going to be in AFib, as you see on the ECG at the top level, is going to be defibrillated, cardioverted, and you see in blue this very small signal that shows you some information. This is what we call the video plethysmography. There is a cardioversion, and there is a changes in rhythm, and this here is the signal we extract from the variation of not only the color of the skin of the patients, but also the movement of the face that is due to changes in pulmonary volume of the patient. So this variation here you see, very low frequency, is not the heart rate, it is actually the breathing of the patient. So with just a video, we can extract breathing, and in this signal, we can also extract some pulse information, and you see this curve before and after AF, after successful cardioversion. So we started doing a software that was analyzing the signal, and we demonstrated as a first step, and we actually published that in 2015. We showed that just with a video camera, now without touching a patient, you can actually extract the pulse. Not only that, but you can extract the variability of the pulse. So you can extract information about cardiac rhythm. Okay, and we see in this ROC curve that the so-called PHS was equivalent in terms of discriminating sinus versus AF rhythm than parameters such as heart rate variability, parameters that were extracted from ECGs. So this is our idea. What are our aims? We want to develop, validate a passive, contactless technology to reliably extract pulse rate and detect the presence of irregular rhythm associated with AF. We need to assess, obviously, the performance of this technology in patients, and we want to make sure that the technology works all the time. Why? Because we're going to integrate, actually, this technology into your smartphone. So we were at this stage at the university with a working technology, and we need now to create a product and submit the product to the FDA to really be able to go into the market. And I think, as we saw also in Dr. Nemez's demonstration or presentation, when you are faculty and you want to commercialize, you need to go for doing true translational research. You need to go through startup companies. So it's what we did, and that's my disclosure actually slide. I'm the CEO and co-founder of this company, and the mission of this company is really to change the paradigm around atrial fibrillation and heart rate monitoring of patients using video-based technologies. So we developed an app, and this is the app that is called actually HealthCam, and specifically for AFib patient. I won't go too much in detail of all the benefits that such an app brings, but this is really transforming your smartphone into a medical device. Okay, and what you're going to be able to do, and you can do now today with this app, is do a health selfie. You do a selfie of your face, and while you are doing that, we extract this signal from the face of the patient or the user, and we extract heart rate, we extract respiratory rate, which, by the way, is a technology that was initially developed at MIT, but we enhance these capabilities by cardiac rhythm assessment. Okay? The statistics in the US tells you that in general, people who have smartphones look at them 63 times a day. We are addicted to these devices. And count how much time in this room you look at your phone this afternoon. Pretty sure that this is actually applicable to a lot of countries. But think about one thing. When you look at your phone and you look at information at your phone, you're looking at your phone, but your phone looks at you. Every single phone has a front camera, which means that our technology, and this is now implemented, is passive because it is created as a service in your smartphone. If you install our app, each time you look at your phone, we detect your face, and we extract information about your pulse, and we test if there is actually arrhythmia or abnormal rhythm, I should say. So in average, we are able, with your smartphone, to test your rhythm 63 times in average every single day. So it is passive. You don't have to do anything. There's no actually need for the patients to follow any kind of recording procedures. You just have to use your phone the way you like to use your phone every day. So we did multiple clinical trials, and basically, very quickly, let me tell you what the algorithm does. It does a face detection. We need to detect a human face. We need to do face recognition. We need to make sure that we are measuring the person we want to measure. You can give your phone to your kids, to your neighbors. We won't actually capture the heart rate of other individuals than who you are. And we also, very importantly, collect environmental factors for quality metrics. As you can imagine, we depend on the light that's coming to your face. Obviously, here, I can tell you, the technology would work perfectly. But in general, during in your everyday life, it happens that you don't have so much light around, and the app is able to detect the amount of light that you have around to decide whether they do or they don't do, actually, evaluation of your rhythm. And we extract, as I said, pulse and rhythm. This is an example where we have recorded simultaneously ECG, PPG with a finger device, and VPG with a video. And as you can see, we have very good, actually, correspondence. It's not very clear, I'm sorry, on the screen, but very good correspondence between a contact PPG sensor and a contactless VPG sensor. It's not exactly the same signal, but as you can see, there's a lot of correlation, I would say, between these two signals. Importantly, as you can see, we have a couple of VPCs in these things and packs. And what is important to note is that those VPC don't have any hemodynamic effect. Okay, so it's important to say that because what we measure, it's really the hemodynamic signal of the electrical activity of the heart. We are not measuring the electrical activity of the heart. So there is a little bit of dissociation between what actually we measure and what's happening in the heart. This is another example during AF, and as you can see, this is very different signal, and it's very easy for us. We have AI-based technology for detection, but simple signal processing technique have been extremely efficient at actually extracting an AF rhythm from the VPG signal. So we conducted 3 clinical trials. I don't have time to show everything, but I want to share with you just this one where we enroll around 60 subjects that had different history of atrial fibrillation. We have the demographic here, and the bar plot shows you actually the distribution of rhythm across every subject in this study. As you see, we have AFib rhythm, we have sinus rhythm, and different type of arrhythmias. And really what we did, we enrolled this patient making sure that we had a proof of their history of AF, and we brought them to the company laboratory and we asked them to use the technology while they were wearing an ECG patch and a PPG sensor, which helped us to really better understand how we were measuring the VPG signal and how good we were at really discriminating between sinus rhythm and other rhythms. This is actually the demographic of the population. I don't think there's a lot to say about that. This is the first Bland-Altman plot that shows actually our performance, or I should say accuracy, for heart rate measurements. And as you can see, the mean error on, whoops, sorry, let me go back. The mean, here we go. The mean error on the heart rate measurement on a list of almost 3,600 measurements from 39 patients, the mean error was minus 1.1 beats per minute. We had a couple of outliers, and what we noted is that those outliers, at least most of them, were actually people that have pulse deficit disorder during their AF rhythm. So, and here, when we remove this case, we see that the mean error for heart rate measurement using video-based detection is below 1 beat per minute. So this was an extremely good result showing a very, very good accuracy in heart rate measurement. And let me show you now the ability or the performance in terms of discriminating in these patients between abnormal rhythm that could have been AFib. In general, it was in this case, but also a high density of VPCs is detected as abnormal rhythm and sinus rhythm. And as you can see, we got a sensitivity of around 96%, specificity 92%, positive predictive value of 88%, and negative predictive value of 96%. So we have today a product, something that you can put on your phone as soon as the FDA cleared the technology to really monitor people and help people knowing what is their cardiac status with just their phone. And we hope that we'll be able to really use the technology to help the patient with AFib. I'm going to stop here. Thank you very much for your attention.
Thank you so much, Prof. Kodrik. Please join us in the panelists. We'll keep the question until the end of the session. And now, please welcome Dr. Ahmed Dalak from KFUPM. You can.
Hi, everyone. So this is late, and I'll try to be as quick as possible to finish the presentation. And this presentation will be actually informative, introducing optimization methods to non-engineers. And then we'll go to some of the applications that we are applying at KFUPM using origami systems. Yeah, so this is taking place in KFUPM, and my lab that I'm developing right now is Laboratory of Applied Mechanics and Advanced Bioinspired System under the Biosystem Machines. The last part of the presentation will be showing some of the things that we are actually generating in that lab. Yeah, so the presentation will walk you through the design methods, and then we'll go for bioinspiration, which is a way actually to cheat from nature. And then we'll go to material selection part of the presentation. So as you know that human beings are 3D systems, and they come with so many complexities. And for that reason, the design space is very vast, very large. The human body is not only 3D, they are tortuous, and navigating it is quite hard. So often we need the topologies or the geometries that needs to tackle or deal with the human body needs to be parameterizable and continuous differentiable surfaces to be able to parameterize it and tune it in a nice way. And most importantly, that it can be realized using one of the fabrication methods that we have. Of course, devices that deal with the human body, especially in the cardiovascular area, is valve and valve clips, endovascular catheters, stent and balloons, adapters at the end of the tube, and LVAD dynamic systems. All of them require careful engineering. So in biomedical systems, there are 3 types of optimization that we typically follow, or engineering in general. Shape optimization, topology optimization, and size optimization. In biomedical devices, size optimization is prevalent, where actually, let's say we have a valve. The valve has height, diameter, and thickness, and the material property of Young's modulus. So the design space for the geometric parameters are thickness, diameter, and height, 3D design space. And this is, for example, just for demonstration that I can show you an example that we can actually visualize. Of course, one of the standard way of modeling such systems, typically FSI, fluid structural interaction, with 2 PDEs that we are solving simultaneously, solid part and the fluid part, where typically we maximize the flow and minimize the stresses on such systems, is finite element analysis. Finite element analysis are quite expensive computationally, and for 5 trials for each variable, as we see here, we need 125 runs, and that takes 5 days typically for an accurate FSI simulation. So one way around this is actually to use optimization algorithms. Yeah. Or go brute force and try 100 tries for each variable, 100 to the power 3, 1 million runs, 114 years required to complete the simulation, and thereby map the design space that you clearly see here in the colorful map. Of course, this is very accurate if the model is high fidelity and it's mission dependent and everything is fine. However, this is prohibitively possible to be done with the time requirement, and hence, and by the way, this has been already done in one of the labs in the US, and they are building a library of different valves designed using brute force optimization. However, they did something. One way to do a trick is actually to feed the 5 trial incrementation for the design space to a machine learning algorithm or a deep learning neural network. A neural network are nonlinear enough to capture the complexities of such system, and then feedback, and then run this surrogate model, we call it surrogate model, and populate the design space again, hoping that the shape of the design space and the surface that we have is identical to the one that we trusted from the previous slide. So there's a hope here. The other way is actually use neural networks to solve the differential equations that governs the system, and then build the and build the design space, and then find the maximum minimum of design space depending on the objective functions that we have. Okay. Now there's another way, another approach. This is a nice way that we are always doing in engineering and in biomedical design. However, there is one way is actually to go through nature. Nature provides us ways to cheat and see if we can actually bio-inspire from different mechanisms. Especially, let's say that we are seeking foldability and compliance, okay? Something that we actually want. We have seen today that so many of the physicians, they say that we can poke certain areas, we need rigid areas, we need flexible tubes and so on. So all these are material properties and structural properties of the system. Earwig insects have actually very nice origami structures inside. Also, potato flowers have very nice foldable, flexible mechanisms. However, what intrigued me when I did some research in the bio-inspired area, which is my expertise actually, is the hawk moth, which their intima is operating at a very high frequency. Yet it doesn't fail, and it's very flexible and breathes very consistently. And when we scanned the literature, we found some papers in the zoology showing that they have some corrugations that looks like an origami that have some offset. This origami actually inspires something we call the Crisling origami. Now, how this is applicable to cardiovascular, I'm going to walk you through it soon. So, of course, what we did is we modeled the system, understood how it acts under cyclic loading, and this system, by the way, it's a unit cell that can be considered as a smart spring that can act like a billow, a balloon, and can act like an adapter with a uniaxial rotation coupling mechanism. So we can actually apply uniaxial loading on one side and get rotation on the other side. So it's a very smart adapter that can act like a balloon and a drill and can maneuver tight areas. We were interested in creating shock absorption systems, and it was one of the actually effective means to shock absorb mechanical loads through viscoelasticity that is built inside the material used in fabricating it. Now, origami and the bioinspiration from such systems have inspired so many myriad of solutions, from switchable bits, 0-1 bits, to shock absorbing systems, to mechanisms, robotic arms, and flexible robotic arms and ventilators. And also micro robots that actually can navigate tight areas within the body and deliver drug delivery to certain parts of the body. In KFUPM, actually, we are perfecting right now the robotic arm, and we fabricated this sample, as you can clearly see here. And we are trying to study its degree of motion and so on. The first thing we did is actually we parameterized the system. So now we have full control over the system. So the system can be parameterized mathematically using a code. And we have a very cheap finite element analysis model, in a sense, because I'm saying cheap because it's shell-based elements. We are not really consuming a lot of computational power. And also we were able to fabricate the system in-house. And now we are moving into actually building the system and instrument it so that it can navigate tight corners and tight tortuous paths inside the cardiovascular system. And this is something that we are working on. The nice thing about the system is actually that they are multifunctional in the sense that they have a grasping effect. So it can drill into thrombosis, grasp certain parts of the body, and also extract things using aspiration. Okay, so the third part of the presentation is material selection. So material selection, physicians know more than me about this. They suffer calcification and thrombosis, and biofilm formation, as well as manufacturability. These are the limitations that we face in biomedical devices, and we need actually not shy away from using traditional methods like injection molding and casting methods. Something that we are actually bringing back KFUPM, where we use traditional methods with 3D printing to generate materials that are trustable and reliable in biomedical devices. And of course, make sure that the system is strong, has a high fatigue life, and durable. These are the general mechanical requirements. Now, when it comes to material selection, the best way to actually do material selection is to go to Ashby charts. These charts have populated the properties of the different materials using different axes. Like, for example, you can clearly see his strength and cost, and you can clearly select the intersection that suits you based on the budget that you have and the strength requirement of your project or the material that you seek. As well as on the right side, you can clearly see the strength and elongation. So elongation can correspond to flexibility. And there are other charts like this for Young's modulus, toughness, strength, and the conductivity, electrical properties, and physical properties. However, we don't have properties for cytotoxicity, hemolysis index, or properties that are relevant to the biomedical cardiovascular area. So that's something that we actually are trying to build right now by gathering data from the literature and build up our own charts, which will help us to do a proper design selection, material selection for the biomedical devices that we have. And by that, I'm done. Thank you so much for listening. If you have any questions, let me know.
Thank you so much.
Thank you.
Now we'll open the floor for questions. Maybe quick questions because we have a couple of the panelists have slides. Yes, please, Dr. Rasha. Yes, let's start with a question here.
My question is for you, Doctor, regarding the facial technology. So maybe I've missed it, but what happens with the data that you're gathering? Does the patient get an alert saying that there is a problem and therefore you need to go and see a doctor, or does the alert goes to the cardiothoracic surgeon or to the cardiologist? What will happen?
So this is the integration, I would say, of the technology into the overall health service path, I guess, in a sense. The patients can do a self-test, and he'll never have the message saying you have AFib, because we don't know. We know that there is abnormal rhythm, so that's the message you'll get. You have an abnormal rhythm, please contact your physician. And in the app, we have it's a service for physicians, for their patients, where they are connected to the app, and the patients, so the app generates a report with the signal, with basically information about abnormal rhythm, and create a PDF that is sent automatically to basically the EPIC system or any kind of system that they have to work with their physician. It does not exist yet. This is our way of integrating, and there are many questions that raise from such type of interaction. But when we see what AliveCore has done, they have this kind of system, right? You do an ECG, they create a PDF, and then you send it to a service for review and a diagnosis. So that would basically be very similar to this kind of thing.
So can I just follow? So is this app just for patients with AF, or is it for everyone?
Yes, it is actually the indication, the FDA submission as we have defined our indication as a software, as a medical device for patients with an history of AF. So patients that have been already diagnosed with AF. It's not for the general population. We are not crazy like Apple is.
Yeah, it will be crazy because the workload will go up massively for every alert.
Absolutely, yeah.
Okay. Thank you.
Thank you. Rasha? We have...
Oh, God.
Am I audible? Please go.
Thank you very much. I have some questions to Dr. Fahd.
Yep.
That was excellent and very informative presentation. You talked about the synthetic engine, and I have some questions about the platform. Was it commercialized? What type of modality that the engine uses to generate data? Like, do you use different types of data or just imaging? Go ahead.
There is a problem with software development. You cannot patent the software. You can protect some IP protection for whatever is in-house for you, for that you can close it and put it in a black box. You cannot patent it. The best you can do is trademark whatever is made out of it. Okay, so it will be more of a business secret for you rather than a patent that you can protect it down the road. You can trademark your company, and then you can protect whatever belongs to that company. right? And foundations for a lot of these devices, if it gets into the translation, majorly, that's when you decide if you want to make a company out of it or not. So you make a foundation, majorly Python. There are all the codes out there. If this code is based on unit and stuff, that's not something you generate. Your smart act is when you apply it for a specific application, a niche application that there is a demand for it. Okay, so for instance, when I was talking about cardiac GPT, I know for a fact that our surgeons are very concerned, or our anesthesiologists are very concerned when there is acidosis, when there is a problem of pH. Intraoperatively, if there is a tool that can confirm the dose of the drug the anesthesiologist will use, and also the follow-up in the ICU, that would be very relieving for them, much less liability for them and load of work. I know that fact because I was in the Department of Cardiac Surgery, and then based on that, I go and build that backbone and foundation. That's how I actually address the translation.
Okay. And what type of data did you use in your project?
Okay, that's so typically we start with the data we have access for. I'm privileged to be in Harvard, so we have the whole MGB, Mass General Brigham database. So for TAVI, we have like 2,500 patients. So my data is trained, my algorithms are trained based on those data. But next step would be you need an external partner so that you can also validate your algorithms, because you don't want it to be biased by your institution, right?
Okay. So and that system was used, or synthetic data was used mainly to train and develop the model. But have you tried to use them in real time, for instance, to
real time in what sense?
Like, for instance, let's
say... So synthetic data, everybody's tired. I need 30 seconds to explain what the synthetic data does. So imagine I'm making a stent. I make this stent, I test it on the benchtop, I test it on the animal, and then for a limited number of patients, I test it in a clinical trial. That clinical trial is limited, even if you do it with digital twins, are limited to the patients that you have recruited for that clinical trial. So then the device goes to the market, and there are a lot of callbacks, right? So what this synthetic data does is you get the population. It's like the people sitting in this room, we are not so many, okay? There are a lot of chairs empty. And I look at two different people, okay? I look at Dr. Fahd and I look at Samhar, and I put someone there based on those two, some sort of average of those two. And that way I populate this room. Now my clinical trial is no longer 20 people, it's 2,000 people. And then with that, I push my device to the corners where it actually starts to fail. I find the modes of failure for the device. Then I generate more patients around that mode of failure. Then I start optimizing the device to withstand that failure and resist. Okay, if there's a fracture of a stent, if it is in a stent thrombosis, it's things like that. And that way, I allow my device to experience problems that might lead to callback before even I get to the market or get to the clinical trial.
Got it. Thank you very much.
You're welcome.
We'll have a question from Dr. Fahd.
Until the microphone is there, I have a follow-up question on that.
Yeah.
How do you validate that your digital siblings are really doing what a realistic patient would do?
That's a very valid point. Validation is always our what's Achilles? They say, yeah, heels. There are ways to validate. There are different levels of validation. One is you want to make sure that you are not building a person with 3 heads, right? With 5 heads. So it should be a human with the head. So it's same story. Mariam was showing that heart case when we were keeping the atrials and ventricles and just changing the size of the one atrium, right? So you want to make sure your heart has 4 chambers, things like that. So those are the sanity checks you do. So what we call it in the terminology of what we do, the topology and morphology of the digital sibling should be valid. Then the next step is, if you have a population, you know the distribution of the sizing of the valves. You want to try to make sure that what you are generating is within the population you are training. That comes with the limitation that if your training is limited, then you might not see the deviation of your domain. Another level of doing that is sensitivity analysis. Down the road, when you want to validate, you can easily do some, the way we always do it, you can do the animal model and test what you are doing with the virtual surgery. You can do imaging. You can actually augment the data, then you do the imaging in real patients and try to see if you can actually replicate that with synthetic data.
Okay, thank you.
You're welcome.
Thank you. I'll continue the same questions of Jutta. I understood that you are taking real patients' data, few numbers, and then you replicate them to generate synthetic data to validate your concept. How many numbers do you take from the real patients' data?
Depends on the prevalence of how many numbers you mean, like how many cases of the real patient?
Yes.
It very much depends on the prevalence of the data. If we are talking about cardiac surgery in like a congenital disease, we might not have enough number of coarctation. If I publish a paper with 30 cases of coarctation, it can go to JHAH, but I cannot do that with CABG, right? So the case is, it very much depends on the availability of the data. The more, the better. Okay, and we admit that our results are dependent on the number of data that we have used to train the database. Our data is as accurate as the training data used to train it.
And this is what you mentioned, in future maybe we will not need a clinical trial, we'll use silicon-based clinical trial.
I absolutely believe the trials of future is in silico clinical trials.
And I can see, Dr. Manesha doesn't agree on that because, epidemiologists are always very sensitive in this.
Yeah, no, I don't think I can agree with that. The legal challenges, I don't know how you can overcome. How many ever replicas you can create across this conference? You have heard that every condition can be triggered by something very unique. Takasuba is one of the presentations that you saw was so different depending on whether it's a male or a female, a young or an old person, what kind of emotional stress they have. If you put out a product like that, so what I see is that what these digital and these digital twins or in silico trials will replace animal experimental models. They can do that, but I think real world trials, whether you do it as phase 3 or phase 4, maybe it will speed up the process to phase 3 and phase 4 trials, but I think they have to be done because otherwise there will be legal challenges. You cannot predict everything. I know even human trials cannot predict everything, but still I think that's something that's very difficult. Maybe the technology will improve so much, and I just cannot believe that can replace anytime soon. In silico trials can be phase 2 or phase 1, but I don't think it can ever replace phase 3 trials.
I can argument. I don't know how much people are patient to hear this. What we are doing sucks. So what we are doing at the moment is not working. So what we are doing is not beneath that. It's actually something adding to what we are doing. So I'm not saying that we are doing this so that we are entirely start the clinical trials, but at least we start the clinical trials where the device has already faced 80% of modes of failure. So what you are doing is we recruit patients, and we can talk. We were talking about shockwave cases. 300 cases, 3 negative outcomes. Seriously? Because all the companies try to recruit the people that are good, and the doctors, with all due respect, we recruit the cases that actually work for that device. And then we call back. The early TAVIs had 50% paravalvular leakage with the Medtronic core valve. Now look at the Sapiens, okay, 10 years later, okay? But we could have modeled them and reduced the risk of paravalvular leakage on the computer so that those iterations will be reduced. I'm not saying we are replacing, it is much cheaper to do computation than doing animals, that's obvious.
Yeah, exactly, that's what I said. It's going to replace animal trials and phase 1.
It is replacing 90% of the procedure. Then at least the clinical trial will be the time that you will have much less adverse outcomes.
Yeah.
If I may.
Many of the trials are also about the communication between the device and the body.
Yep.
So with platelet adhesion, protein adhesion, etc. So is that something that you expect that you can replace that?
To some extent, yes. Not entirely. The new physics-informed neural networks allows you to look at the response and try to back calculate it with inverse modeling. So I agree our bodies are dynamic. Biology is dynamic. We cannot do much about it. But we are all human, like one species. So probably our behavior and response is constrained. So whatever is constrained might be easier to map than if something is infinitely different. I agree with you, we still need to do a lot in terms of modeling the biomaterials, drug delivery, and so on, and whatever is concerned with biology. This is more towards structural, mechanical, anatomical deformation and changes.
So my question is regarding those ideas that you guys trademarked. Where do you see the limit goes between building a wrapper and building everything in-house? And when you do actually build in-house, how do you actually get the resources? Because like nobody's getting any of those chips that are coming out now. Like
the difference between building what?
A wrapper where you just like get info, build your own version of an LLM and get that to aggregate your info, or build your own model based on your own data to give you your own outputs.
So LLMs, that ChatGPT is LLM. So and our cardiac GPT is also LLM. There is a big problem, and I think that's one Manisha will appreciate. The problem is when you are using these open source, whatever you call it, OpenAI, ChatGPT, or whatever we have in China, then you are kind of exposing your data. That's the limitation you have. What you are gaining about that is the computational power. It's much faster, 16 billion parameters, and you can do it in matter of seconds. Sometimes you need to sacrifice that for the patient's data protection, and then you build some LLMs with 4 billion parameters that can be run locally, and that runs for 2 minutes. And that's still within the range that the hospital would be happy with. So that's the kind of a compromise you make for the data safety and data protection.
I'd like to conclude with one missing piece here. The data synthesis and generation model are still dependent on the clinical data set that we have. We cannot generate data without clinical data sets. So we still need good clinical data sets in order to generate good synthetic data. So this is an important message that I would like to leave you with. And we use them as a complementary and augmentation models to our clinical trials. We are still at the very first step of these models, and hopefully we can see what we can do with these models in the future. Thank you everyone for joining this session.
Okay, everyone. So we made it to the end of the conference. Congratulations. Before we start with the closing remarks, I'd like to extend my deepest gratitude to Mr. Faisal Al-Goufi and Mr. Fahd Diaby for their wonderful work in this conference. Without them, this conference wouldn't have happened, and these collaborations wouldn't have happened, and we wouldn't have been able to hear these amazing, intelligent, brilliant discussions that we've heard today, to be honest. So thank you to our speakers, moderators, our panelists, and everyone who joined us, and then for everyone in the background who literally, this conference wouldn't have happened without you. So thank you. So Dr. Faisal Al-Goufi and Dr. Fahd Diaby, would you please join me on the stage for the closing remarks?
Good evening. Heartful thank you to all people who are, I attribute all the success of this program. For me, these 3 days was amazing. It made me truly learn, meet people who I honestly look forward to work with, and I have seen so many leadership styles at so many levels, at younger level and a higher level. I would like to start by thanking the leadership in King Fahd University Petroleum and Mineral and Johns Hopkins Aramco, Mr. Al-Saggaf and the CEO. There are, over the last 3 to 4 months, we have been working together with lots of groups. But to be fair, there is always a relationship, a clear relationship that developed over the last 2 months. I would like to start by thanking Dr. Faleh. Faisal, you truly showed a great collaboration and leadership in bringing us to this conference. The list of people will go on, but I have to say that Gitu, watching you, as I said, between here and there, gave me energy, to be fair, because we want to deliver, but more importantly, we want people to enjoy the content, the atmosphere. So thank you. I would like to thank Dr. Fahd, who's not here today, but you could see his dedication in terms of the team that he actually left behind to run the venue and the conference. I would like now to start formally, and I will pass it on to Dr. Faleh to go on with the list of appreciation.
Thank you very much, Dr. Faisal. This is the first product of KFUPM collaborations and strategic partnership with Johns Hopkins. Honestly, I think all of you witnesses the work that has been done so far, but I have to tell you something, all what you see now, it's done within 2 months, which is very unusual, and the credit for this goes to the steering committee and scientific committee, but the people behind this, really the engine is, Gitu and her team from Johns Hopkins Hospital, and Dr. Fahd Zahrani and from KICS and team. I don't know what is the team now, they are here. And yes, there. And also, from my side also, Amna and Samhar. Samhar is PhD students, but he acts more than actually a full faculty. And honestly, this wouldn't happen without leadership support and visions. I think, this is a great start. It's not, the end, but it's the beginning. And we look forward for collaborations. The good thing about this conference is that, it's networking. We're already actually discussing 4 projects with different institutions, which is very much aligned with the KFUPM visions and focus. The Vice President, Dr. Ali, he would love to be with us today, but there is some also ongoing agenda, and his schedule is always full. He convey his wishes and great thanks to all of you participants, speakers, moderators, panelists, guests, and we look forward for more collaborations, and we want to see this fusions, as the President mentioned, the colleague series coming in different areas. Dr. Faisal, without saying, you took the initiative and you asked me to do it, and we're very happy that we did this journey together. And I think now, as you mentioned, we have the experience with the team that we trust, and we really can do even bigger than this. Thank you very much for all your participation and also contributions.
I'm just gonna, before I go to pass it to Dr. Juri Mubarak, also from the Johns Hopkins team, thank you to Dalia, Rand, and Rana, also working in collaboration with our KFUPM team. I get the chance to honestly to meet people who are really dedicated. But I would like to spend a minute to thanks to Dr. Juri Mubarak, who truly showed a clear and an exemplary dedication throughout the whole 3 days program.
Thank you.
Just excuse me, Dr. Faisal, one of the JHAH team, her name is Sarah, I don't know her full name. She started also with us, and maybe she's not here today, but also she has done a great job. I don't know if she's available or not. Or Maha, maybe Maha? I'm sorry, Maha, yes, Maha. She has done a great job, and she's not there anymore, but this is also goes to her credit. And I should not forget also the innovations support manager directors, Mohammed Swai, that you maybe witnesses that he's always around us working, and all your booking, everything, he's working 24 hours for that. So I really appreciate the team and from both organizations. I feel actually we are one organization. This is fact. I'm clinicians, but still I'm becoming also more engineer now, and especially after this discussion. So again, thank you very much.
Okay, so we're gonna start. We're gonna start with acknowledging the scientific committee. We would like to acknowledge Dr. Abdulrazak Amir, who's not here today, but I'm gonna keep mentioning the names in recognition of them. Dr. Abdul Muttalib Masloom, Ms. Gitu Mirchandani, Dr. Abu Bakr Ahmed, Dr. Asim Shah, Dr. Emmanuel Akou, Dr. Hayat Mushkab, Dr. Ilan Wittstein, Mr. Mohammed Madghi, Dr. Fahd Al-Sindi, Ms. Nada Sabbagh, Dr. Tariq Dihsan, Mr. Mustafa Fleet, Ms. Sumaya Hajri, Ms. Sumaya Hajri, Ms. Hussal Abbad, Dr. Muzammil Bahzad, Dr. Ahmed Dallab. Dr. Momin Abazat Yazid. Dr. Ikram Mikisi. Miss Aram Zahrani. Miss Amna Al-Sammah. Dr. Fahd Al-Zahrani. On behalf of Dr. Fahd Al-Zahrani, Mr. Faiz Al-Shahri is going to accept his certificate. Miss Iman Al-Shahrani. Miss Bayan Al-Shahri. فايز الشهري. مسرن الغامدي. الشروق المطرفي. مس أزهار العالي. Miss Dadia Basrawi. Miss Rana Al-Akkaz. Miss Randa Al-Misfar. Okay, and a special recognition to Miss Claudia Pestana, if you can come right back.
Will be the master of the ceremony. It is my great honor to honestly recognize Dr. Ajuri Mubarak. يعطيكم العافية وشكرا جزيلا. Let's conclude HeartFusion 2025. We sure hope that we plant the seed for HeartFusion 2026.